passed on to the electrocardiography to evaluate the nerve fibers. So when we talk about candidacy criteria, the indications have been ever evolving. Earlier, implantation was only considered for patients who were adults and bilateral profound deafness, but now the indications have expanded a lot. So I'll be talking about these in detail. In 2003, ASHA gave the guidelines that whenever you're considering a patient for surgery, it's not just the radiology and audiology that you have to see, but you have to answer all these three questions, and only if the answer is yes to all of these three should one consider the patient for further workup and implantation. So is the implantation medically possible? Is there any contraindication against surgery? Is the first question. Secondly, are we expecting that the individual will receive more communication benefit from the implant rather than a hearing aid or no process at all? And thirdly, does the patient have the necessary supports in the family, psychological, educational and rehabilitative structure for keeping the implant working and integrating it into the patient's life? Because after surgery comes the hardest part. And if not, can they be developed? So if all of these three answers are yes, then one should consider going ahead. So this is the general surgery because the candidacy criteria have been changing frequently and there are lots and lots of guidelines, so it is always confusing. So here are the salient features of changes in the FDA criteria for both adults and pediatric patients. So in 1985, when the implantation was not yet approved for children, the criteria was only approved for post-lingually deafened adults who were 18 years or older in age with profound bilateral audio. So the thresholds were 90 decibels and the patient was having no speech recognition skills. In 1990 was the first time that the minimum age of implantation was made as 2 years. So it was approved for pediatric patients again with bilateral profound hearing loss and nil speech perception. In 1998, there was another breakthrough that the age of implantation in children was reduced to 18 months and speech perception even less than 20% was considered as a criteria. And for adults, pre-lingually deafened adults were also included in the candidacy. The thresholds were lowered to 70 decibels and speech perception less than 40%. In 2000, further, the age was reduced to 12 months. And in children also, severe to profound hearing loss in children at least 2 years of age was also included in the criteria and speech perception was adjusted. In adults, the speech perception was adjusted to less than 50% correct in the ear to be implanted. In 2014 came a major change in adult candidacy criteria in that patients having low usable residual hearing volume in the low frequencies, hearing loss in the low frequencies, so less than 60 decibels with a sloping sort of SNHL, they were considered for hybrid or electroacoustic stimulation devices. And those who were having moderate to profound hearing loss, traditional devices were considered. And speech perception criteria was made to be 10 to 60% in the ear to be implanted and less than 80% in the contralateral one. A major change in 2019 was addition of single-sided deafness in both children and adults with duration of deafness less than 10 years. So for children, the minimum age was 5 years for asymmetric hearing loss or single-sided deafness. For adults, there was no such age limit. And in 2020, that is just 2-3 years back, the minimum age has further been reduced to 9 months and there is no other major change in the candidacy criteria. So this was just briefly about the changes in the FDA guidelines. So as I was talking about the evolving criteria, so we've seen that even infants less than 9 months of age can be implanted, patients with residual hearing can be considered, and it is not only that the patient is using the hearing aid and the audiological benefit is not there. If the child is having lack of auditory progress, as should be there with the hearing aid, even if there is some speech perception, some speech acquisition also, but the child, especially in children, if they are not able to make adequate auditory progress, even that can be considered to go ahead with surgery. Then inner ear malformations and cochlear nerve aplasia, which were earlier initially used to be absolute contraindications for surgery, are no longer contraindications, and even cochlear nerve hypoplasia or aplasia is being considered for implantation. And atypical etiologies of SNHL in adults like advanced otosclerosis, post-traumatic hearing loss, Meniere's disease, all have come under the indications. Now, some important considerations apart from all of these criteria are, we need to see the patient as a whole, especially in adults. Do they have any residual low frequency hearing? Does the patient have a passion for music and wants to appreciate it? Is the patient working in a noisy or reverberant environment? What the lifestyles demand? And whether or not they are motivated to experiment with hearing aids. All of these things need to be discussed with the patient before we simply plan for surgery. Now, one important thing to be considered before going ahead is the presence of any cochlear-vestibular malformation. So in around 1/3 of the patients with congenital SNHL, there is some associated cochlear-vestibular malformation, which may range from Michael deformity, that is complete absence of any cochlear vestibular structure, to various grades of cochlear hypoplasia and IP123 deformities, which I will be discussing a bit later in radiology. So the minimum requirement to go ahead with surgery is there should be the presence of an implantable cavity in proximity to stimulable neural elements whose projections connect to the auditory cortex. Another important aspect to be considered, especially in children, is the presence of additional handicaps. So in these children, around 30% of the children will develop some additional handicap later on in life. So that is one challenge that we face in reducing the age of implantation. Suppose the child is being planned for surgery at 9 months of age. There are certain diseases or additional handicaps like autism which might not be picked up before 12 months of age. Then Asperger's might not be picked up before 3 years of age, and ADHD, cerebral palsy, all these effects may come on later. So whether we should go ahead with surgery in such a patient who is a known case of cerebral palsy or not, again, it's a question for discussion. But in favor of going for implantation is the fact that at least one faculty of the patient will be developed. So the child will have some benefit. Also, one moral question is, if a child has a congenital anomaly which is not compatible with life and the expected lifespan is very short, just a few years, should we deny the child the right to have that quality of life for those few years? So most of the surgeons would say no, we should not deny the child that right, and whatever age, whatever lifespan is left, that should be with the maximum possible quality of life. So for a child whose language is not intelligible for the parents, who cannot be rehabilitated in the mainstream also, if we just are able to establish contact between the child and the family members and improve the quality of life, so even if only the parents are able to understand him or her, it is still an advantage for the family. Now, why has always this age been a major topic of discussion is because there are certain inherent risks of early implantation. Firstly, challenges in diagnosis. Obviously, the reliability is less in younger infants. Then difficulty in rehabilitation of a very small baby. Then again, as I discussed, overlooking subsequent and additional disabilities which might develop and which might hamper the potential that the child should achieve after implantation. And also, rarely there's a possibility of hearing improvement with age, so that also needs to be considered. And all of this needs to be discussed with the parents beforehand. Then since the children have low body weight, small size, large body surface area, the skin is very thin, well perfused, so there's more risk of hypothermia during surgery. Low blood volume puts them at a risk. Even a few milliliters of blood loss may compromise the child. And any undiagnosed or unpredicted cardiac disease which might not manifest in a small baby may further pose anesthesia challenges. And for the surgeon, definitely blood loss from the bone marrow emissary vein can create havoc. And we need to refine our technique since the facial nerve is more superficial and lateral. And the skull is very thin, so probably making a good subperiosteal pocket, circular exposure of the dura, and fixation of the implant with suture in very young babies might be considered. These are just modifications which have been which are beneficial for younger babies. Now, another important aspect is single-sided deafness or asymmetric hearing loss, which is nothing but the patient having near normal or normal hearing in one ear and severe to profound hearing loss in the other. So the minimum difference in the thresholds is at least 30 decibels in the both the ears. So adults are able to adapt better, especially in their work environments. They can use head turning and alter their seating arrangements so that they don't have much difficulty in the work environment. But for young children in the classroom setting where there's a lot of background noise, it is difficult for them to be able to localize the sound and catch what the teacher is talking about amidst all the background noise, the background chatter. So benefits of CI in asymmetric hearing loss are definitely sound localization, better speech understanding whenever there is a lot of background noise, and suppression of tinnitus because these patients tend to have unilateral tinnitus in the affected ear. Again, a point of discussion is whether to go for one implant or two. As I discussed earlier, it was mainly one implantation only, and now everyone is going towards bilateral implantation, that too in the same setting. So the benefits are quite obvious. Physically, there are two autonomous implants on two opposite sides of the head, so there is better improved signal to noise ratio. There is better sound localization. And also in case of device failure, suppose a young child, implant is damaged and we are planning for surgery on the opposite side. Still there is a gap of few months in between those two implantations. So that will again push the patient's auditory progress and speech language acquisition progress further backward. So that is something that can be avoided. If the child already has 2 implants, one gets damaged, still we have another functional implant. And one ear or microphone array is always closer to the sound source, so the child is always able to hear better. Then central processing benefits like summation effects. If a sound is given simultaneously to both the ears, there is an additional gain of 3 decibels, which is significant, especially in a background noise. And localization is always better with 2 implants. And also medical and surgical considerations. The child has to be admitted once only, post-operative antibiotics and hospital stay, everything can be shortened. And also GA is also administered once. So these are the other benefits. Now, once we have planned for surgery, what is the workup that needs to be done? A detailed history from the family to rule out any other vestibular symptoms, dizziness, any syndromic association, a detailed perinatal past history, developmental delay, and what is the social background, family's educational status, immunization and amplification history. They need to be taken in detail. And from the first step itself, hearing aid trial and AVT, the need of these has to be emphasized. Then local and detailed systemic examination to rule out any local ear infections which might contraindicate or delay the surgery. And systemic examination for any associated syndromic association, which is seen in 30% of these children. Then we go for a complete audiology and radiological battery of tests. The parents have to be counseled and consent needs to be taken at each and every step, and hearing aid trial and AVT needs to be started once we have the audiology. So the child needs to be evaluated by a pediatrician, ophthalmologist, cardiologist. A psychological profiling needs to be done to look for the developmental social quotients, and other workup including torch profiles, etc. needs to be done, and then we get the PSC fitness. So when it comes to audiological evaluation, I'm maybe talking more about children because that's the major population that we are catering to, but all this includes adults also. So behavioral audiometry for young children, PTA if the child is 5 years or above, and for adults, impedance audiometry, ABR, ASSR, OE tympanometry, this is a standard battery that has to be done for all the patients. Then unaided speech audiometry whenever possible, especially in adults. And bilateral hearing aid trial with aided audiometry. Not just, the benefit is not just that we can have an idea of what is the patient's current status and how the patient will fare post-operatively, but even during counseling, it gives us a baseline with which we can compare the patient's pre-implantation performance with those of other cochlear implant users at that stage. So that helps in counseling and explaining to the patient as well as the attendants what is the expected benefit and what is the expected outcome after the implant. Then a minimum speech test battery, which is a set of high fidelity recordings which are used pre and post operatively to assess the language also of the patient, and some particular tests like hearing and noise test, consonant nucleus consonant test, these are used especially for adults. And earlier there was no special test for children, but in 2017 a pediatric minimum speech test battery was developed. So these also help in pre-operative workup, in counseling as well, and then maintaining the progress of the child post-operatively. Now coming to one of the most important parts is the scans. Why do we need a scan? Why do we need a CT as well as an MRI in all patients? Because these are the 3 questions that need to be answered. Is there any cochleovestibular anomaly that precludes implantation? Is there evidence of luminal obstruction? So we can plan ahead if there's labyrinthitis ossificans, whether we are going to be able to implant the patient or not. And are there any additional findings that may complicate the surgery or subsequent patient management? So as we all know, both CT and MRI have their own benefit. A high resolution 0.6 mm CT scan is usually done for all patients, and MRI, especially FaceTime CIS sequences, which is a modification of T2 weighted images, especially for the cochlear nerve, because oblique sagittal view is the best view to look for the cochlear nerve. So if we compare the 2 modalities, both have their own benefits. Bony parts like fallopian canal, the facial nerve, then cochlear aqueduct, these are better seen in CT along with the middle ear mastoid. And if you want to look for the morphology of the cochlea, semicircular canal, and the cochlear nerve, enlarged vestibular aqueduct, all of these are better seen on MRI. So I've just put a few images here of different anomalies or different possible problems that we need to look for in the scans. So in the first image, we can see labyrinthitis ossificans. The basal turn is ossified. Here even the middle and apical may probably ossified, so we need to plan before surgery. Mycaloplasia was complete absence of any inner ear structure, so there's no cochlea, no vestibule is visible in both these images. That is a mycaloplasia, which is still a contraindication for surgery. Enlarged vestibular aqueduct, which is nothing but when we compare with the posterior semicircular canal, the diameter is increased, or if we want to see the length, then 1.5 mm in the midpoint or more than 2 millimeters at operculum is defined as an enlarged vestibular aqueduct. Then we have cochlear aplasia, where the vestibule is formed but the cochlea is absent. Different levels of cochlear hypoplasia, grade 1 to 4, and common cavity, in which you can just see a cystic common cavity. There is no differentiation between the cochlea and the vestibule. Then the incomplete partition defects. So the first image is of IP1, in which there is absence of modulus and interscalous septum. IP2 or Mondini's, which is a triad of three things, that is, the basal 1.5 turns of the cochlea are present, but the middle and apical turn are fused, giving the appearance of a cystic apex. And along with it, there's an enlarged vestibular aqueduct and a dilated vestibule. And then the IP3, in which both the basal turn and fundus have a bulbous look, and there's no lamina cribrosa. So all of these can be seen both on CT as well as MRI. In MRI, the specific sequences are CIS, that is constructive interference in steady state acquisition, and as I said, parasagittal reconstruction to look for the cochlear nerve status. Normally it is bigger than the facial nerve, diameter is almost 0.4 millimeters. If there is a lower diameter, that indicates hypoplasia. And two other pointers are, if the diameter of the IAC is less than 2 millimeters, that increases the risk of the congenital absence or hypoplasia of the nerve. Also, a modulus diameter of less than 3 mm in CT increases the risk of absent cochlear nerve. So these are the parameters which we need to see. And now lately there are further studies in which the angular rotation or the basal rotation of the cochlea, whether it is anterior or posteriorly rotated, that is measured using the alpha angles and the beta angles. All these help to address the possible trajectory during implant insertion, and they can help in predicting whether the surgeon is going to face any difficulty in implant insertion electrode or not. Now, which site to operate? If there is asymmetric hearing loss and one ear is less likely to benefit our application, that should be implanted. If neither ear can use a hearing aid, then we go for the better ear. If both ears can use a hearing aid equally well, then there are other criteria like handedness, patient preference, or other non-audiological reasons. And in children, if everything is equal, still there is a propensity to go towards the right side. So a brief algorithm, just to summarize, since that is important, how to select the ear is, if imaging is abnormal, we have to implant the better ear. If imaging is normal and on medical evaluation there is some infection, trauma, prior surgery in the ear, again implant the better ear. If both are normal and on audiology there is asymmetry between the two ears with more than 10 years of disuse, implant the better ear. And if there is bilateral residual hearing, we go for implantation of the worse ear. Surgical contraindications, as discussed, mycaloplasia, narrow IAC, hypoplastic absent cochlear nerve, even though this is not an absolute contraindication now. Presence of infection delays the surgery, that has to be addressed first. And detailed counseling is the most important aspect of preparing and planning a patient. We need to know about the parental attitude, how much support they'll be giving the child or the patient, because there's a prolonged input requirement. For years to come, rehabilitation needs to be done, and benefits and risks of surgery and expected outcomes need to be discussed. Then there is a wide range of devices. How to select the device is an entire topic in itself. But just to enumerate a few, MRI compatibility is one feature. A child who is expected to require MRIs repeatedly, you might want to go for an implant compatible with 3 Tesla. Then labyrinthitis ossificans, we have compressed electrodes around 15 millimeters of length by Medal. And for IP deformities where you're expecting a perilymph gusher, there is Form 19 and other such modalities with a plug, so that will help during surgery. So the prerequisites in short are a properly evaluated candidate, a good team with adequate expertise, all adequate equipment, realistic expectations from the patient and the family, and a strong commitment and support for rehabilitation. So thank you so much. That completes my talk. Any questions are invited. So as far as the state government schemes are concerned, I think that is not a contraindication. All we need for the child to be a candidate to avail these benefits, especially like in Rajasthan, we have the Chiranjeevi Yojana. All we need is the audiological criteria and an MRI basis. That's what we do in our setup. We first go for the audiology and 3 months of AVT with no benefit, with a good hearing aid and regular AVT and radiologically no contraindication. So those children are all covered, whether syndromic or non-syndromic.
When you look at the various state programs, the problem is happening because in the main EDIT program, they have categorically written you cannot implant
Yes.
child.
Yes.
And there are few states which also strictly adhere to the fact remains that they are doing it in India and they, surgeons or policy makers, it's all about taxpayers' money. So they feel that those who are having poor prognosis, yeah, so basically it's all about the taxpayers' money, which that's what I think the policymakers. Few states, like I'm from Patna, Bihar, they don't ask you, they just ask the surgeon's paper to issue the funds. Same with Rajasthan, it seems. But
No,
there are other states.
In Rajasthan, it is not there. In Rajasthan, you should have a normal cochlear.
Yes, that I think there
No
is a criteria. Anomalies they are not giving. Because my state, we are starting and they are yet to review it. We are getting it once the surgeon says that you are implanting the child. That's why adult people are also getting the money. So it all depends, and EDIP is very categorical that they are not going to fund anomaly child.
Anomalies.
So this is, and also, if I'm not wrong, it's not only in India. Many places they have put this, because it's all about prognosis, and it's not only. So if you look at the cost-effect ratio for anomaly child, even to rehabilitate, the parents have to spend more. Like they have to do it more extensively for a longer duration of time. So all this taken in consideration, I think that's what they are doing. Whether it is right or wrong is something, a very philosophical question. I mean, I think they all should get that benefit. Even a child, as you told, I have 2 kids who are mentally retarded. I did it way back, and they're still using it. And there are other kids, as you said, developed autism later, and now they're non-users. So it is a fluid water, I think. It's something which we need to think about.
All of this needs to be discussed with the family beforehand, before that all this is possible later on.
Delhi का मुझे पता नहीं कि whether they are actually sponsoring implants. I don't know whether Delhi government, AIMS Delhi में almost all the kids who are coming are getting funds from their state, like ADIP they are doing, and they are doing state funded. Like for instance, Bihar will pay people who are getting treated at AIMS Delhi also, AIMS Patna also.
Okay.
So yeah, they give money to both the places. Jharkhand also gives money to AIMS Delhi. So AIMS Delhi was the nodal point for most of the states to give money, and they cannot deny it because that's a central government institute. ADIP though totally, ADIP has a completely different system of giving funds. So it doesn't give fund, it gives you implants.
So Dr. Kanti, I think we can cut short this discussion because we can discuss it over tea or breakfast or maybe in the lunch because the time is inbound. So I would invite Dr. Rajiv Kapila for his presentation on post-it hypnotic techniques. So we have designed this instruction course like in the first go, we had these basics about the candidacy, radiology, preoperative evaluations and all. Then we'll go by the surgical techniques like post-it hypnotomy. Then we'll come with the Varia technique, then with the modifications of the Varia technique. And then the forum will be open to like discuss about the rest of the aspects of cochlear implants.
इसके ऊपर आपने So, okay, a very good morning to all of you. So, I will be talking about the most commonly used technique for cochlear implant all over the world, and that is transmastoid posterior tympanotomy technique. So, I'll go through the basic steps and then a little bit of finer details about it. So posterior tympanotomy, it uses facial recess that was first described by Jensen in 1968 as a part of combined approach tympanoplasty. So the facial recess is a triangular area which is bounded anterolaterally by the chorda tympani, posteromedially by the facial nerve, and superiorly by the incus buttress. And this triangular area gives us access to the middle ear and the round window niche, which is our site for cochlear implantation. So I'll straight away begin with the steps. It is done in general anesthesia. After cleaning draping, the post-oral area is infiltrated with adrenaline in saline or with xylocaine. The position of the well is marked before taking the skin incision using company-provided measuring templates. Then a small post-oral incision is given in the post-oral sulcus, and for the ease of the surgery, this incision curves slightly posterior-superiorly to enhance the exposure like this, and then the flaps are raised. The flaps are the skin flaps, leaving the periosteum, anterior flap and the posterior flap. Then we raise two periosteum flap. One is very small anteriorly based periosteum flap and a very broad superiorly based musculoperiosteal flap, and this makes the bed for the drilling and mastoid drilling and the implant bed. And these flaps are then secured with the ties. We don't use retractors these days. And I'll directly begin with the surgical video to show the steps. So the incision site has already been marked with the receiver stimulator and the zygomatic arch. The receiver stimulator is placed at a 45-degree angle, and this area is infiltrated around 20 minutes before. This gives around a bloodless incision site, you can see here, and the incision is given at the right angles with a 15-number knife. So once we deepen the incision, we go till the fascia, and we raise a thick skin flap with underlying musculotemporalis muscle and the fascia underlying. And it's very important to have a good adequate thickness skin flap, and again the posterior part of the skin is being elevated so that it eases a broad superiorly based periosteum flap. Now the incision is being given for the periosteum flap. We leave a small periosteum anteriorly as it gives a tension-free suture after the flaps have been raised and sutured. So it is very important when the flaps are reposited back and sutured, they should give a tension-free suture line, and the incisions are made in such a way that the skin incision and the periosteum incision never overlap each other. Alright, then this musculoperiosteal flap is raised. So sometimes you encountered one mild small emissary vessels in this while doing this. You can easily control bleeding with a diamond burr. So once these flaps are raised, they are secured with the tie with the ties, and we are ready for our bone work. So the posteriorly we are exposing the periosteum, as this part of the periosteum exposure is also important because this will be sutured with the flap. Now the surgery started by doing a cortical mastoidectomy. The steps are same as we all know how to do the cortical mastoidectomy. The landmarks we know: superiorly the dural plate, posteriorly the sigmoid plate, and as we go down, the only difference here is keep on undermining your edges, because these edges will house the extra electrode, and now you can have a glimpse of the sinus plate and the dural plate. As you go down, open the antrum and start identifying here the short process of the incus, because that is a very important landmark. Once you identify that, go inferiorly at the mastoid tip area and try to identify the digastric ridge. Now this is very important because we are doing the posterior tympanotomy, but exposing the tip area will give it a better access to the facial recess. So another is the thinning of the posterior canal wall. It should be made very thin to get a wide access of the posterior tympanotomy and wide access and visualization of the middle ear. Keep thinning when you are going down, keep it thinning. And initially use a cutting burr, big cutting burr, but as you go close to the facial nerve, then you can switch over from the cutting burr to the diamond burr. And so we are using the cutting burr here. So when you see the bony canal of the facial nerve, you can switch over to the diamond burr. So we have switched to the diamond burr. That's the coarse diamond, around 3 mm diamond burr here. Now the opening to the facial recess, you almost commonly find a cell that we call a herald cell that marks the entry to the middle ear, right? So you can see the herald cell here. So you can widen this herald cell and get an entry into the middle ear. In difficult cases, you can put some betadine here and see the betadine coming out of here. That is almost a sure shot. You want to confirm you are entering the middle ear or not. So you see now you can see the chorda tympani here and the facial canal here, and that's our opening of the posterior tympanotomy. So when we open this, see we have opened it. The first structures we saw is not round window. The first structure that we saw is the IS joint, the stapes suprastructure, and the stapedius tendon. All right, so we have done the posterior tympanotomy, but still we cannot see the round window. So to see the round window, we need to extend this posterior tympanotomy inferiorly. So when we are doing this, we keep on decreasing the size of the burr. Here we are using around 2 mm diamond burr here. So you keep on decreasing, keep eggshelling the bone on the facial nerve and anteriorly over the chorda. So it is advisable not to injure the chorda because don't go very enthusiastically anteriorly. So see, when we are going inferiorly and see this is the eggshell bone, sometimes if you place your burr posteriorly, this shaft may touch the facial nerve. So you should either place it superiorly or you should place it inferiorly, depending upon you are a right-handed surgeon or a left-handed surgeon. So, but I am a right-handed surgeon, but I use my left hand also for doing this work. So, but avoid the shaft heat, rotating shaft heat injury to the facial nerve. So, still you can see this part of the bone is still remaining and it needs to be drilled. So here now we are using around 1.5 mm burr, and once this is drilled, see now you are getting a glimpse of the round window. So inferior exposure is very important. So now you can see you can have the exposure of the promontory, the round window. Once you have done, just block this area with a gel foam or a cotton ball, and now we are ready to do the receiver stimulator work. For this we raise a periosteum pocket. Now it is very important to raise a very tight periosteum pocket. You know, it should be just of an adequate size. Don't elevate the periosteum too much higher or too much inferiorly. You see, from here to here, when you put your template, even without making the bed, when you put your template, it should be tightly held by the periosteum. See, when I put the template, it is held by the periosteum, and when I hold it and I move it, the template is not moving, but the head is moving. So that is an additional security measure to do so that your template does not migrate post-operatively. Then we mark the bed and do the bed work. So in today's era, for posterior tympanotomy, we are doing either round window insertion, extended round window insertion, or cochleostomy. So for round window insertion, we drill and smoothen the round window niche margins, both anterior-inferiorly and posterior-superiorly, to expose the round window membrane completely. And once the round window membrane is exposed, it is incised with a curved or right angle pick. After the opening the round window, a small amount of hydrocortisone is injected slowly into the cochlear lumen, which helps to flush out the bone dust, and it also says that it preserves the residual hearing and prevents cochlear ossification later on. And then the cochleostomy is sealed with the connective tissue later on. So going with the surgery, the bed is template is done, and the bed is made in the skull. It is very important to have a right angle margins, no slanting, and adequate bed so that the implant fits properly here. So once that is met, we are ready to do the round window work. So drill the round window niche anteriorly and posteriorly. Now you can see the whole of the round window membrane here. So round window membrane is oval and obliquely placed here. You see, so once the round window membrane is exposed, you can beautifully see the cauda and the facial, right? And you incise it with a right angle pick. So this is what we call a soft insertion, or the soft technique of cochlear insertion, so that we don't drill the cochlea. We do not drill inside the cochlea or cochlear lumen. We just incise the round window membrane and we are ready to put the electrode. So now the hydrocortisone injection we are just putting so that it eases the electrode insertion. The implant is being placed. We always place tie down holes. Just an additional measure, it hardly takes 10 minutes. This implant is gonna stay with the patient for his life. So, and there had been incidences of migration. So we always use tie down holes. Now the electrode is being inserted through the round window directly into the scala tympani. So take time. Our ideal time is 1 to 2 minutes, 1.5 to 2 minutes for electrode insertion. One electrode at a time, slowly you insert the complete electrode. Right, and don't exert pressure. It should be atraumatic, frictionless insertion. Insert slowly till all the active electrodes are inside the cochlear lumen. And then you place the extra electrode in the mastoid cavity. And you seal the cochleostomy with the periosteum tissue that has been harvested previously. So then the soft tissue closure is performed in 3 layers. Superiorly based flap is approximated to small anterior flap, as I have told you, and subcuticular skin closure is given with 3-0 vicryl suture. So just to the closer, the ground electrode being secured, and see the anteriorly based flap and the superiorly based periosteum flap, these are sutured. Now this suture and this suture should be tension free over the implant bed, right? And it should completely cover the implant without any tension. So making an implant bed also helps in helping in a tight less and this suturing, and then the skin is sutured. And then intraoperative electrical testing, NRT and impedance is done. Intraoperative, we routinely do a CM especially whenever we are using slim electrodes, because slim electrodes are the electrodes where the tip rollover is very common, just to rule out that. And second post-operative day, we get modified Stenver's view and transorbital view X-rays, and the patient is discharged on 3rd or 4th day, and sutures are removed on 7th day. And if it is subcuticular, then it's just the knots, and switch over generally after 2 to 3 weeks. Now, there are certain problems with the posterior tympanotomy approach, especially in identifying and reading facial recess in patients with small mastoid cavity, low-lying dura, and anteriorly placed sigmoid sinus, and difficulty in assessing round window niche in malrotated cochlea, especially in posteriorly rotated cochlea. It is difficult to drill out in ossified and cochlear malformations in such a posterior tympanotomy that is a narrow corridor. And whenever there is, we are doing a lot of mastoid work, so that is another thing. So this is a case where we had a difficult round window visualization. So you can see that the facial nerve sheath has almost been exposed here. You can see the IS joint, but you cannot see the round window niche there, right? So we are trying to, thin the facial nerve, but we cannot see the round window niche. So round window niche is somewhat posterior to this point, and all this is promontory, but without seeing the round window niche, we cannot even do the cochleostomy. So these are the difficult cases. This is type 3 round window niche here. So what to do in these type of cases? So I would say we should not be adamant that in every case we have to do the round window insertion. So even if we do cochleostomy by posterior tympanotomy, that is okay. So but what to do in these type of cases? These type of cases, what we did is, we took a pediatric endoscope. We used our pediatric endoscope, and we saw, you see, this is the 0-degree view with the pediatric endoscope. You can see the IS joint, but you cannot see the round window niche with a straight head-on view with the 0-degree endoscope. And when you go inside, now you are inside the middle ear cavity. It had a very high jugular bulb. So you can see the jugular bulb almost touching the anterior lip of the round window. Now you can see the round window niche. You can see the handle of the malleus, you can see the cauda, you can see the residual TM, and you can see the round window. Now this gives you a fair idea, this 0-degree endoscope, that if this is your round window, then your cochleostomy site is somewhere here, just anterior-inferior to the round window membrane. And then we did, cochleostomy through, in this case, in the same case, we used 0.6 millimeter cylindrical burr to do the cochleostomy. And when we are doing the cochleostomy, don't exert pressure on the burr. Drill it with just the motion of the burr. And when there is blue lining, you stop drilling. You can use a pick and avoid suctioning once the cochleostomy is being done. So always suction around the cochleostomy and avoid suctioning over the cochleostomy. So in the era of hearing preservation, so now there are some hearing preserving electrodes like slim modular electrodes, mid-scalar electrodes that are good for hearing preservation. So I have put this slide intentionally. So this is the electrode latest electrode from Cochlear, that is slim modular electrode 632. Now point to be noted here is that it has a sheath of around 0.7 millimeter and a sheath stopper of 1.5 millimeter. All right. So this, if we want to use this implant with this electrode, we cannot do it with Varia technique, because the tunnel that we made for Varia technique, I think Dr. Pawan and Dr. Kranti will be discussing that for the Varia. Tunnel that we made is 1.4 millimeter and maximum 1.6 millimeter. And you have to pass this whole sheath through the tunnel, which is almost near to impossible. So for doing this type of electrode, the only method is posterior tympanotomy. So therefore, I must say that every cochlear implant surgeon should be well versed with both the techniques, posterior tympanotomy technique and Varia technique. So each technique has its definite indications and contraindications. Where there are anatomical variation, you use Varia, and such type of electrodes, definitely posterior tympanotomy. Now, this is a cochleostomy size measuring tool that we are using. So this measures your cochleostomy size. So here our size is around 0.8 millimeter, and this stopper is 1.2 millimeter. So this is so that your sheath does not go inside the cochlea through the cochleostomy. Now just to show you, this electrode, it has a flange here and a sheath with two white markers. You can see the two white markers here. This flange should be directed upwards, and the sheath is put inside the cochlea through the cochleostomy, and once it is put, it bypasses the hook area. And with the AOS forceps, you just advance this electrode, the active electrode, slowly into the cochlea, holding the flange. And it goes around the modulus inside, and you keep on inserting till this white marker comes at level with the other white marker. And then, holding the electrode, you just withdraw the sheath. Now both the white markers are at the same level, you can see now. And just hold it and you withdraw the sheath. That's it. Alright, rest of the steps are same. So, thank you very much for your patient listening.
क्या हुआ? तुम्हारा कहीं से अटक रहा है?
वापिस लगाओ ना कहीं नहीं चालू है ना
चालू है.
अभी अभी लगाओ दोबारा
इसको थोड़ा सा इधर ले लो ना, पकड़ लो. क्या किया है?
नहीं नहीं मैंने कुछ नहीं
वो आपने उसको प्रेजेंटेशन को कर दिया है. Don't do it. Brief discussion of the basics of cochlear implantation, and with the preoperative elevation and post-hypnotomy approach, we would now discuss about the Varia technique. I have nothing to disclose. There are no conflicts of interest, no financial disclosures are there. Cochlear implantation, we have gone through all this. You know, there was an audiologist who went through the cochlear implantation himself, and he shares an experience. You read this paper, this is a wonderful paper he has written. He went through the cochlear implantation himself, and he experienced all the things which patient must be experiencing. Why this is? An otologist experience as a cochlear implant patient the power of neuroplasticity. Is it coming? हटा दो प्रेजेंटेड व्यू. वापस करके देख लो. Through this paper, wonderfully written paper about the implantation of himself. So various techniques are there, right from posterior hypnotomy. We have heard by Dr. Rajiv Kapila. There is a middle fossa technique, Varia technique. And we have done some modifications. Me and Dr. Rajiv, Dr. Amit Goyal at AIMS Jodhpur, Dr. Amit Kesri at SDPJ at Lucknow, and Dr. Kranti. So we are there with some modifications there in the Varia technique, and with a few good outputs. We have yet to publish large data series there. So a classical approach was that was the posterior hypnotomy. We have already discussed. The completion rate was 0.7 to 1%. That is not palatable, I think. And chorda injury was the second thing which was there. Identifying the facial recess, as Dr. Rajiv have discussed, is difficult in patients with a small mastoid cavity, low urine entry sinus, and sometimes in type 3 or type 4 round window membrane, and even if so-called cochlear rotation. In my basics, it is a myth. It is the external acoustic canal angulation which makes the cochlea look like anteriorly or posteriorly rotated. So it is disturbance of the normal anatomy and the ventilation during the mastoidectomy approach. Lengthy surgery and the learning curve is difficult as compared to the Varia technique, which is a more versatile technique. So Varia is a non-mastoidectomy technique defined by Trifon Keratides there at Greece in Varia city. The city has given its name. Done just like a stapes surgery to the endoral root. All types of cochlea can be handled well, and there are three separate holes, like is hole in hole in hole, because you are using a posterior canal, you are using a various tunnel there. So incision of varia, we used to incorporate, we used to make an endoral incision type 3 through the incisura terminalis, and it used to be extended posterior superiorly there, and then you use the templates to mark your well and the processor, and then you make an incision, a circular incision on the posterior canal wall, and it has to be connected with the endoral incision, and you raise the flap like this, and the posterior inferiorly based flap taking the whole pinna down, and then you make an incision there in the periosteum, making two flaps. One is anteriorly placed, one is posterior inferiorly placed flap. These figures I have taken from Dr. Amit Kesri because I have never done the classical varia as such. So after doing this, you raise the flaps, you make an internal incision, just like the stapes surgery, and you do a exploratory tympanotomy sort of thing. You see the chorda, you see the IS joint and all there, you see the round window, and this is all you. So there is some logic people give that you are exposing the middle ear in varia as compared to the posterior tympanotomy. I don't think, is there any difference exposing the middle ear from posterior tympanotomy approach or from like stapes? It makes a difference. It is all same. So the closure is after implanting, we make a varia tunnel in the posterior canal, and then it is closed in two layers. And Dr. Amit has published his study of 50 cases of varia technique there at SGPGI in IJLO. So if you compare both the techniques, like the posterior tympanotomy and varia technique, and in endoral approach by varia, it is readily offered by the nature, And the first cochlear implantation by the robot, it uses a varia tunnel. It doesn't use the posterior tympanotomy approach. So it has got a wide accessibility, safe for inspecting the anatomy of the middle ear. No healthy bone is removed, no ventilation is disturbed, and it is more of an embryological approach. If you go by the embryology of the ear development, there are less chances of migration of the electrode because extra electrodes are housed in the varia tunnel. They are not like flying in the mastoid cavity as such. And in the posterior tympanotomy is a wide opening in which the electrode can migrate. But in varia, there are no chances of migration or mobility of the electrodes. No chances of facial injury so far, and less blood loss as compared to posterior tympanotomy, which is laborious, which is dangerous as compared to the complications related to facial nerve. And keyhole visibility is there. We can see that we are always mugging up with a microscope to see the round window, to make a cochleostomy down there. Healthy bone is removed. Dramatic change in the anatomy of the ear cell system is there. And it is not an embryological approach. More chances of migration of electrodes are there and more complications. If you see in the varia approach, no scar formation in the mastoid is there as compared to the posterior tympanotomy, and minimal drilling is there, no impact on growth of the children, and all anatomical variations can be dealt very well with the varia technique as compared to the posterior tympanotomy technique. And the cases with the hypoplastic mastoid in which the anteriorly placed sinus is there, low dura is there, you can't do a posterior tympanotomy. Some people being adamant to the posterior anatomy, what they do is they just fracture the posterior canal wall and place it anteriorly. With the whole flap, they place it anteriorly and they make a new posterior anatomy window and put in the electrode there. So if it is a forward-lying sinus and low dura, I think it is impossible to do a normal posterior anatomy, classical Jensen's posterior anatomy. No foreign body material is left in the mastoid as compared to in posterior anatomy, and pathways for the active electrode has to be additionally created. So I was not happy doing that posterior anatomy in my first 35 cases so far in SMS. So you need to modify your technique. It is again done. Why it is doing again and again? There. So I went ahead because why modify a technique to change to get some more to ease of operating, better efficacy, lesser complications, and decreasing the cost of the things. So we modified the way we discussed it together in one of the conferences. Me, Dr. Amit Kesri, Dr. Amit Goyal, and Dr. Rajiv Kapila, and I started doing this posterior tympanotomy technique by this small post or incision, maybe 2 to 3 centimeter with a lazy S sort of incision, and we have modified our musculoperiosteal flap also. We are raising a superiorly based flap because if you are doing a posterior tympanotomy, you would have seen, I think 50% of the times, this anteriorly based palvas flap falls short when you are suturing it back later in the last. In superiorly based flap, it doesn't fall short ever because you do have a good amount of sternocleidomastoid down there which can be pulled and sutured back. You do have a good anterior flap which can be done there, and posteriorly you do have ample tissue. So this is why I modified it to a superiorly based flap. In Varia technique, you use the same Varia perforator there. It is going with the same Varia technique. To show you how do we do that. So it was modified. After making an incision there, we use the post-oral J-shaped incision, a small one in the skin. The flap is raised. The skin flap should not be very thin so that it get necrosed over time, or it should be not thin that there is no interface, electromagnetic interface with the external unit and the internal unit. Then the straightening of lateral part of the posterior canal wall is done so that your Varia perforator does not stuck anywhere, and your direction should be like this, between 9 to 11 o'clock in right ear, and it should be directed along parallel to the long process of incus. You make the bony wall is created for the vestibular stimulator there, and a channel, narrow channel. With a cantilever, we always leave a cantilever so that electrode migration is not there. After we have done this, and I'll drill the round window niche, the lip of round window. Posterior superior drilling is also done a bit so that the implant carrier channel does not stuck with the bone and get injury. Then after I have placed the electrode there, I'll make an incision there in the round window, and then I'll insert the electrode through the Varia tunnel, and I'll just direct it inside. So if you would have seen in the posterior anatomy, the electrode is hanging like this. Sometimes it strikes there on the posterior canal wall, sometimes it strikes there in the straight ball. But in the Varia technique, it doesn't strike anywhere, it is directly going to the round window. You have to just touch it with a pick so that it goes inside, and then you seal it with the thing. So it is a soft insertion technique we are using. So we did a comparative study, a randomized control trial with a comparative study of posterior anatomy with the modified Varia technique. It was 15 patients each in 2 groups, and it has been published so far. You can see this in IJLO, modified Varia technique for cochlear implantation by post-oral approach. We have published that. Now our another study with 55 cases has been accepted by IJLO. It is about to publish in coming thing. So at SMS we have done around more than 700 implants now. Most of the cases are done with the CM Relief Fund. with self-funded 160 cases are there. Varia is gradually picking up. So far, we have done now 115 or 116 by the Varia technique in SMS. So I think we have discussed so far. So it is a simple technique, a better alternate to the classical approach in order to reduce the surgical time and the complications, and thus rendering the patient less perioperative and the post-operative morbidity and better outcomes. Even robot uses the Varia technique. It was limitations of the study because statistically small sample size was there. Although it looks complicated at first, but in reality, Varia is very easy for beginners and has a lesser learning curve as compared to the posterior tympanotomy method. So minimally invasive surgery, suitable route for insertion, gentle and soft tissue insertion should be done, and control of inflammatory response to electrode insertion by using the steroids and remove and sucking out the bone, all the bone dust when you are drilling it, and not using the suction over the things, and use of atraumatic electrodes. So you will never find the right approach there if you never let go of the wrong one. Thank you. Now I'll invite Dr. Kranti for another modification there in Varia technique she has done so far.
Okay, so we actually are now coming to the end of this instructional course. But what happens when you start operating your cases, you start thinking laterally also. And it is at that stage then you start thinking what could be better and if you can actually do it. The problem with all cochlear implant surgeons is that we are a bit scared of changes. Implant is something which is a very high value product, and it's not only about the money because as I said, it's not always about money, but it is also about the kind of patients you are dealing and the kind of lifelong commitment which you need to have with the patients. So when you are planning to modify something, you really have to think a lot as to whether it will have a long-term effect in surgery. And in cochlear implants, I think surgical aspect is one of the very, very important aspects for a long-term result. So we already have seen the basic concept of Varia. I'm going to be very short. I'm going to just tell you what are the things which we thought, and we thought that it will make it a bit better and have good surgical result in long run. So we already know that Varia is almost a minimally accessed surgery. The best thing about Varia, what I feel, is it exposes the middle ear completely in front of you. So whether it is anterior rotation of cochlea or posterior rotation of cochlea, you have access to do your round window insertions, you have access to do your cochleostomy insertions, and you have access to operate upon the whole of cochlea when if it's malformed or it is ossified. So I think that is one of the basic advantages of Varia, other than what Dr. Pavan already told us about the electrode migration, etc., etc. So we know the critical aspects of Varia. We know what are the critical aspects of Varia, that you raise a tympanomeatal flap. This is what has been the contentious issue between Varia and posterior tympanotomy. In Varia, you open the middle ear through the ear canal. That is important, and that's also important for a surgeon that you be very, very meticulous when you are doing that step. You do not want tears in your flaps. You do not want tears in your tympanic membrane. You do not want a perforation in post-operative period. So that is a very, very important aspect of Varia technique. So your soft tissue work in Varia is meticulous. It has to be meticulous. There is no space for any error. So the critical aspect, as I told you, is the facial nerve, the chorda tympani, visualization of round window, cochleostomy site, and flaps and tissue covers. So out of all these points is what our modification is. So I'll just show you what, this is some still images, and then I'll just show you a short video as to what we are doing a bit different. So if if you can see here, this is our modification, this is our implant marking. So we are still using a scalp incision, which is instead of a post-oral, it is still a superiorly based scalp incision, but it is not going into the canal. So the canal is not being opened. What was happening? all my cases, I'm not telling that that was a complication or something which is happening to our old patients. No, it is not. But when you open the canal, the healing is slow. You need to see the patient, and there are gel forms in the ear. The patient will have pain and other problems. There at times you will have otitis externa. So this is one thing which we thought when we are raising a good flap, you'll see how pliable these flaps are, and then you don't have to open the canal. So you just make an incision and put it backwards, and then you do a U-shaped periosteal cut. So as I told, this is same with posterior tympanotomy or varia, that your incision of both the skin and periosteum should not overlap. That goes without saying. So you have just opened it, you are not opening the canal from here. So there is no endoral incision going inside the canal. You give a good, so it's pliable enough, it's gone down, and then you have raised the flap here. Now you see what's here. You actually do these stay sutures. This is very, very comfortable rather than using retractors. And this flap can be directly elevated completely in unison till the middle ear is exposed. So that is important. There's no cut here. So it's all in one go. And then very easily you can use a suture cover to protect your flap when you are doing the drilling. So you have made it thin, you have made the posterior, you have made the mastoid well to accommodate your electrode. And then you come, you have, I have not shown completely that, okay, I use the varia tunnel. You can see a 24 gauge cannula inside. Now it's important, you can see the chorda. We always delineate the chorda. We do not want to take, so if my suction is coming down here, then somewhere I must have injured the facial. So we should always be above that chordofacial angle. And then you can see how well it, don't be confused, this is the hypotympanic cell, this is the round window. I do round window insertions in most of my cases only unless it is very posteriorly rotated that I do my anterior, anterior inferior cochleostomy. So all my cases are round window. We have published papers in that. And there are certain important aspects which I want to be very, very categorical about. When I plan my incision, my skin incision, as I told you here, I always have a distance of minimum 1.5 centimeter from the implant, and I always make it sure that this inferior aspect of the implant is also above the hairline. It is very important. These small things will tell you when these kids come back to you in post-op period. So this totally covers, the incision will never come over the implant. Now the implant is there inside, the canal is very well seen, but in spite, there is no hole in the canal, but in spite of the fact that I just use a bone pate and I use a layer of fascia, because I do not want any, I think this is a good approach which I have done in now many of my cases since I have been doing varia. So I make a extra buttress, you can say, with a bone pate and a fascia, and very nicely stitch the whole thing back. The canal is all pristinely clear, no problem. So this is the view, and the implant lower end is here. It is above this hairline. Make sure that your implant doesn't cross this lower hairline. The skin here is very thin. So implant secured here, incision is subcuticular, no incision in the ear canal. So that is what is the varia. I think it makes it very clean. And what I would also suggest, and what I'm also planning to do, is also delve into posterior tympanotomy, because as you said, there are certain electrodes which are not. So we are planning to do the posterior tympanotomy, and I still feel that this incision can be done well for posterior tympanotomy. Know where the incision crosses the electrode at any point. And if you go back, this is a video, just a short video. Sorry. So this is just the external picture from the camera, and I'll go to the microscopic picture as well. So it's important that you plan your incision well. So can you see this? So this whole thing will go ahead, and quietly, very nicely you can expose. This is the place where my periosteum will be covering the implant. So that's how I'm opening up. I'm having no cut into the middle ear and no incision into my ear canal. Very slowly I go ahead with that. And as I said, I want to delineate my chorda early on. It is also important that I do my lateral wall drilling because I want to keep my canal straight when I'm using the Triphon perforator. All these things Dr. Pavan has already told you. So I'm just going to show you how this finally ends up. So this is the Triphon perforator. The canal is already thin, it's already out at the above the cordofacial angle, which is important. And then you use the 24 gauge cannula to see the patency. There's again a view from the camera of the overhead light. The implant bed, importance of implant bed, making it right angle, all those things goes without saying. We are using routinely metal implants. Anchoring hole is very important. All my surgeries has, I do not place in tight periosteal. The periosteal pocket is tight, but an anchoring hole is done in all my cases. I use Ethibond 3O to do the suturing. So this is there and you remove it. You can actually then do your round window. So this is the round window niche drilling as Dr. Rajiv was telling. There are two ways. Yes, you can also do the just the removal of by a small pick. You can expose a round window, open it using a pick, and once it is done, you close everything, put your implant tightly fitting there. And then very slowly you can insert it. The whole thing goes in one go. I usually use my instruments of metal forceps at the very last to just bring the ring there. So that is the ring, and it is quietly, and I don't do a cantilever, it's a complete, so this is how it is anchored well into its bed. So I'm putting a bone pate here and a layer of fascia there, and that's how I cover my extra electrode with a layer of fascia and then stitch it. As Dr. Rajiv told, we take a small anterior. So this can be easily done for your posterior tympanotomy also, this incision. So the incision doesn't cross. So if you do a post-oral, fine, everybody has been doing. Try this for your posterior tympanotomy, that's what I'm thinking. Because you have adequate space, the same flaps you can raise, and your incision will not cover, not cross your implant at any go. So that's what it looks like, and the post-op picture, I told you how it was. So this is, I think, and we are, now I have done around 45 cases, Rajiv, I think 45 cases with this. So what are the steps which we modified? The incision was scalped with no extension to the ear canal, inferiorly braced scalp flap, superiorly braced periosteal, which is same as before. No metotomy or incision in the canal. Incision is always 1.5 centimeter away from the implant, away from the hairline. Bone pattern canal led by temporalis fascia. No part of incision crossing the implant. Round window insertion in most of our cases. Anchoring the implant in all our cases. So what is the advantage? No metotomy, no otitis externa, faster healing, minimal pain. Buttressing the canal, reducing the chance of extrusion of the canal electrode at any point. Planning incision, ensure complete coverage, reducing extrusion chances. Round window insertion, residual hearing preservation, and anchoring implants prevents migration. So this is it. This is the modification I wanted to share with you also. Dr. Amit was not coming. I requested Dr. Rajiv and Dr. Pavan, who have always been very good friends. I want to show something which I have done. So I have done around 45 cases till now, and I have been doing round window insertions since many years now. So thank you for your time, and I hope you like this modification and start doing it.
So we are left with 5 minutes. Any discussion? Question? Anybody want to put
Yeah.
I'll ask you one thing. So when you
Yes.
pull it down,
Yeah.
you feel there is a lot of stretching
Okay.
the canal.
In the ear canal skin.
Yeah, the incision is superior, right?
Yeah.
You have to expose it for inferiorly. Like
Yes.
if you ask
No, okay.
you ask me to do the posterior tympanotomy.
I'm just telling that it can be done.
In posterior tympanotomy, we have to drill till the mastoid tip
Yeah.
to the digastric.
So I just want to show you this. इसको ऑन कर देंगे क्या? एक बस फोटो. नहीं एक फोटो. Okay. So yeah, this last image which I wanted to show you, this one. So if you feel that this tip needs to be exposed, so actually this is a bit tighter. You can what we are doing is using a lot of stay sutures. So the whole tip area is in front of you. I'm just thinking to do it in coming cases. Let's see if we can do that. Otherwise, post oral is always there. For Varia, I think there's not a problem. It doesn't. So if you see this, it actually when you take the stay sutures, this whole thing comes down. The pinna actually comes down, and I feel that it can be done. It's something which is there in my head. So let's see if it can be done in posterior. I just feel that if the incision is not crossing the implant, it's a good thing to do. If it is a problem, then I think we'll push it back to post-oral for posterior tumorotomy.
Dr. Saurabh from Indore.
Hi.
I have one query. If the patient had a history of ASM or CSM,
Yes.
when the child is having a history,
Yes.
in that case, maybe if we need a blind side closure, then this technique will do the same.
Look, blind sac closure, this is just a skin incision. So blind sac closure, if you want, then obviously you'll have opened the canal and the way you do a blind sac closure.
I'm asking for the Varia technique, whether we can go ahead with the Varia technique.
Yeah, no, wait.
In a case of chronic
Then you have to do MRM and
subtotal petrosacchary,
yes. So that is not a Varia technique. That's completely different thing. No, so Varia technique is for these places, but for subtotal petrosectomy, the whole approach is different. And then you do a cul-de-sac as you do it in proper case.
but if it is an acute otitis media, history of acute otitis media, you wait, you treat that, and then you can do anything.
Yes, but still we are raising a tympanomeatal flap.
Yes, yes, we are, definitely.
But why to do CI in the case of acute otitis?
No, that is what his question. Matlab, he was just asking whether those,
If there is a history, yeah, a history of,
if there is a history, and then how do
if
you?
it is a glue here, you treat it.
So glue here, I think is no more. Many of these cases you open it and you have and you are opening the mastoid. So glue here में आप literally एक grommet type का तो बाहर से ही खोल दे रहे हैं. So you had actually opened it, and so in glue here is I think no more a contraindication for doing an implant. In many of the cases you will get a good curve C type, and then you open, you say, oh, there is a thick glue there. Until and it's purulent, it's something.
Chances of facial involvement is equally both in both the
I feel so, yes. It has to be very, very, as I said, it is sort of the anatomy, and you need to read your scans. You need to really go back and see your scans as to where is your facial and what is the cordofacial angle. What is that? What is the, actually, you know what? Yeah, we are done.
I think we can cut short this over here. We can discuss it over lunch or dinner, maybe breakfast over here. Thank you so much for patient listening. This instruction course was made like this. Thank you so much. So there is a symposium on salivary glands. I will invite Dr. Pradeep Tiwari to chair the session and Dr. Yamini Gupta to chair the session, please. Over to you.
Good morning, everyone. So to begin with the symposium on salivary gland, I invite Dr. Milind Navlakhe. He'll be speaking on how to become a siloendoscopist.
Yes, you pointed.
Good morning. At the onset, I would just like to thank the organizers for putting a panel on endoscopy first Apollo Symposium, because this is something which is quite new to a lot of ENT surgeons, and I think there are other speakers and not yet arrived. So I will start with mine, which is basically about how to start a endoscopy center in country like India, where I have been running it for more than 15 years now. It's not moving. Excuse me. Yeah, fine. So, like any other surgical skill, silent endoscopy is not something it's somebody is born with, but you need to have a desire and urge to learn it. But a lot of surgeons, even in India, who are very skilled, have started with silent and left just because of the patience you require. Yeah, I don't think any other surgery, because I'm into a lot of other things like face rhinoplasties and face rhinoplasty cochlear implant, but there's no surgery like this which requires patience for 2 millimeter and 3 millimeter stone. Initially you may have to spend like 2 hours, 3 hours. Now even though after training, yeah, it becomes easier. So my talk today is basically how to go ahead with, if somebody who is interested in silent endoscopy, how to start. Firstly, what is important is a good training and mentorship. Now the training itself start with observing surgeries. Maybe nowadays you have YouTube, but once you go into the OR to observe a silent endoscopy, you'll realize that even if I want to relay a silent endoscopy, it's not only the endoscopic picture, but it's the external cameras also. So it's better to go in the OT and observe. There are only two hands-on training centers in the world where best training is given. One is in Geneva, and second, proudly, we run in Mumbai. And the Mumbai fee is almost 1/50th of what you pay in Switzerland. So it's better to just get to start training with our center in IMAST. These have been my mentors, Dr. P.P. Singh, who started silent endoscopy in India almost 15 years back, and after which in a year's time I started, and Professor Koff, Ero, and this is Professor Ero and Zenk, and obviously Dr. Marshall. Most of you know he has been to India many times for silent endoscopy. So we started with a concept that we need to do something for Indian surgeons to get trained, and I would proudly say that I started a center almost 5 years back, and now we have trained about more than around 100 silent endoscopy surgeons, and in India there are about 50 of them are actually doing surgeries. So there we have a model which I have developed. So I start. It's a day's course where the surgeon is first given lectures in the morning. I am the faculty director there, and there is one more faculty usually. And we take only 8 delegates so that there's a dedicated full day silent endoscopy training. At end of the day, I'm sure that the surgeon, if goes back and buys the silent endoscope, will be able to start with at least a diagnostic procedure. So how we make sure of that is we give them lectures, then there is a hands-on training which is the main part, where we start with this model and then go on to the pig head. You can see Dr. Professor Udwadia there. Is actually the last month we lost him, and otherwise he has been a pioneer in starting this center where all the trainings is done, a good mentorship, and it's all stores based of the equipments available to you at a very nominal cost, and the training really helps starting your center. Any of you interested can go on to this website imas.org, and there are a lot of ENT courses, not only silent though, it's on face, cochlear implant, and everything. So in silent endoscopy, the parallel thing in the urology is basically it's a calculi which they deal with and we deal with. So a lot of time when I am free in multi speciality hospital, I go to the urology OT and just observe them breaking the stones and how they use the techniques, and similarly we can just follow. So being said about surgical training, it's very important that you know about preoperative investigations and how you need to manage the patient preoperatively. Firstly, you have to control the acute infections. Radiology is integral part, and as I have written here, it's not only the radiologist, but it's the surgeon who needs to be trained in ultrasonography. That is because intraoperatively there are situations where you have an ultrasound machine, you have radiologist for some time, but later on you have to be on your own with the machine, and you need to know how a stone looks like. So basically, sonography, CT scan, and MRI. Main thing is sonography, where we would know whether there is a stone or a stricture or a stenosis. The sonography, I would suggest that when you talk to your radiologist, get a habit of doing it pre and post vitamin C, so that the obstruction is seen more prominently. Depending on the pathology, if there is a stone, then obviously CT scan, and if there is no stone seen, then I would prefer a MR scilography. A conventional scilography is definitely no because that causes a lot of damage to the ductal openings. So, as I told you, intraoperatively sonography very important. As here, I could not find a stone, and then obviously my radiologist come in picture, and he would tell me that exactly how many millimeter I am away from the stone. So, you require a lot of training on sonography also. What are the difficulties in silent endoscopy? The main difficulty being you are operating in a very small narrow area. The openings are very small, so obviously to start with, the dilatation has to be done with microscope or loop. I am more comfortable with microscope, but the loop is also, the maxillofacial surgeons do a lot of silent endoscopy nowadays, and they are using more of loop. Now the main difficulty for us is all our endoscopies other than silent endoscopy, the medium is air. Here the medium is water. So you are operating under the fluid. So the picture quality does not remain as you will have in a face. That because the scope is very small and you are under, and it's under fluid. So the moment your assistant stops irrigating, you will stop seeing the picture. And whenever your assistant is irrigating, you will see the picture. So it's continuously under the fluid, which under which you have to see, visualize, use instruments, everything. So as you see here, there's a duct which is getting collapsed the moment the assistant stop irrigating. So coming to my main topic of training and starting. So what you need to, sorry. So basically the instrumentation is very important. You to make it convenient. Now Stowe's has, this is Carl Stowe's brochure. Unfortunately, no other company makes all the equipment. So basically, we have to depend on Stowe's. Equipment obviously are quite expensive, but if you start a center, it is definitely becomes cost effective. You have basically basic set or a advanced set. Now the basic set will have only one endoscope and some instruments, and once you want to go for advanced procedure, then you have two endoscopes and the instruments. So there's a catalog available online also. So the instruments are basically of two types: Erlangen system and a Marshall system, where Erlangen is a place from where they are originated from, and Marshall obviously named by Dr. Professor Marshall, and both made by Stowe's. And I have been fortunate enough to get trained at both the places, Marshall's and Erlangen's. So there are instruments which are reusable, and there are some disposables. So these are the basic things which we all of us have as a ENT surgeon: a cold light source, fiber optic cable, and a monitor. Endoscopy, a regular camera is also good enough. So in the instrumentation, when you go for, in the basic one, you will get all these dilators, which are basically the solid dilators on this side from 40 to 8, and you have 5 hollow dilators, which also called as bougie. And these are the instruments which are basic. Actually speaking, the silent endoscopy instrument wise requires very few instruments, and mainly the endoscopes. This is one of the dilators, which is a conic dilator, and you have the dilators which I showed you before. And this is how a bougie or a hollow dilator is used, that the guide wire is passed, and above that these are threaded gradually from smaller to bigger one. So you can gradually dilate the duct. That's how is the guide wire looks like. So this is the basically after dilatation, that the guide wire being passed. So as you see, this procedure is done under microscope. So once it is under microscope, you can see quite clearly. I will skip some longer videos due to short of time. So, coming to instrumentation, which you're on, now we talk about Marshall system first. Now, what is the difference between the two sets of instrument? Marshall system basically works on different channels. So, you have these diagnostic channels and you have the therapeutic channel on this side. So, diagnostic channel have only one port through which the endoscope goes, and you have the side port for irrigation. Here you have another port for instrumentation, and this is how the tip of a therapeutic channel looks like, so that it's easier to pass in. So the diagnostic channel is threaded with the guide wire, on the guide wire I mean, that the guide wire which we have already put in the, as you saw in the initial video. So basically the channel, as you see here, that the diagnostic channel being passed. Now once the channel is in place, which is obviously a blind, but you have to be very gentle because you are not seeing inside. Once it is in place, then I would remove the guide wire and put an endoscope inside, and then you can visualize. Once you have done the diagnostic scopy, then you can go on to therapeutic channels, so that you have an additional channel for putting the instrument. This is how a Marshall system looks like. So as I already told you, I won't go into detail of any procedures. Talking about the other system of instrumentation. Now it's a matter of once you go for training and then you realize what are you comfortable with, whether Marshall system or Erlangen. Now the Erlangen system, the disadvantage is you do not have different channels, but you have a better picture. That is because it doesn't have a carrying channel, but the whole endoscope has everything. So here, what this is the Erlangen's endoscope, which has the channels for instrumentation is already in the endoscope, as you can see here. So you will have to buy multiple scopes. You can't manage with one scope. Whereas if I compare this to the previous Marshall endoscope, now Marshall endoscope, as I showed you in my videos, that you can use different channels. So same endoscope with multiple channels you can use, but here if you go for Erlangen, you will have to buy multiple scopes. Is that 20 minutes over? I don't think so. Was it fast? No, we have time. Yeah, because okay, fine then. So this is how the endoscope and the trolley looks like. This is the basic diagnostic endoscope. You just require only these many instruments. So that's, as I showed you, this is the Erlangen scope, which is little more sturdy. You have the instrumentation channel here, irrigation channel here, and an endoscope. And the camera head and the endoscope head remains here. So this is not just the fiber optic cable, but that's the part of the endoscope. So you have to be very careful about the sharp instruments or needles on the trolley, because a small cut in the cable would just spoil your picture, and that's not repairable. One fiber which starts here at tip of the endoscope ends at the head of the endoscope. So the whole thing is the endoscope. Now the Erlangen system has a inbuilt channel, so you have more space for fibers. That is how the picture of a Erlangen system is much better than the Marshall. If you imagine a Marshall endoscope here, so you will have a lot of gap between the sheath and the endoscope. So endoscope becomes smaller in size in case of Marshall. But the advantage is you can manage with one endoscope multiple procedures, because each endoscope costs presently I think about 5 to 6 lakhs. So that much of less investment if you are going for a Marshall system. But the picture quality wise, the Erlangen gives you much clearer picture as compared to Marshalls. I think we spoke about localization of the papilla. Coming to other instruments, this is a handheld drill. So drill does not have any motorized this thing. You have to just put it, hold it in the hand and rotate. So these are the burrs which are zero point 0.4 and 0.6 and 0.8 size, and that is how we have to hold it here. I just hope this video was giving a little problem. I would just show you separately. This is basically a stone which is broken with a burr. Just burr rotates onto the stone and it breaks into pieces. But not that easy as you think of. You require a lot of precision for that. Instead of burr, you can even use a holmium laser. So the other instruments are these forceps, which are for grasping the pieces of the stone. These are reusable, these are not disposable. Coming to more expensive part as far as the patient is concerned are the disposable. And unfortunately, after this COVID time, the disposable cost has almost doubled. So it become quite expensive. So these are the baskets which are available as 3 wire, 4 wire and 6 wire. And there are some baskets which are tipless, wherein it doesn't have a tip like this. So even if you go head on onto the stone, you can just open the basket and grab the stone and take it out. This is how a basket with the stone looks like. Then you have disposable balloons, which are basically for stricture dilatations. And then you have some stents which are for stenosis, strictures, or post combined approach endoscopies, which are basically the advanced procedures. So this is how a stent looks like in place, a parotid. Now, talking of the procedure, if somebody wants to start a endoscopy when they come for training at my IMAS center, to tell you for the people who have come late, IMAS is a center in Mumbai where we give training. We have 4 courses in a year, a full day's course from morning to evening, where at end of the day you should be able to go and perform at least a diagnostic endoscopy, and then obviously you progress on your own. So you can start with basic procedures which are listed here, and then you can go to advanced procedure like combined approach. What is combined approach? Is basically you have a large stone inside which you cannot break, which you cannot take out, not break. You may be able to break it, but not take it out because the stone is very large. Suppose you have a 8 or 10 millimeter stone in a submandibular or a parotid, then you have to do it combined. In the sense, you have to localize the stone with the endoscope, but have an incision. Now, in case of submandibular combined approach, all the incisions are intraoral. You go very proximally on the duct. Proximally is toward the gland. Go on the proximally on the duct, dissect the lingual nerve, and then take out the stone. But in case of parotid, you have 2 options. You have either intraoral combined or external combined. For proximal stones in parotid, again, you require usually an external incision to remove the stones along with the endoscopy. So if somebody is planning to start a endoscopy center, basically your training hurdle which was there when I started endoscopy, obviously I was trained for a few days with Dr. P.P. Singh, but with the limitations of equipments and everything, I couldn't get much hands-on there. So I had been to Professor Marshall, where he had the course which is exactly similar to what I do now in IMAS. Where we use a big pig head to give a hands-on training. So pig head gives you almost realistic experience of endoscopy. So that is overcome. Then your equipment stores have come up with a basic and advanced set. So you don't land up taking something which does not match with each other, because you have to have instrument which matches the lumen of your scope which you have taken. So that problem is also taken care. Maintenance of the equipment, obviously, that's such delicate that you have to take care of yourself. Failed cannulation is one of the things which puts on to a surgeon that you struggle for 1 hour, 2 hours, and you don't find the opening. But that's okay in the beginning; it can happen, and that is how you need to. That is what you need to tell the patient pre-operatively that it may fail. Cost effectiveness, definitely initially it's quite a expensive thing to put up, but if you, as you see, the population of India is so big and there are very few silent endoscopy centers in India, and there's a lot of scores to have at least one center in each district. So, and we are doing a lot of silendos, all the surgeons who are in our group of silendoscopy group of India, we always there to help and get more people. I myself have trained about 100 surgeons by now. For the patient, I think it definitely a cost-effective thing with today's days of selfies and photographs and seeing nobody wants even a small scar on the face, and that is how silent scars really picked up in India now. Coming to consent part, obviously when you are a beginner, I have already formatted. This is a very small one which I have showed as a representation, but for different procedures, like if it is a JRP, juvenile recurrent parotitis, or if it is a stone, depending on that we have different consent, which I can share with whoever is interested. And those are basically, when I was in Germany, I got it translated into English and I have got those. So those are quite good. So it's very important that you are aware about silendoscopy procedure. You keep your patient informed, because this was an article which I have written in almost 2010, and after the article came in the newspaper, one of my colleagues within Mumbai came and told me your article has put me in problem, because I just removed one gland yesterday and the patient has come to me and fighting, why did you give me a scar? Then obviously tried explaining him it's quite expensive this thing, and he said no, but I never talked about the cost. I am quite a highly placed software engineer. I can just afford anything, and you are not given me an option. So this can put you in problem medico legally also. So be informed. You can, whatever your way, you can inform to a patient that this procedure is available, possible, whether you are doing or your colleague is doing. I think you should refer the patient. So with that, I would end my talk on how to start a silendoscopy. Any of you are interested in the course, or any of you are really would want to know about the course, you can approach me. I'm here for next 2-3 days. So with that, I thank the organizers. I was just showing this. Okay, you have this website to go on to for the course. Thank you very much.
Dr. Mellon. Thank you, Dr. Mellon, sir. It was a nice lecture.
Center. Now the basic, as I told you, one scope cost about 5 to 6 lakh. Remaining things, obviously you have your own, you have light source, cable, cameras, I'm not counting that. So addition to that, the other instruments are not very expensive. That would cost about 1 lakh of rupees. So one scope and a basic instrument about 7-8 lakh, which stores people will be able to give the cost here also.
So you showed one case putting stent.
Yeah.
How long do we keep the stent?
The stent is put for maximum for 4 weeks. It's a silicone stent, and minimum for 1 week. And in that much time the healing occurs, and you can take out the stent in OPD basis, because it's just anchored at the opening.
Thank you, sir. It was very nice.
Size of the stent, it starts from 3 French. Usually 3, 3.5, 4 are the ones which are required. And the length is 4 to 5 centimeters. No, there are different. There is one developed by my colleague, Dr. Aditya Murthy from Bangalore. And there are others also. The imported ones are very, very expensive, but the Indian ones are good.
German-made bougies are available, sir.
Sorry?
German-made bougies are available, sir.
Bougies? No, the bougies are basically of stores. They are disposables. If you are talking of guide wire, guide wires are disposable. And dilators are reusable, autoclavable.
Excuse me, how much is the percentage of unsuccessful procedure?
Yes,
Now,
good question. So in the beginning,
after so many years of experience I'm talking about.
now I really know that this patient is impossible. I can see fibrosis, I can see basically fibrosis at the opening, or cases with SMF, very restricted mouth opening. But if it's a routine silendo, now after so many years, I don't get any. But to tell you fact, that initially if you start today as a first thing, be prepared for 20 to 30% of failure to cannulate for first 10 cases. After that, you should be okay. Now, how I improved on that and how I suggest is when a patient comes to OPD,
We can discuss this after.
yeah.
We are running ahead of time.
When you come to
Yes,
OPD,
we'd like to call upon the next speaker, Dr. Srinivas Murthy sir. He is Dr. Ravi Sachi sir. His topic is neoplastic disease
Thank you.
of salivary glands.
Can we start, ma'am? Yeah. After that excellent talk by Professor Navalke, so we'll just go to the much more common disorders, the neoplastic diseases of the salivary glands. I mean, I work in Bangalore, and neoplasms of salivary glands are, compared to other head and neck tumors, are pretty rare. It's accounts to about 1 to 5% of the head neck tumors, and most of us will not see more than 3 to 4 per 100,000 population, and in a busy practice, probably most of us operate between 15 to 20 a year. So it is not very common, these glands, and most of them are benign, and they present as a small lump either in the parotid glands or the submandibular gland. So in the next 20 minutes or so, we'll look at some of the evidence of management of salivary gland neoplasms and different types of neoplasms as well. So what are the guidelines which we have? We have limited evidence-based guidelines, and most of the evidence is currently based on long series of cohort studies, comparative studies, and there is only 2 guidelines. One is the ASCO guidelines, which came in 21, and the ENT UK guidelines in 2017. So there's not much hard data on salivary neoplasms. So we'll look at the management and some of the controversies surrounding it. So once we see a lump of the salivary gland, what do we do? So other than taking a good clinical history and an examination, so we all have to get an ultrasound done to see where exactly the neoplasm is. So if you're looking at a parotid, we just want to know is it superficial lobe or a deep lobe, and get a fine needle aspiration cytology. And if we do not get good sample from the fine needle aspiration cytology, get a core biopsy to find out what it is. So the most important thing is to make the distinction between a benign and malignant, or of course if it's an inflammatory disease, to know whether it's an inflammatory disease, because the treatment will go to a sialadenoskopist or conservative antibiotic management. CTs are generally done for an inflammatory disease, and for neoplasms, the investigation of choice is MRI. So there's not much scope for CT sialography or MR sialography. Of course, there is role for frozen section if you are doing surgery to find out whether, if there's a diagnostic uncertainty between benign and malignant, so a frozen section can help. And if you are sacrificing the facial nerve for whatever reason, you would want to get a frozen section. So how many types of salivary gland neoplasms are there? It is pretty big, and WHO proposed a classification a couple of times, 2005, which is the more simpler one, but 2017 also we had a classification, 2021 we had a classification. So there are quite a few classifications, and if you look at the literature, there are at least 250 types of salivary neoplasm. So it's very difficult for a cytologist to tell which type of tumor you are dealing with. So in 2017, the American Society of Cytology and International Society of Cytology came with a little classification to make the cytology a much more easier option. So that basically, if you send to a cytologist, he'll try to, classify the salivary glands into 6 bins. So one is non-diagnostic category, which means that, the sample is insufficient, so which means that you'll have to repeat it. Non-neoplastic, which means that it comes towards granulomatous diseases or sialadenitis. Then ATP of undetermined significance, which means that OS, it's just like the thyroid classification, which you have the TIRADS, they've also proposed this for the parotid as well. So then you have the type 4, which is basically benign, and SUMPs, which are basically salivary gland neoplasm of uncertain significance, which means that it might be low-grade malignancies or probably a benign one. Then of course type 5 and type 6, which means the suspicious of malignancy is type 5, and type 6 is frankly malignant. So this classification is now slowly being practiced all over the world, which makes things easy for cytologists as well as the surgeon, because the decision making becomes easy. So if it's non-diagnosis, what's the risk of malignancy? Because most of us want to know whether the tumor is benign, malignant or inflammatory. So if it is a non-diagnostic sample, the risk of malignancy is about 25%. So you just have to repeat it or get a core biopsy. If it's non-neoplastic, it's easy. You'll have to refer to your colleagues if you're, to a cytologist, okay? And if it's us, the risk of malignancy is about 20%, and if it's benign, if the cytologist says it as benign, the risk of malignancy is about less than 5%. If it's suspicion of malignancy, risk of malignancy is 60, and malignant, it's of course 90%. So there's a good inter-rater reliability, and a lot of us are practicing the Milan system of classification. So once you come to investigations, other than the ultrasound and the ultrasound guided cytology, we would want to know if it's a tumor, whether you want to know it's a superficial lobe tumor or a deep lobe tumor, and if it's malignancy, you would want to know whether there's any facial nerve involvement, perineural spread, dural involvement, bony involvement, etc. And for knowing whether the tumor is a superficial lobe or a deep lobe tumor, the best one is to see the marginal the retromandibular vein, which I'm showing you on the picture here on the operative field, and it's very, very closely linked when you're to the facial nerve. So, here you see this retromandibular vein, and this is the external carotid artery. So if you draw an imaginary line between the digastric and the posterior border of the mandible, you can separate the superficial from the deep lobe. So this will help us to classify, and also to take a good informed consent, because the deep lobe parotid tumors have a slightly higher risk of facial nerve palsy. So in summary, all of them have to have an ultrasound, and CT is basically to looking at stones, and MRI for all the benign and malignant neoplasms to classify whether it is superficial or deep lobe, and to give a reasonable characteristics of the tumor. Now this is one more example of a benign tumor of the superficial parotid gland, which is extending into the deep lobe of the parotid. So what classification do we have? We have a TNM classification, which is very simple and easy to replicate. Basically, it says that T1 is a less than 2 centimeter tumor, 2 to 4 is grade 2, grade 3 is anything which is more than 4 centimeters, and T4A is basically involvement of the skin, extraordinary canal and facial nerve, and T4B is often probably an inoperable cases, which means that it will involve skull base, pterygoid plates, or encasing the carotid artery. Now, coming to the treatment of salivary gland neoplasm, the treatment is bog standard. We'll have to do a parotidectomy. Now, parotidectomy, over the years, people have classified into superficial, total, and radical. Now, again, there is a work to sort of, what is superficial, what is partial. There is a lot of variation between centers and between surgeons. So they're trying to unify the parotidectomy. So basically, they have basically graded the parotid into 5 zones. Axillary parotid is zone 5. If you have a superficial lobe and a deep lobe separated by the facial nerve, so anything in the superficial lobe and superior is zone 1, and superficial and inferior is zone 2, and same thing with the deep lobes. So deep inferior is zone 3, and deep superior is zone 4, and axillary parotid is 5. But this will still leave the radical parotidectomy. So they have not made a comment on this. So you can actually, when you do a parotidectomy, you can actually write which zones you have operated. Now with all this, there is one more technique called the capsular dissection technique, where you do not identify the facial nerve and then still do the parotidectomy. So they are usually done for benign tumors of less than 4 centimeters. And here what happens is that other than doing the classical parotidectomy where we identify the facial nerve, here you do not use the technique of identifying the facial nerve, but use a facial nerve monitor and go along the tumor with a margin of about 4 centimeters. So there's a technique, and it is shown to be having good local control rates and less local recurrence rate, and the facial nerve palsy rates are also less. So people are moving more towards conservative surgeries. Now, to summarize, how do we work up? So if you see a patient, so make sure that you take a good clinical history, look for facial nerve palsy, look for if there's any pain, then get an ultrasound and guided FNSE or a core biopsy. So if you know it is benign, go in and do a parotidiectomy. The choice is yours what you want to do. So tailor it to the patient. And if it's malignant, you will have to do a total parotidiectomy. And if there is facial nerve involvement or involvement of the bones, you might have to do a radical parotidiectomy. So sometimes it so happens that with the amount of histology, you might find some unusual tumors in the parotid, which means that you will have to discuss this in the tumor board and then take further consideration. So this is a fairly easy chart to look at and see how to manage the glands. Now, there are certain important things which I would like to sort of discuss. How many of you actually use loops for doing parotidiectomy here? Does anybody use loops? No. Magnification or microscope? Do you use, madam? Okay, yeah. I mean, this is very important because, without loops, do not operate thyroids or parotids, because loop makes a lot of difference. At least 2.5 centimeters, 2.5 magnification is very important. Otherwise, looking at the branches of the nerve will become very difficult, and it certainly helps you to dissect the salivary glands much better. So use loops, but there is no hard data again. So, but certainly use either a microscope or a loop, and loop makes it easier. So what are the different types of incisions which we use for parotid surgery? So there are very many incisions, but the advantage of modified Blair, which is what I use, is that, if you have or if you see a neck node, it's easy to clear the neck nodes as well. The others makes it a little bit difficult, the mini incisions, facelift, if it's a very limited benign tumor, you can certainly use a facelift incision as well. Now, this is an example of a parotidiectomy which has been done, and scar, on the, so this is the, after, you can see all the important structures, which is basically sternocleidomastoid, and you can see the digastric, the facial nerve, all that. And it heals quite well. But sometimes in Indian skin, you tend to have a little bit of keloid tendencies. If that happens, you might have to inject a little bit of steroids to improve the scar. So how do we go about the deep lobe tumors? The deep lobe tumors, we need to, get a scan. This is what it helps us to make the distinction between a superficial and deep. And there are many techniques. So this is a technique where you actually preserve the superficial gland. So you basically, once you identify the facial nerve, you reflect the whole of the superior lobe of the parotid anteriorly and deliver the tumor. So it's if you have a very encapsulated tumor like this one, which is basically a lipoma, you remove the tumor between the branches of the buccal nerve and put the superficial gland back. So the advantage of this is the incidence of Fraze syndrome decreases, facial nerve is conserved, and contour deformities which you often have, all that decreases. So this is one technique which you can do for deep lobe tumors. Now here is one more video of deep lobe tumor where sometimes it's very difficult to dissect the thing. You need a lot of patience. But here we have taken the superficial along with the deep lobe. And what you can see is the superficial lobe superiorly, and that is the tumor, and that is the digastric muscle. So in such kind of situations, you have two options. Either go in between the branches of the buccal, but if there are too many buccal branches, you might have to divide one. And here, see, you can see the amount of stretching of the tumor. It's often very difficult to dissect this. But what we have done is used magnification and used an iris scissor and gently and slowly dissect the nerve and deliver it inferiorly. So this takes a little bit of patience and time and works pretty well. So let's just advance this one. So here is the nerve, And once you do that, what happens is that the nerve, gets bare a little bit, about 4 to 5 centimeters, it does get bare. And that's why the risk of facial nerve palsy in deep lobe tumors is little higher compared to superficial lobe. So that is the site after resecting the tumor. Now here is a case in, again, a deep lobe tumor where, you see that, you don't see very many times you're cutting the facial nerve. So I thought there is a little bit of involvement and, it will be difficult for the tumor to be removed. So what you have done is you cut the buccal branch. So once you cut the buccal branch, it is more forgiving compared to the eye branch and the marginal branch. So you deliver the tumor, and after that you use a 80 or 90 ethylon to close the nerve. Okay, so that's what we have done here. And immediately you obviously see a little bit of facial nerve palsy, but because you have sutured the nerve, and you can see that at the end of 6 months, the facial nerve function is absolutely normal. So sometimes you might get into situations where you might have to cut the nerve a little bit and then deliver the tumor. Now, another important issues, should we monitor the facial nerve? How many of you use the facial nerve monitor for mastoid surgeries, let's say? Probably none, I think. Nobody, no? And for parotid, how many use the facial nerve monitors? Probably nobody. Okay. So I think, again, in India, it's very difficult to get the monitors because, probably medical colleges have it, 8-9 lakhs. And the other simple solution, if you don't have it, is a nerve stimulator. This is a Medtronic stimulator, which is about 3,000 rupees, I think. So it's very easy to use it. Or you can use the anesthetist stimulator, which I'm just showing as a photograph on the side. So you can use that as a stimulus if you have doubt whether the nerve is seen or not. You can use it even for mastoid surgeries. It's a very simple disposable instrument, and you can just stimulate the nerve and look for you can directly see the contraction. Okay, so use this if you don't have a monitor. Now coming to the other important and rarer tumors, the malignant salivary gland tumor. So this is a mucoepidermoid tumor which I operated, fairly aggressive tumor. So in malignant tumors, you'll have to do total parotidectomy, but in this case, it had to be much more than that. So it required removal of the bony external canal, then zygomatic process, doing a neck dissection, and basically a radical parotidectomy. So this kind of surgeries might be needed. So what do we do with the neck in a malignant tumor? So usually total parotidectomy suffice, but if you have a N0 neck with a high-grade mucoepidermoid, adenoid cystic, squamous cell cancers, carcinoma ex pleo, make sure that you do at least 2 to 4 clearance. And if you have a N+ neck, go and do a modified neck dissection. And where are the situations where we give adjunct RT? It's usually given for high-grade tumors, T3 and T4, residual tumors. If you think that there's a little bit of residual tumor, bone, nerve and vessel involvement, extracapsular spread, recurrent disease, and inoperable cases, you can certainly consider that. And adenoid cystic carcinoma, there is a debate that even for early tumors, you better consider radiotherapy, although it's one of the most radioresistant tumors. So what does the radiotherapy do? It, most of the data suggests that there is a good local control rate and adds survival as well. So all the SEER database, Dutch database, all that says that. So what else do we have in terms of therapy? The problem with salivary gland is they are radioresistant, so it makes it difficult. So there people have exposed fast neutrons and carbon ion with IMRT as well. And in inoperable cases, CTRT, metastatectomy, biologics. But unfortunately, a lot of these are still in phase 2 trials, which means that they are experimental. And if you see recurrent tumors inoperable, so you can put them into one of the bins, and basically it's a trial treatment which you will have to tell to the patient. Now coming to the facial nerve palsy, what do we do? So if there is, if there is no preoperative facial nerve palsy, make every effort to preserve the nerve. But if there is already preoperative facial nerve palsy, there is more likely that the tumor is involved, and your MRI will definitely tell that. And if the facial nerve is involved for a very short distance, you can do direct single anastomosis, like which I just showed you. But if the involvement is pretty long, then you might have to put a interposition grafting. So, which is the commonest nerve which you use? You use the greater auricular nerve, because you would anyway identify, and when you're doing parotidectomy, learn to preserve the greater auricular nerve, because if you preserve 4 to 5 centimeters, most of the times it will be suffice to do an anastomosis. Sometimes you might not get it. So if you are an ENT surgeon, it makes it easy. You can actually drill the mastoid and go higher up. And as you see in the top photographs, you go very high up, and you can anastomosis the facial nerve in the mastoid segment itself. So there are other options which you can use. One is hypoglossal to facial nerve anastomosis, and the other is mesenteric, which is shown in the second one. So now people are preferring the mesenteric to facial nerve anastomosis. So I think there's a talk here on management of later in the day or later in the conference. So you will probably have more information. So there are other things which you can do as well, but I think this is probably be out of the preview of the talk. So next, coming to spillage. Spillage is one of the problems of salivary surgery. If that happens, make sure that you go and clean the area. And some people have used to, if there's a spillage, take the tumor out, and whatever left behind, put a little bit of tissue glue so that more doesn't come out, and then dissect the tumor. And I think any spillage, it better be discussed in the tumor board, because you might have to sometimes consider radiotherapy. The other important issue is recurrent pleomorphic adenoma. I think it's something which should not happen, but if you get it, which can happen, there are two types. If it is, if the recurrence is only in a single area, it makes it easy. You just go and do a total parotidectomy and things are fine. But if it is multiple recurrences, it's often difficult, and the risk of facial nerve palsy increases. And here is again something to consider radiotherapy for if it's a very bad disease. So what are the complications of parotidectomy? So I'll just put a few. The most common one is transient facial nerve palsy. So this can be as high as 20%, but generally, permanent facial nerve palsies are just about 2 to 3%, so you don't get that very many. Frey syndrome again is very common, but in literature, although I put it 3%, up to 40-50% people do report. Silocele, which is the little bit of salivary leak, and 1 or 2 patients I have put some Botox, which works quite well if it is more than a month. Then contour deformity, which is the lower photograph which you can see. If the patient is very thin, this might happen. You can use a sternocleidomastoid flap or anything similar. Ear lobule numbness tend to recover. First bite syndromes are also something which will recover over time. So, take home message, there is limited evidence. Most of these are cohort studies and expert opinions. Malignancies are rare, and the surgery should be tailored to the disease and to the patient. And remember to use the loop in parotid surgery. And should you identify the facial nerve, just like the thyroid, should you identify? I think the answer is an emphatic yes. Although if you are somebody who has done very many parotidectomies, at least 100, you can seriously consider extracapsular dissection techniques. And if it turns out to be malignancy, make sure that you take the patient to the tumor board to discuss adjunct treatment. So what's new? People are looking at US ultrasound guided elastography to find out the distinction between malignant and benign tumors. And facial nerve is still elusive for imaging. You still can't make out unless it is involved by a tumor. Optical imaging seems to be a great thing. I think there are a couple of papers on this where you inject sodium fluorescein, and there's the photo which shows down shows that if there's a recurrent disease, you can actually see it and you can remove it. And a lot of neurosurgeons are using it. They use a Pentario microscope for that. And concurrent chemo-RT for inoperable disease still being looked at, but hard data is still not there. So the next conference is in Namma Bengaluru, so please do come and book your tickets in advance, because Bangalore has a lot of traffic and you might get stuck in one of the steel bridges. Thank you. And there's a little video if somebody is interested. If there's a little bit time, I think you can ask questions and this video will play. No time. Okay, if there's any questions, yeah, please.
What is the magnification of the loop we use?
2.5, that is suffice. And if you want to use 4, but I think the advantage of using 2.5 is you can use it for anything. I use loop for septoplasty also, and no resident of mine will ever operate a neck without the loop. No loop, no surgery. Yeah. Yeah. Huh? See, a lot of times I put them on tryptomer, which is an anticholinergic effect. Until 1 month it can close on its own. If it doesn't happen, use a bit of Botox. Yeah, but try Botox. Try Botox. I mean, if nothing else, you'll have to put a flap in between. You'll have to put a flap. But largely, I've never had, I had one patient which went on for 1.5 months or 2 months, Botoxed him. It's very easy. And it stops. So nothing to worry.
Do you think the microscope is superior to loop in doing these cases? Because ENT surgeons, we are much more used to microscope than using loops.
Yeah, I have used both. But see, the problem with microscope is it becomes static. Okay, and with loop, you can actually keep changing the position. And if you use a good...
Your assistants will share the same view because you have a camera attached to the microscope as well. So, so they can see it as well. But with the loop, it's only you see.
No, again I said, without loop, my residents do not come inside. So no chance of even touching a parotid.
Running short of time.
Yeah, okay.
We'll try to go for the felicitation.
Yeah,
to felicitate you.
So I request Dr. Millen to join.
I'm really thankful to our chairpersons for chairing this wonderful session for us. Can I please request Dr. N. Sahila Swami to come up on the stage and felicitate our chairpersons?
At 10 a.m. to 11, Hall D, invited talk. The first talk is by Professor M.N. Shankar. He is the Professor of ENT, Madras Medical College, Chennai. And he will be talking on endoscopic ear surgery and beyond. Your time is 15 minutes. Shankar sir, please go ahead.
Thank you, Professor Airasamy, my dear friends, and good morning, everybody. I'm Shankar from Madras. So today I'll speak to you about endoscope ear surgery and beyond. To start with the history, it was Muir in 1967 who first introduced the endoscope to see the anatomy of the middle ear. And 2 decades later, it was Nomura who popularized the idea of surgical myringotomy for an intact drum just to see the middle ear. Then it was Kimura and Thomason who first introduced the endoscope to see the various pathologies in the middle ear. So this is important because it was only the revolution which produced all these changes. So every once in a while there is a revolutionary product that comes along that changes the whole thing. You all know how endoscope had changed our thought of doing surgery. So the endoscopic perspective redefines and reimagines the surgical anatomy, allowing a better understanding of the disease and anatomical relationship. So to start with, what is endoscope? We do both otoendoscopy and endoscopic ear surgery. So why not binocular? What are the deficiencies of binocular vision and the endoscopic view? Why is it?
Audiovisual people.
Yeah.
Okay.
So transcanal cases, especially when it is narrow, it is a bit difficult to use the microscope. You'll find it very difficult to change the position of the head, etc., and also the microscope. As the previous session also, they were telling loop is better than the microscope. So all these makes a lot of change. And second is why you want to go through the mastoid when you want to get into the middle ear. You are unnecessarily making a larger cavity. So endoscope will be a definite advantage. So this was first found out by Trueblood and Durham, who when they said that you using a speculum to see a 90-degree angle to see the middle ear, in the corners are not seen, but with the help of endoscope you can see the corners, and so panoramic view is better. So most of the diseases of the ear, especially the middle ear, occurs only when you have recurrences. So these recurrences are very difficult to see with the microscope because that is when you leave. So with the help of endoscope, you know where the recurrences are occurring and you'll be able to do a better job. So that is why endoscope. So this is a view of the operating microscope on the left side and endoscope on the right side, where you can see almost everything. Same place. So this is a higher end view with the endoscope. You can actually zoom also. Here you can see the stapedius, the stapedial bar, the anterior crura. With a slight higher magnification, you can also see the other structures. So when to do surgery, always choose the patient, choose the disease for which you want to do, choose the investigation, choose the equipment, and choose the anesthesia also. And these are the instruments that are being used. Yeah. So these are the instruments that are being used, and these are the endoscopes that are being used. I just want to go a bit quicker because there's so much to know. And always keep the light source below 50. Don't make it above 50 because there have been studies using pyrometric techniques wherein the amount of heat that is generated when you go closer to the cochlea is around 2 to 3 degrees. So it does not affect anything, but still it is better to keep the illumination much at a lower level. So Cohen has classified the ear surgery with the microscope and endoscope into 4 grades, that is 0, 1, 2A, 2B, and 3. You can be completely endoscopic or you can be endoscopic and microscopic. So it is only the way to do. I'm not contesting any microscope or endoscopic use, but I'm saying that endoscope can also be used. So in the earlier, probably the older generation would have read middle ear anatomy as epitympanum, mesotympanum, and hypotympanum. But with the endoscope, we are adding protympanum and retrotympanum, which are divided by the tympanic branch of the glossopharyngeal. This is the tubotympanic recess and all the structures that are derived from it. Why I have put this slide is because the folds and the ligaments that are attached to it are very important for the ventilation. So, and respecting these structures is very important in endoscopic ear surgery. And this is just the parts of the ear. So why this atlas? So the cochlea is within the temporal bone. The temporal bone holds the cochlea, and what should hold the cochlea? The structures like proteniculum, the funiculus, everybody would be asking why these are being mentioned. So all these are there to tell you that these are the structures which are holding the cochlea within the temporal bone. Funiculus, the fustus, the ponticulus, the subiculum, etc. And then retrotympanum, there's a very important classification which comes with the endoscope. You have a superior retrotympanum and an inferior retrotympanum. And in the superior, you have sinus tympani, posterior tympanic sinus. In the inferior tympanum, you have the facial recess and the lateral tympanic sinus. I'm not going into the details. Ventilation of the middle ear is very, very important. So the tensor tympani fold plays a major role in the ventilation of the middle ear. So position of the tensor tympani fold makes a lot of difference as to how the middle ear is being ventilated. So here you can find it can be either horizontal or vertical, and depending upon the position, the ventilation of the middle ear occurs. So this is the ventilation through the middle ear with the tensor tympani fold, which shows 70% passing through this way. And the second is through the supratubal recess. About 30% goes through the supratubal recess. This is the main route. Actually, when the air enters the eustachian tube and gets into the adductors, it passes through channels. One passes along the Prusac space along the malleus, and the other straight through along the facial canal. So just to highlight the ventilation, I'll go straight away into the middle ear surgeries. So the endoscope has really revolutionized the concept of middle ear surgeries and also the inner ear surgeries. These are some of the indications. There are much more to it, but I'm not going to talk much about middle ear because we have to go beyond. So endoscopic myringoplasty, I've just put in the photos. I think something's. Yeah. So it can be, and second is the management of cholesteatoma endoscopic. It can be transcanal or open endoscopic or extended transcanal approach to the cholesteatoma. And this is a video showing how we do the endoscopic. So you can see the attic perforation, you can see the cholesteatoma also. For want of time, I don't want to get deeper into this video. So this is the final result. I mean, removing the posterior superior meatal overhang and completely removing the cholesteatoma from its origin. And this is the mastoid cavity, which has been completely cleared of the cholesteatoma. And then we put in a graft and also do tymparoplasty. So this is the classification of cholesteatoma, epitympanic cholesteatoma from Livio Persuti. I think I've been having a lot of problems with the. Yeah, now it's better, I think. So this is a classification. I just don't want to get into the. And this is a small video of the endoscopic stepidotomy. I'll try to go a bit faster because there's not much time, although there has been. So there's a very old video of perilymph fistula. It was taken probably in 1998. So at those time there was not much good video camera. You can see that after the fenestration being made, there was a lot of perilymph gush. And so what we did was put in the graft, and then usually vein graft is done. Those days we used to do with temporalis fascia and then finish off with a piston. So 2 or 3 days there will be a little perilymph leak, and slowly it will become all right. So this is another revision stapes. You can see the stapes here. So this is the malleus and this is the stapes piston. So you can see a lot of granulations. So this was removed and perforation done, and then we did the case. So this is a case of CSF. This is a CSF otoria. It's not playing. This is another case of endoscopic facial nerve decompression, where you can see that we have that's the stapes, and there's we are removing the posterior superior meatal overhang, and we are trying to completely decompress the facial nerve up till the stylomastoid foramen. So this is the facial nerve being completely decompressed. This is the endoscopic cochlear implant. So we have done a few cases of endoscopic cochlear implant also. There are various ways of doing either posteriorly, transtympanic, or even robotic, which is the latest. So this is the endoscopic cochlear implant. So it is the advantage of endoscopic cochlear endoscopy is the view of the round window is much better with the endoscope. So after doing the posterior tympanotomy, you can see the round window quite clearly, and you can also go transtympanic, meaning without making any elevation of the tympanic membrane. Just go posteriorly, elevate the external auditory canal skin with the tympanic membrane, and then you can see. That is also one method. And another method is doing it robotically. And transtympanic approach to the petrous apex and also the internal acoustic meatus is another important use of the endoscope. So endoscopic approaches to the internal acoustic meatus can be promontorial, cochlear, or vestibular. Transcochlear can be suprageniculate, and transvestibular could be oval window. This is a short video of endoscopic approach to the petrous apex. So you can see that we have, after elevating, we go through the subcochlear canaliculus, and this is the cholesterol granules being flushed out after suctioning the apex. So you can see the dura. This is an intracochlear approach to the petrous apex. So for the acoustic neuroma, we have certain criteria for doing endoscopic procedures. That is whose grade 1 or maximum 2 with the American Academy of Audiology class 5. These two cases we can do endoscopic acoustic neuroma surgery. So,
sir, you are having 30 seconds more, sir.
There was a lot of...
It's already over, sir. 1 more minute.
Yeah, sure. So this is the transcochlear approach to the internal acoustic meatus. So after drilling the promontory, you have to drill from the round window anteriorly and superiorly and completely open the internal acoustic meatus. So you can see the tumor there, which is being slowly removed. A small tumor which completely produces deafness is an indication. The advantage of this procedure is that with the preservation of the facial nerve is quite easier. The only disadvantage is if there is bleeding, you'll have to be very careful. You'll have to know that there is no bleeding. You should not create any bleed. So we close the internal acoustic meatus with fat, tissue seal, temporalis fascia, and finally totally close the external auditory canal also. So this is it. So this is another method of doing stapedectomy, reverse stapedectomy, wherein normally we stand on the same, ask the patient, we stand on the side of the head, whereas here you face the patient so that retrotympanum is better seen. So the other surgeries are endoscopic lateral skull base surgery. It's in the ascending curve. And the future is robotic endoscopic ear surgery. So, which is still in the ascending curve. We can expect a lot in this regard also. Thank you. Thank you for your patience.
Thank you, Shankar sir, for enlightening us about otoendoscopy, which started as a diagnostic, and it has been, you have proved that it can be used beyond middle ear. So whole otology can be tackled with otoendoscopy. Thank you, sir, for your enlightenment.
Thank you, sir. I would like to thank the organizers and all of you who have humbly been here for hearing this lecture, and also our chairpersons. Thank you, sir.
Thank you, sir. Now I call upon Dr. Sanjeev Kumar. For the topic, learning curve in endoscopic stapes surgery. So I have witnessed your presentation in Asia Pacific, Hyderabad, sir.
Yes, sir.
It was the same topic. It was very impressive.
Folder is empty. क्या हुआ? Copy कर लो यार. Don't discuss scan now. Stapes surgery and learning curve. Actually, it is not the stapes surgery, the learning curve of stapes surgery. It is the learning curve of endoscopic ear surgery. And this Professor Shankar sir has given a wonderful talk about the basics and beyond. Basically, I started endoscopic ear surgery in 2012, and then till now I have completed 1700 endoscopic ear surgery and 100 stapes surgery. Particularly, if I talk about my journey, I started in 2014, and it was a total failure for me when I started endoscopic stapes surgery. And after few failure and learning and unlearning, and then I succeeded. So I will tell one thing, जिंदगी जीने का एक ही तरीका होना चाहिए, जिंदगी के हर मोड़ पे सीखने का जज्बा होना चाहिए. With this word, I am just giving you my perspectives of endoscopic stapes surgery. And this is basically the advanced stage of endoscopic ear surgery. So the beginners and whosoever is interested to do endoscopic stapes surgery must be convinced that they should attempt and they should master endoscopic basic procedure like tympanoplasty, laryngotomy, and many things, and then start doing endoscopic ear surgery. And if you are not feeling comfortable even after many surgery, you should about just without thinking if and buts I should go and or not. So when I think about the endoscopic stapes surgery or ear surgery, when endoscope is going transcanal, obviously it is better than microscope. Everybody should be convinced. When microscope is doing post-oral, obviously post-auricular approach with microscope is unparalleled. So I am not just competing with a microscope, but what are the advantage and disadvantage of endoscope and microscope in transcanal stage? It should be narrated before going to the main topic, I think. So why endostepidotomy? Why not? So I think microscopic stepidotomy in transcanal is almost established in otology for last many years, and probably the endoscope in year is a legacy of only 50 years and 50 years of research, innovation, and the publication. So better, I think a little advantage over microscopic stepidotomy, because you need to see the whole structure of the middle ear mesotympanum, and in stapes surgery there is a minimal tolerance of error. So you should be careful about all these things. And this is a high risk of otological procedure, so need to be very careful. But when you start doing endoscopic approach for a stapes surgery, it could be visibility is better, and so you need to have a less curating of bone. And then obviously the teaching and the training purpose will be more fruitful. And if you do other middle ear surgery, that could be again very good to see with endoscope and wider view, you know. So endoscope in a transcanal is almost opening the eyes for everybody in your theater and your audience. Whenever you use endoscope in here, everything will be absolutely crystal clear. So this is a very old diagram, and it is propagating since last 20 years. So after that, if you see the same perforation with a microscope or endoscope, it is very well understood that this perforation size and everything. So you need to have diagnosed basically the ear diseases and the fixation of a stapes, fixation between the incus and malleus. If you go beyond that malleus is fixed, malleus and incus is fixed. So it could be very easy to understand while doing a stapes surgery. So if you compare the endoscopic versus microscopic, obviously the endoscope with a wide field of vision and microscope is narrow. But the disadvantage of endoscope is the 2D. So you need to have a proper training of 2D, and your depth perception, your binocularity, your lack of binocularity, your limitations of doing endoscopic ear surgery while you are using endoscope, because you need to have one hand to work. Obviously, in endoscopic, microscopic ear surgery, most of the surgeon, if doing transcanal, one hand is holding with a speculum or suction. So basically, only one hand is working. And for the two-handed, obviously 200, but not really 200 with a microscope. Most of the time, I have seen. So transcanal, by definition, and usually transcanal is established with a microscope. Curating less, learning, need to learn. And learning curve of endoscopic ear surgery is for the juniors. My way of doing endoscopic ear surgery is a preparation of endoscopic canal, preparation of external canal, because you need to have two portions of the canal. One is the outer portion wearing hairs, and other is the surgical field. So you need to prepare both the portion of the canal. You clean the hairs very well, and particularly if you are using chemical for removal of hair, this could be again wonderful, because if you are using any scissor to cut the hairs, it could be traumatic, and the blood is going down and your field is going to obscure. So chemical removal of hair is important, and then you need to infiltrate the canal with a particular solution. Like I use 1 in 30,000, use 30 ml of Lux lignocaine and 1 ml of ADR. Just mix it, and it becomes 1 in 30,000, and give proper time to become decongested, because the half-life of ADR is 5 to 10 minutes, and it will take almost 50 to 20 minutes to become very effective and very decongested your covering. So after that, you need to have ADR packing for 20 minutes, and then you will be very good about your canal. So beginning to advance, anybody using endoscope in office procedure like otoscopy, and since last 25 years, the YouTube and the CT scan and the endoscope, the training become most easy, and you can train with the YouTube also, seeing videos and joining the courses, and start with simple procedure like wax removal, meringotomy, and just to just see the pathology first, mustard cavity, and and then maringoplasty. Type 1 maringoplasty should be before doing anterior perforation. The canal should be wide. And if you're choosing endoscopic ear surgery, left ear should be started first, because the crossing over the instrument should be avoided, because you have less space. So if you are going with the left ear, your endoscope will be superior, and you will be just approaching inferior, and your instrumentation will be most easy. So after maringoplasty, looking to the microscopic transcanal tympanoplasty, looking to the mustard cavity after. And raising of tympanomeatal flap is very, very important here, because actually the typical the incision is like a curvilinear or S-shape incision. When you do S-shape incision, I think in difficult situation where incus or malleus or incus is fixed, you have to again raise the flap more anterior. So I think a very horizontal incision and a large flap will give you better advantage, mechanical advantage, that you can park the whole flap anteriorly, and there is no need to just give another hand to just always keeping the flap away away from your field. So, and then tympanoplasty and osculoplasty is next, because you need to have a more training for the osculoplasty and cholesteatoma surgery, and then a stapes surgery and glomus tumor and other, just Professor Sankar sir has given the beyond. So loss of 3D is basically is not going to I think solve, because if you using 3D image, I think you need to have more virtual than real. So microscope has no answer about the binocularity and the 3D visualization. You need to train yourself in this particular field of ear surgery. Image quality of foot plate. Foot plate image quality always having a problem with endoscope, because you need to have thicker foot plate and just a minor fixity of the foot plate. In that case, if you are not able to understand, then you will avenge the foot plate and there will be disastrous. So these are the challenges we need to know. And one-handed always putting prosthesis with one hand is again a challenge, because most of the time, if microscopic surgeon have seen many times that macroscopic surgeon is also putting the piston with one hand, because ideally it should be holding the incus, stabilization of the incus, and then put your piston with another hand. So these are the challenges with most of the time in a microscopic surgeon also. So bleeding is again a challenge if your blood is coming from superior and going down and your field is going. So need to prepare that. And regarding about the prosthesis is basically, if you are master, you can use any prosthesis. But for the beginners, prosthesis picking is very, very important. And that these are the pistons, where the costly pistons, and initially might be some more difficulty by choosing the piston. So this Teflon piston, you can tailor it, cut it in this way, and just go introduce your long length of the piston in the hole, and then push it entirely, and it will go very easily. So this tailored Teflon piston could be used for the beginners. And what could be the steps of reverse? What it mean reverse? Because most of the complication of a stapes surgery, either way, microscopic or endoscopic, it is out fracture of the foot plate. During out fracture of the suprastructure, the foot plate avulses. And if you are doing a stepidotomy, any method by laser or drill and anything, the very controlled way of doing a stepidotomy should be there. So I use a reverse for the last 1 or 2 years, because I did microscopic, I did classical, but I think the reverse stereotomy is the best way to start with, because this is the safest, I think, in any way. In sometimes when your foot plate and the area of working is not properly visible, then reverse could be not possible. But majority of time, reverse stereotomy is possible, and the 10 steps of reverse stereotomy is here. Local infiltration is always necessary, and raising a large tympanomeatal flap right from the 12 o'clock to 6 o'clock. You can extend to the beyond the 12 o'clock and beyond the 6 o'clock. And then curate of scutum. Scutum curating is slightly lesser in endoscope. So you need to have a very sharp curate for that. And because of, and choosing the patient is very important. Ladies with wide canal, because you need to have
Sanjeev, we are having 1 minute more.
Yeah, you need to have a less pressure over the bone. Bone should be soft. Measurement of required piston before doing anything, a stepidotomy, and graduated stepidotomy we require. Placement of prosthesis is very important, and then separate IS joint, and you can remove the suprastructure after cutting the stapedial tendon, and crimping of prosthesis is last, and then replacing the tympanomeatal. So this is a very short video. I'm just about the reverse. Oh, sorry. And most of the time we have media is unavailable. Chal nahi raha ji. Source is not identified. So I think, yeah, folder नहीं है, इसी में हम insert किए थे. Oh, source is, yeah, actually. Yeah? No, I don't have original video. अरे नहीं, ये एक पेन ड्राइव में ही सारा था, वो चल ही रहा था, दूसरे लैपटॉप पे भी चल रहा था. अरे नहीं बॉस, सॉरी, मेरे पास ये वीडियो नहीं अभी अवेलेबल हो सकता है, सॉरी.
पेन ड्राइव का
ओरिजिनल फाइल नहीं है ओरिजिनल फाइल.
नहीं कैसे होगा?
नहीं आएगा ना?
नहीं आ जाएगा.
नहीं सर, कॉपी की हुई ओरिजिनल फाइल नहीं है, इसकी सॉफ्ट कॉपी भी नहीं है.
सॉफ्ट कॉपी नहीं है?
नहीं है.
पेन ड्राइव कहाँ तुम्हारा?
सोशल मीडिया माय साइट. Thank you very much. Thank you, sir.
Thank
Any
you,
questions,
Sanjeev.
any query, please?
It was a very nice presentation, especially for the beginners or who are newest to the endoscopic ear surgery.
Yes, sir.
Your levels of difficulty and levels of acquiring the learning curve or reaching the learning curve was very good. Thank you. It was a nice presentation.
Thank you, sir. Thank you very much, sir.
Now I invite Dr. Rishabh Jain for the endoscopic ear surgery. Where is the limit?
Very good morning. I'm Dr. Rishabh. I'm also part of the organizing committee here, so I welcome you all for this wonderful academic feast here. I would like to say thanks to the chairpersons for inviting me. So since we have seen Professor Shankar sir's and Dr. Sanjeev sir's presentation, we'll know a little bit about the endoscopic ear surgery and where we have reached now. Now, let's discuss something about where is the limit. Means, if there is something new coming in the in technology or in procedures, there is always a limit. Means those limits can be changed with time, But in today's scenario, we see that there is a limit to it. And to me, into my personal experience, what are the limits? So myself, Dr. Rishabh Jain, I'm director at Siddham ENT Hospital, Jaipur. So endoscope, where we stand today. So in my opinion, still we are in a learning and transition phase. Still we are debating endoscopic versus microscopic surgery. Okay, there are proponents for both the cases. It's not acceptable to all, and it's understandable. So to me, if I see the history, means when we were residents, when we were students in the MBBS, the same scenario happened with the laparoscopic surgeries. So people were doing open cholecystectomy. When laparoscopes come, they rejected it outrightly. But today, we see laparoscopic cholecystectomy is the minimum basic procedure. No one does the open surgery. Same thing for the sinus surgeries. Initially, there were limitations for the endoscopic sinus surgeries. Everybody said inverted papillomas, malignancies, or bigger tumors or CSF leaks can't be done with these things. Nowadays, it's a routine procedure. So we believe the same thing will happen with the endoscopic ear surgery also. This is the future. So I would like to quote this quote. So I'm not going to limit myself just because people won't accept the fact that I can do something else. Now, why to choose endoscopic ear surgery? Sir has always already explained it. So it has good exposure, wide-angled view, direct access to the hidden areas, a great magnification you can have, and the image quality is absolutely unmatchable. But if we see, everything has its limit, as I said. An iron ore cannot be educated into a gold. That's a quote by Mark Twain. So let's come to what are the limits, in my opinion, for the endoscopic ear surgeries. So we broadly divide it into two types of limits. It's a general limit or it's a procedure-related limits. So if we come to the general limits, as Sir said this, right now, so there is a bidimensional image. Now, in my opinion, again, the general limits are not absolute limits. These can be overcome with the training. The same thing happens with the bidimensional image you have. It can overcome with the experience by understanding of depth and by changing the viewpoint during movements of endoscope and instruments. So it's just related to the learning curve, okay? And also means if you want to do also this thing, though I have not used, but we have seen that the 3D cameras are also available now. We don't know how it will go for the endoscopic ear surgeries, but people have started using in the sinus surgeries. Another general limit, as I said, one-handed surgical technique. Again, means if we ask about the scenario 10 years back, the endoscope, we were not so tuned to hold the endoscope. Means the endoscopic sinus, there were not many proponents of doing the endoscopic sinus surgery. Nowadays, everyone knows how to do endoscopic sinus surgery, and we are doing it with a single hand always. So we are tuned to that thing. It's just the thought of our mind. We have a blockade in our mind that we can't do it with in the case of ear. Okay, that's the same sites we are operating. So it's just again can be overcome by the surgical experience. Then we have few things called the endoscope holders here also. Nowadays, which are available. If you want to go for the two-handed technique, you can use that. Particularly in the areas, I usually prefer them in the areas, as Sir said, for the advanced procedures. When you are going to the inner ear and you need a suction as well as cortis simultaneously, then you can use it. But again, to avoid these things, we have endoscopic ear surgery instruments also available nowadays, which have attached suction to them. So that can also be overcome with that thing also. So it's not a limit in my opinion. The Sir just explained bleeding. So bleeding again means it can be controlled by surgical experience or by the preparation of the patient. That's the said. Infiltrate properly. When you are using the flaps, use adrenaline cottonoids, it can be controlled. And if you are doing it under general anesthesia, then you can have an hypotensive anesthesia also, that also controls the bleeding, as we do in the sinus surgeries. And again, for the bleeding, as I said, means you can have the instruments with suction channels with you. That's not a limit. So in my opinion, there is general limits are the limits related to the training and your thinking. So if you overcome of this, if you start doing it endoscopic surgeries, these are not the limits as such. So what are the limits exactly? So let's come to the limits related to the procedures. We'll come by areas. So let's see in the external auditory canal. The easiest procedures we used to see and can be done with endoscopes also. But as in the sinus surgery, if you have a DNS very anteriorly or the columella is deviated, you can't do the endoscopic septoplasty. You have to go to the conventional one. Similarly, in the ear also, if there is a lesion which is at the junction of cartilage and bony part, you can't hold you don't get the support to hold the endoscope. So to me, that's a limit in cases of external auditory canal procedures. Or if there is a very huge osteoma or something like that, you don't get a space, in that cases also, I see it's a limit. In cases of tympanoplasty, to me, as such, it's not a limit. You can do tympanoplasty in any case. Means whatever the external auditory canal bulge is there, you can do the tympanoplasty. But though I don't do overlay technique, but in the literature we see, if you are a proponent of overlay technique for tympanoplasty, then endoscopic tympanoplasty is a difficult procedure to do. Because removing everything and suctioning continuously, it's a difficult job. So it is difficult, but again, it's not a limit as such. So to me, the limit starts coming when you are doing a cholesteatoma surgery, an endoscopic ear surgery. So again, it's a routine for us to do a cholesteatoma surgery, but we found it difficult in certain cases. We have our own recurrences also, means we have our own failures also, and when we learned where it is. So the most important thing is extension of pathology. If your pathology is going up to the tip of the mastoid, and then in that case, though again you can remove the disease completely, dealing a lot of things, but needs a lot of labor. Then comes degree of pneumatization. An sclerosed mastoid is very easy to do with endoscopic. But very highly pneumatized mastoid, it's difficult. And when you have a combination of both, you have an extensive surgery and then pneumatized mastoid, then I usually say no to the endoscopic surgery, because that case will drain a lot of energy from my side. So it's better to do an open surgery in those cases. Another limit for me, if you have a disease in continuity, then it's easy to remove it with the endoscope. But if you have a multifocal disease, multiple cells are involved and they have a cholesteatoma in them, you can see that on CT scan, then again to me it's a limit. Means it's difficult to do endoscopic surgery in those cases again. Similarly, if you have a very deep sinus tympani, we say type C sinus tympani, which is involved by the disease. In again those cases, it's difficult because you can't really go there beyond the facial nerve, and it's difficult to take out the disease. You have to go for the facial approach in that thing. So that's one case where I see it's an absolute indication for me. Another few cases, if you go, means if you have a complicated cholesteatoma surgery, suppose. In those cases, though it is debatable nowadays whether you should do, means you can do endoscopic ear surgery, but there are few instances, few conditions where I think endoscopic ear surgery should not be done. One is semicircular canal fistula. Now, in that case, again, if the fistula is in the anterior part of the semicircular canal, lateral semicircular canal, then you can reach endoscopically very well, and you can repair it also there. Expose the disease. But if it's in the posterior part, or if it's involving the posterior or superior semicircular canals, then it's difficult. Okay, so that's a limit for me. Similarly, if there is a defect in tegment tympani or there is an active CSF leak, sir just showed a CSF leak repair endoscopically, or I think that was a gusher repair, sir showed to it. But if this is an active gusher, very fast fluid is coming out, high pressure leaks are there. In those cases, again, it's difficult to get it done with the endoscopes, particularly when if you are doing a single-handed technique. So these are again, a small tegment defect that can be repaired easily with the endoscopes. But if there is a large tegment defect, or if there is an herniation, there is a meningocele or meningomyelocele or encephaloceles are there, again, it's difficult to do with the endoscopes at now. Now, these things we are doing the endoscopes in the sinus surgeries. But in ear, the space is again very low, so sometimes it becomes very difficult. So again, it can be challenged means means in the future we can have means something like that, and we can find out the areas where we can do all these procedures endoscopically. But in today's scenario, and at least for me, and the literature also supports it, for many of us, it's a limited basically, and we prefer the microscopic surgery in those cases. And we always remember these things. If suppose we are doing some endoscopic surgery and accidentally we found a leak or we made a leak, and that's a high pressure leak which we can't repair endoscopically, you can always convert to a microscopic approach. Don't hesitate in converting to a microscopic approach. For stapes surgery, as Sir said, there are limitations, but for me as such, means I'm doing the stapes surgery and Sir is also doing it for the last few years. To us, it's not a limitation. And this is even the easiest way, and this is the most convenient way to convert a microscopic surgeon to the endoscopic surgery. Because the limitation what you see is one-handed technique, mostly. In stapes surgery, we are tuned to do it one-handed technique. We are always taught to do it transcanal. Means I am trained at PGI Chandigarh. At PGI, when I just suggested to my teacher, my sir, Professor Panda sir, once, sir, I am having difficulty doing it transcanal, so can I open I do it posteriorly also? Sir ने मुझे बस थप्पड़ ही नहीं मारा, बाकी सब कुछ कहा. Stapes should be done transcanal only. This was the teaching we taught. This is how we were taught. So and that's how we started the endoscopic also. Since you can do it endoscopic single-handed surgery, few of us were doing transcanal tympanoplasty also. Few of us are trained for that thing also. So why not endoscopic? So for me, an stapes surgery, there is no limitation. You are doing it in one-handed technique. We were controlling the bleeding at that time also. We were doing suction at that time also. We were managing any complications as a gusher or with single-handed at that time also. So we can manage with endoscope also, and it's better. As Sir said, the vision with the endoscope as compared to the microscope transcanal means you can't compare them. So that's how I say there is no limit for me in the stapes surgery. So let's go to the skull-based surgeries. Means I don't have as much exposure as Sir has taught us. Basically, we have very few cases we did with endoscopic skull-based surgery. So I took them mainly from the literature, what is available in the literature right now. So mostly right now these are combined procedures. Total endoscopic lateral skull-based surgery is a rare still in today's scenario. So there is an integration of classical microscopic and endoscopic approach. This is steadily growing, because you have more chances of preserving the vital structures, you have better vision sometimes. Then, means for facial nerve preservation, again, it's a very good approach, means if you combine both of them. Exclusive endoscopic approaches, they include, like Sir has said, infracochlear approach or suprageniculate routes are there, means you can use them again, but there's a limited indication for these things. And the patient, again, as patient population for these types of procedures is again very low right now. So in the inner ear and CP angle, again, for me, it's a mostly combined procedure. And means if you go for the endoscopy, Sir has also said, transpromontorial approach, which is usually done. Again, for the limited cases, because you know that there will be a hearing loss to the permanent hearing loss to the patient is going to be there. So means here it has to be the lesion which is already caused a damage to the inner ear. In those cases, you can go directly in these approaches. So, but these are growing, means this is the area which is still growing. And if you go for these procedures directly, it's mainly combined approach which is being used. Otherwise, we usually prefer, in our center also, we usually prefer only microscopic approaches for these types of procedures. So that's our team, sir, which we are doing here at Siddham ENT Hospital. Since we are running short of time already, we are behind the schedule. I would like to close my end. Thanks for the patience listening. Yes, sir. Yes, sir, sure.
They are still same.
Yeah, I agree, sir.
Last 50 years. And even we know the birthplace of cholesteatoma is mesotympanoid.
I agree.
So the control of mesotympanoid with endoscope is much better than the microscope. So if I think the recurrence of cholesteatoma with endoscope is even lesser than the recurrence of cholesteatoma with microscope. So again, the combined approach for the cholestoma surgery is the best way to go.
Yeah, I agree. Means as I said, it's combined approach.
You can't avoid endoscope in ear surgery, but you can avoid macroscope in ear surgery in that sense.
Okay, thank you, sir. It was a nice presentation. It began with justifying the otoendoscopy and trying to clear the clouds of prejudice against otoendoscopy and the practical limitations of endoscopy. Thank you, sir, and your personal limitations also were in time. Thank you for
Thank you.
Now I welcome Dr. B.N. Gupta, sir. He is the fourth or last invite lecture of today's session. He is be speaking about stapedectomy while laser.
I'll be talking on stapedectomy via laser. Why laser should be used for this stapedectomy procedures. See, I am doing laser stapedectomy without laser since more than 35 years. Earlier picks and perforators, then skeeter. Now since 2016 I am using laser. And more than 350 cases have been operated by me in last 5-6 years, 7 years. And personally I feel that laser is very essential for the stapes surgery. Stapes surgery is the most technical and demanding surgery, and expectation of the patient is to be fulfilled by doing perfect job. It is the most effective operation and that should be performed with full confidence, provided the surgeon has acquired the skill as well as the proper instrumentation. Stapes is a very delicate bone. And for such a delicate bone, using conventional technique of surgery by using picks and perforator is quite crude, risky and traumatic. Now since last few years, skeeter has come into the market and the surgery by skeeter has become a little bit less traumatic than the conventional technique. Laser is a new tool for stapes surgery by which the surgery has become very much safe. There are two steps in the stapes surgery which are very important. Other steps are equally important, but these two steps are very, very important. Number one is removal of the stapes superstructure, and number two is making a proper fenestra in the stapes footplate. Fracturing the crura of the stapes by the pressure of the right angle hook is a very crude procedure, and it may cause complete removal of the stapes in toto. Now this is the video showing, this is my own video. Long back I attempted removal of stapes superstructure and the whole stapes came out. And this is very, very dangerous and this can lead to the dead ear. Similarly, while making the fenestra in the stapes footplate by using picks and perforator, it exerts a lot of pressure over the stapes footplate. And it can cause subluxation of the stapes if your perforator or pick is not very sharp, or it may cause floating footplate. This is the floating footplate that is to be tackled. To avoid all these problems, laser is the most important tool. This is the most suitable tool. Excellent hearing results, less vertigo after the surgery, and a shorter hospital stay. This is not only used for primary surgery, but it is very much useful for revision surgery. What are the advantages of laser? I'll just discuss in short. Laser is found to be very safe for the vestibule, and most of its energy is used in vaporizing the bone of the stapes footplate. Laser energy becomes very, very less by the time it reaches the saccule. Hence, not very much disturbing the inner ear. With the laser, a precise fenestra is made in the stapes foot plate without handling it mechanically. There is no trauma. As you are not handling the stapes, you are not touching the stapes, there is no trauma to the inner ear and no post-op vertigo and sensory nerve hearing loss. There is no chance of getting floating foot plate. And there is a good hemostasis. If the area is bleeding, you can achieve with the laser in coagulation mode. This is a laser machine. In early otosclerosis, where there is a minimal fixation of the stapes foot plate, the airborne gap is less than 30 decibel. Surgery by using picks and perforator is quite risky, and it is very much traumatic. There are high chances of stapes getting mobilized. There are high chances of removal of stapes in toto while fracturing the crura. And there are high chances of getting floating foot plate while making the fenestra. Laser is an ideal tool for these patients to avoid all these complications. And similarly, laser is very much useful for biscuit foot plate. Here the foot plate is thicker, but the margins are very weak. This is a video. This is again an endometrial incision. This is through microscope. TM flap has been elevated. The sufficient overhang has to be removed for the better exposure. Now I'm using CO2 laser. The posterior, this is stapedius tendon is cut by using CO2 laser. Then the posterior crura has been cut. 2 or 3 shots may be required. The incudostapedial joint is separated gently by using sharp right angle hook, and the stapes superstructure is removed. At times we can visualize the anterior crura also, that also can be laserized. Now this is a early fixation of the foot plate. If you make an attempt to perforate the foot plate by using pick or perforator, you may land up with a floating foot plate. The laser is the ideal tool here. The middle third of the stapes foot plate. This is the inferior most part of the stapes foot plate. This is the middle third, which is very safe. A 0.6 millimeter fenestra has been made. Now see that this is a discrete fenestra. A proper size piston is to be used. And the length of the piston is to be confirmed by doing hanging and bending test. This is again laser stapedectomy. Here the foot plate was very thick. Hence the micro drill, that is skeeter and laser, both are required here. This is again an endometrial incision. Sufficient overhang has been removed. This is the skeeter of 0.6 millimeter. A gentle drilling of the foot plate is done. The complete foot plate is to be thinned out. It should not be like a tunnel. The complete foot plate has been thinned out. They should be saucerized. It should be blue lined. Once the foot plate is blue lined, you can make the fenestra. It should be very gentle drilling with the intermittent pause. There should not be any hitting of the bone. Now this foot plate has been blue lined. Now I can make the fenestra by using laser in that. Fenestra is to be made and put the piston. Now see the bleeding part. There are many times the foot plate area bleeds quite a lot. The foot plate area is, the mucosa is very much hypertrophied, very much congested. The moment you touch it, it starts bleeding. This is a similar type of patient. The moment you pack the area with the gel foam, its bleeding stops. Again you touch that area, bleeding starts again. In this situation, laser is wonderful. You use the laser in coagulation mode. This is the coagulation mode of the CO2 laser, and coagulate all the blood vessels. Here, cautery, you cannot use the cautery here because that is very much dangerous. It raises the temperature, you may land up with a facial nerve palsy. Laser is very safe here. All multiple bleeding points have been coagulated. Then this is again a very thick foot plate. Again the bleeding started from this is a bleeding from the otosclerotic focus itself. Then the superstructure has been removed. Then all bleeding points have been coagulated. Then procedure was completed without any events. This is the beauty of laser. The foot plate has been saucerized. Then fenestra is made by using CO2 laser, and proper size piston is to be placed. This is a 0.6 mm fenestra, 0.4 mm piston. This is a very interesting case of revision stapedectomy. This patient was operated elsewhere around 6 months back before I opened it. The previous surgeon removed the stapes superstructure, but while fracturing the stapes foot plate, while making the fenestra, the foot plate got fractured. And part of the foot plate has entered the vestibule. This is depressed foot plate, I should call. I opened this here after 6 months after the previous surgery. Now this is under higher magnification. If you attempt to remove this part of the foot plate, you may land up with the dead ear, because this is very much in the vestibule, and it will definitely damage the saccule. This foot plate is to be, again, a fenestra is to be made by using CO2 laser. For revision cases, this laser is wonderful. It gives a lot of confidence to the surgeon. All adhesions you can break with the laser. Okay. 2 minutes more. Oh, yeah. Now this fenestra has been made, and proper size piston is to be placed. This is one more case. This is again a revision surgery. This the patient was operated somewhere else, and when the patient came to me, there was a persistent conductive hearing loss after surgery. The patient says there was some improvement after surgery. Then she had persistent conductive deafness. When I opened here, this is the end oral incision I took here. The piston was seen. There was insufficient exposure of the stapes foot plate. The piston is seen there, which is over the incus, but the lower end of the piston is not in the stapes area. It is very much on the promontory. There was insufficient exposure. The posterior superior curettage has been done. The stapes foot plate has been exposed, and this piston is removed. This is again a very thick foot plate. That is again to be drilled out by using skeeter. There was some bleeding here, which was controlled by packing the area with the gel foam. You can coagulate these bleeders by using CO2 laser. The laser gives you confidence of handling all possible situations. Again, this is to be saucerized, what I did in the previous case, and again the fenestra is to be made by using CO2 laser. As such, laser is very safe. The bone of the fallopian canal is much more thicker than the foot plate. Even then, due care should always be taken not to expose the facial nerve to the laser beam, especially when it is dehiscent. See the situation here. This is the dehiscent fascia in touch with the stapes. Here you cannot use the laser. The microdrill what skeeter was used for this surgery. This is very old, almost more than 25 years back I operated this patient. The superstructure has been drilled out by using skeeter. The superstructure has been removed. This is the descent facial. You have to be very careful. By the way, if you damage this facial, the patient will be in trouble. Distance has been measured,
Sir,
then proper size fenestra has been made, and as I already said, this CO2 laser is very safe for the vestibule.
Sir?
And laser beam becomes very inactive by the time it reaches the inner ear. And most of its energy is used in vaporizing the bone of the stapes foot plate. There are 2 slides more. Laser is little bit cumbersome, and the most important disadvantage is very expensive now. It has become more than 1.5 CR now, and it is very costly to maintain. Every year they take 5 lakhs rupees to maintain the laser machine. It has made the life of the surgeon very comfortable and it has improved the hearing results. Laser is really very useful. More than 350 cases have been operated, and most of the difficult situations have been handled by the laser, which otherwise could not have been handled. Excellent hearing results, less vertigo, shorter hospital stay, almost a day care procedure. Thank you.
Thank you,
See,
sir.
one more, before closing, I just want to inform you, there is one book written by me. This is a book published in January this year only, January 22. This is an approach to successful stapedectomy. This book has been published by Thime, and they requested us, all of us, to visit their stall, some D25 stall. And this book is available in the stall at the concessional rates. Thanks a lot. Thank you.
Thank you, sir. Thank you for demonstrating the indications of laser for this age-old surgery. So with this, we are ending this session. I thank all the invited guest lecturers for enlightening us on this specified topic. So the way forward is, the catchword is symbiosis rather than versus. It is symbiosis between endo and micro, or symbiosis between conventional and laser for stapedectomy.
Okay.
Thank you.
Thank you.
Photograph and the felicitation.
Okay. Then I'm waiting for my co-chairperson. She has just left her bag somewhere, went for searching. Let us wait for a few minutes. This Aoicon 23. We have 3 very good speakers, renowned speakers. They have been invited for talks, and please stick to time, that is 15 minutes. I know the post-lunch session is a bit difficult, that's why the audience is less. but then we have to continue with this. So I request the first speaker, Dr. Anjani Kumar Sharma, to please come and give his talk.
Good afternoon. Today we will talk about follicular variant of papillary carcinoma of thyroid. I am Dr. Anjani Kumar Sharma. I am Associate Professor at Department of ENT and Head Neck Surgery at SMS Hospital, Jaipur. So, cancer always require adequate and good treatment. Sometimes it may be overdue, sometimes it may be underdue. So in head and neck cancer, there are many tumors we are going to be overdue. So we should identify those tumors and we should do adequate treatment for those tumors. So the planning for extent of differentiated thyroid cancer is very important. It's a very challenging job. So in this presentation, we will discuss about the differentiated thyroid cancers. So differentiated thyroid cancer is one of the commonest malignancies in head and neck region. Among differentiated thyroid carcinoma, papillary carcinoma is the commonest. Papillary carcinoma is categorized in 3 subtypes. It is well differentiated. Subclassification is classical type, encapsulated, follicular variant, cystic, and microscopic type. In worrisome differentiated type, these are tall cell, columnar cell, diffuse sclerosing, oncocytic, and insular type. And the third one is poorly differentiated. So the classical variant of papillary thyroid carcinoma is the most common type of thyroid cancer. The second most common subtype is follicular variant. It comprises around 5 to 41% of PTC. These are 2 types. One is encapsulated and the second one is invasive type. Both the varieties are different in histological feature and behavior. So we reviewed a lot of studies and we found out that follicular variant of papillary carcinoma had more indolent behavior and likely a genetically distinct entity from classical papillary carcinoma thyroid. So they are little bit different from classical type of papillary carcinoma. So in follicular variant of papillary carcinoma, this variant behaves between benign and malignant disease. It's difficult to distinguish cytologically from follicular adenoma and classical PTC. So this is something between follicular adenoma and the classical papillary thyroid carcinomas. So this encapsulated follicular variant has the features of follicular adenoma and classical PTC. In follicular variant PTC, the follicular architecture is same like follicular adenoma. It is well encapsulated and shows RAS mutation. These all 3 features are follicular adenoma. The cytological features, behave like nuclear features are same in follicular variant of PTC and classical PTC. But it is different from classical PTC in some features. In classical PTC, it shows psammoma bodies, tumor necrosis, high mitotic rate, true papillas are more than 1%, and it shows BRAF mutation. So it is something different from classical PTC. So these are the 3 variants. One is papillary carcinoma, classical type. The second one is follicular variant, and the third one is follicular adenoma. The growth pattern is papillary. In papillary carcinoma, nuclear features of PTC present. It shows BRAF mutation. In follicular variant, the growth pattern is follicular. Nuclear features are same as classical PTC, and it shows RAS mutation. And the third one is follicular adenoma. It's a benign tumor. It shows growth pattern is follicular. Nuclear pattern of PTC are absent, and it shows RAS mutation. So the new diagnostic criteria for follicular variants are these. It is well encapsulated tumor with clear demarcation.
It shows follicular growth pattern with nuclear features of classical type. It is less than 1% papillae, no psammoma bodies, less than 30% of solid pattern. Nuclear score is between 2 to 3, no vascular or capsular invasion, no tumor necrosis, or no high mitotic activity seen in follicular variant of papillary carcinoma. So this tumor comprises between follicular adenoma and classical papillary thyroid carcinoma. So it's an indolent tumor. So in real terms, is total thyroidectomy is really required for these encapsulated tumors? So we did a study in SMS hospital. Our study aimed to evaluate bilateral incidence of malignant disease in this group to assess whether hemithyroidectomy or total thyroidectomy is required for complete cure of disease. We did prospective study to evaluate thyroid cancer patients on multiple aspects, but we retrospectively collected data of follicular variant of PTC. We followed all the guidelines by AJCC, whether hemithyroidectomy, total thyroidectomy, or completion thyroidectomy has to be performed for these patients. So we operated around 692 patients for thyroid disease. 256 patient was malignant one. Out of 256, 199 patient was diagnosed as papillary carcinoma. Around 30% patient related to follicular variant of papillary carcinoma. The number was 69. It was around 59 patient was encapsulated and 10 patient was invasive type of follicular variant of papillary carcinoma. So we divided all these 59 patients in 3 categories according to the size of primary tumor. The less than 4 centimeter tumor, 4 to 6 and more than 6. If the tumor is more than 4 centimeter, we did total thyroidectomy. If the tumor is less than 4 centimeter or unifocal, we did hemithyroidectomy. If the tumor is less than 4 or tumor is bilateral, then we did total thyroidectomy. So in 59 patients, we did 39 total thyroidectomies. And 20 patients undergo for hemithyroidectomy. So in these 39 patients, where we did total thyroidectomy, we did not find any malignant disease in opposite lobe. So the tumor was, whether it was size was more than 4, more than 6, more than 8. In all patients, we did not found any disease in opposite lobe. The disease was limited to unilateral lobe. And in the group of hemithyroidectomy, we regularly follow up these patients for more than 3 years, and we did not reveal any recurrence in the remaining thyroid tissue. So irrespective of size of tumor, it does not show multifocality. There was no bilateral involvement of thyroid. Hence, hemithyroidectomy is sufficient treatment for encapsulated follicular variant of papillary carcinoma. In invasive follicular variant of PTC, the number of patients was 10. We did total thyroidectomy. 3 patients had bilateral disease. So we recommend total thyroidectomy in this group. If there is an invasive follicular variant, we should go for total thyroidectomy. So we advocate some changes in the management line. Even there is some revision of nomenclature of these tumors also. They are called follicular variant of papillary thyroid carcinoma. It's a little bit confusing term. Sometimes it mimics like papillary carcinoma. So it also required the nomenclature revision for these tumors. There was in 2016 Endocrine Pathology Society, they took the cases from multiple institutes and reviewed the literature. And they gave new nomenclature to these tumors. So these tumors, the morphological features shows follicular growth. Nuclear features are like PTC, lack of invasion, clonal origin related shows it's a biological neoplasm, or there is a very low risk of adverse outcome. So these tumors, previously called encapsulated follicular variant of papillary thyroid carcinoma, now we are calling them non-invasive follicular thyroid neoplasm with papillary-like nuclear features. This is NIFTP. So the nomenclature has also changed. So in the present, with this new nomenclature, with the new treatment guidelines, there is a decreased use of radioactive iodine. There is we are not using completion thyroidectomy in these patients and related complications of surgery. So there is a decreased psychological burden. There is a avoided medical overtreatment, reduces expenses of the treatment. It reduces complication related to the bigger surgery. It reduces post-surgical consequences like permanent hypothyroidism, sometimes permanent hypocalcemia. There is a decreased need for long-term surveillance. There is a decreased overall cost of healthcare surveillance. And based on a US cost, alone RAI treatment, they are saving around 5,000 to 8,000 USD dollar per patient. If they are not using this RAI for patients, they are saving around 5,000 to 8,000 USD dollar. Or these are the numbers around 45,000 patients per year worldwide. So there the overall cost of this surgery is also reduced. So the take-home message for these tumors: encapsulated follicular variant of papillary thyroid carcinoma is no longer considered as a malignant lesion. The second thing, renamed as non-invasive follicular thyroid neoplasm with papillary-like nuclear features. We should avoid over-treatment for these tumors, and the hemithyroidectomy is the sufficient treatment. If we find out any size of tumor that is labeled as NIFTP, we should not do completion thyroidectomy. We should not go for any radioactive iodine treatment for these patients. So the hemithyroidectomy is the complete treatment for these patients. We should not do anything else for these patients. Thank you.
Would the audience like to ask any questions? How do you decide that this is a totally encapsulated tumor? Do you do the hemithyroidectomy, then do a frozen, and then decide, or how will you decide?
All these patients post-operatively, histopathologist labeled whether it is encapsulated or it is invasive.
So it's the decision to do a hemi is decided pre-operatively only?
Yes, we did hemithyroidectomy in the, if the size is less than 4 centimeter, for the Bethesda 2 to 5.
Okay.
If in the cases where the size was more than 4, we did total thyroidectomy. If there we find out it's an encapsulated tumor, then we regularly follow up those cases. So we didn't found any recurrence in the remaining thyroid lobe. Or if we did total thyroidectomy in the cases of more than 4 centimeter, we did not find out any multifocal disease. So it was limited to the single lobe of thyroid.
And do you all use frozen section at all?
Basically, madam, now we are using frozen sections, but they are not frozen, on the frozen section, the specificity is around 70%.
Yeah.
So we cannot rely completely on frozen section. We are deciding on post-operative histopathology report.
Okay, thank you very much.
It's entirely encapsulated, and it is a possibility that patient that tumor might come as an encapsulated case. So in that case, it goes like it's a little bit benign cases. Sometimes if we are having scan like CT scan, and if we see that the tumor is well defined and it's well encapsulated, so in that case, these pre-surgery inputs can lead us, this patient can go with the hemithyroidectomy and they can end up with the encapsulated sort of the things. But definitely, and frozen is also having high false positive and false negative rates. So that's why we also do not rely on frozen sections. So if we want some inputs, we can take this from scans and then only we can decide it.
Oh, thank you, Dr. Sarma, for your excellent talk. You have thrown light on that. Our next speaker is Dr. Mahendra Haja. Please.
A very good afternoon to all the delegates, chairperson. Myself, Mahen Singh Ada, and I'm associate in the Department of ENTSS Medical College, Jaipur. And first of all, I would like to thanks to the organizing team for giving me this opportunity to present this talk. and I would like to request all the delegates to enjoy the hospitality of Jaipur in this your stay at Jaipur. So with the permission of chairperson, I would like to start my talk. We are discussing to the salvage surgical treatment, especially in recurrence head neck cancers, and what is our experience in SM's Medical College Jaipur. So first of all, why we need to discuss this thing? Because in head neck cancer, if you're talking about the head neck cancer, the darkest point, or we can say the second darkest point is what we are dealing with, the recurrence and residual settings cancers. Basically, after palliative cases, these are the most the darkest part of the head neck cancer. And why we need to discuss this thing? Because as we know, all the patients of head neck malignancy, almost 2/3 patients present with the locoregional recurrences. And among them, 20-30% present with the distant metastasis. So this bulk, 2/3 of the patients which we are treating as a head neck malignancies are presenting us again with the recurrences in the form of the recurrence or residual cases. So these people are again giving us a burden because we are having primary burden of primary patients as well as secondary burden. And the prognosis of these patients are little bit poorer than as compared to the per primary cases. So that's why we have to arrange our resources so that we can deliver maximum to our population, to our community for the best of them. Okay. The 5-year survival of patient after salvage surgery is range from 10 to 40%. So what is salvage surgery and which is the factors which is influencing your salvage treatment, surgical treatment? If I am talking about the salvage surgical treatment, I mean it to the salvage surgical treatment with the curative intents. We are talking in terms of curative intent, not on palliative intents. So first and the most important factor is the tumor factor. What are the tumor factor? We'll discuss about what are sort of the patient we can go for the salvage surgical treatment. Second, we can go with the infrastructure, logistic or resources problems. And the third, which is the most important, the patient factor. And basically, it's not a patient factor, it is a family factor, because a patient is always associated with his family. It is attached with the economically, socially, and most importantly, emotionally. So you are treating to a patient, but actually you are treating to the family, entire family. Why we should go with the surgical treatment in such patients? First of all, as we see, like the system is changing little bit, and we are getting more young patients right now for the surgeries, and we know that these young patients are having long survival expectancy. So the patient might have long-term side effects of the whatever primary treatment we are giving to them, as well as whatever treatment we are using, we should keep, because such part of the treatment, for example, radiation, is such that there are single fire guns. So we should not fire this gun first. We should keep it reserved because our patient is young and is having long expectancy. Patient may recur, patient may have second primaries and all these things. So that's why we should try to do such things which can be repeated again and again. Sorry. Second is trismus and oral submucous fibrosis. Patient who has already been treated either in the form of surgery, either in the form of the radiation or in the combined treatment previously. Patient usually end up head neck malignancy. We are talking especially of squamous cell carcinoma of head neck malignancy. And if more precisely, we can case the oral cavity, because this is the maximum cases we are having in India. These patients are mostly presenting with the trismus and oral submucous fibrosis. And the best treatment for to relieve with the trismus and oral submucous fibrosis is the surgery in such patients. And certain tumor factors, for example, closed bone and cartilage disease or involved disease, we have to do surgery because there is nothing alternate of this thing. If we don't have surgery, then what is the other options and what is the factor which is affecting that we should not go with the salvage surgical treatment? That is the impairment of the function and the cosmosis. Most of the patients are very much concerned about their cosmosis and functionality. Even some people are like, if I can't speak, agar आवाज नहीं है तो साहब डॉक्टर साहब जीने का क्या मतलब हुआ? So these are the some excuses presented by the patient, and you need to counsel the patient that voice, life is more important as compared to the voice and all these things. Even in patients with, in terms of, if we talk about in terms of the tongue malignancies or larynx malignancy. So that's why we have to counsel the patient what is the need. Second is technically difficulty or associated morbidity. Each and every treatment is having his own morbidity associated with this thing. So we should always count this thing. We should always counsel the patient about this thing. Sometimes patient refuse itself for the surgery. We don't want surgery. And sometimes patient is having high risk factor in the form of like medical and all these things. The patient is not fit for surgery. In such cases, we should go with surgery. Now, it comes, we discuss about the what patient factors which lead us to go for the surgical treatment or not. First is the performance of the patient. Performance is the general condition of the patient, because it is might a possibility that a 70-year-old male can tolerate a treatment, but a 40-year boy cannot tolerate the treatment. There is a possibility is always there. So there is a GC or performance status of the patient should be quite enough to tolerate the patient, because if you are giving him best treatment, but patient is not able to complete the treatment, there is no use of such treatment. You should give him even a average treatment, but if patient is able to complete this treatment, that is a beneficial for this thing. So you should calculate the performance status or GC, whether the patient is able to tolerate the treatment or not. Second, especially in Indian cases, it is very important because financial aspect is very important for the patient, because some patient default just because of they are not having good financial support. So you should counsel the patient that what is the expected expenditure they are going to have in this treatment part. If it is he is not able to this thing, you can suggest them to contact to some NGOs and some aiding agencies and all these things so they can complete their treatment. After that, there are some other issues like what is patient's priority with their treatment, what they want, what is their future expectation with the treatment. And in Indian context, most of the patient, especially of the rural patients, that what is the quality of life their treatment. So basically, these all are the points we should discuss with the patient, and we should sit with the patient and counsel the patient personally. If you can sit with once, twice, thrice, whatever it is, but at least you should sit with the patient and you should counsel the patient, because it's very important. Counseling is very important. You should explain the patient entire spectrum of your treatment. What is the possible outcomes? What is the possible good outcome? And what is the possible bad outcomes? Because good outcomes is always welcome, but the bad outcomes, patient is not always ready to this thing. So performance status. This is a sense of patient's physical well-being, physical as well as mental. Education useful for treatment modality should be there, and adjustment of intensity of doses of the treatment. Here the doses means in terms of surgery, your extensiveness of your surgery you should decide according to the patient. What is performance status and how much extensive surgery he can tolerate. These are the scoring system. Now, if we talk about the tumor factors which are affecting to our salvage surgical treatment, we should first define disease-free interval. As we all know, patient who is recurred within 1 year primary treatment, they are doing bad, very bad, as compared to the patient who is recurring more than 1 year. So that's why patient is recurring, recurrence time is also very important. It is important in terms of as well as like patient, whatever primary treatment patient has received prior. So your head neck bed is ready to accommodate or to tolerate the second treatment is ready or not ready. So as time goes long, your patient's, your surgical bed or your head neck bed is ready to tolerate the second treatment in form of either surgical or non-surgical treatment. Biology of disease, it is very important. You should go, because upfront recurrence cases you don't know the biology, you just know the biopsy, and biopsy you know only it's a well differentiated, moderate differentiated or poorly differentiated. But previous surgery biopsy you can review and you can go through that, so that can give you a clue what is the high risk factor patient had that time and how badly he can behave in this time. Field cancellation is again a field where you can, because when you are dealing with a single site, there is a possibility patient may develop something on the other side also, opposite side, second primary, and because of field cancellation. So it may alter your treatment plan, because organ specific treatment you can convert to your program into the like generalized treatment sort of thing. Site, stage and extent is very important. What is the patient is presenting right now, in what stage and extent of the disease. Now, the last one is the resource factors. So first of all, what is your team skill and experience is there. It is very important whether you are your team is skilled for the dealing such cases, because these patients are, they are emotional patients, because they demand so much things that I am having this thing, I am having this thing. You have to counsel very patiently in such patients. Okay, so that's why your skill and experience in dealing tumor as well as to the patient, such patients, recurrence patients. What the waiting list you are having in your institutes, For example, if you are having a long list of per premium cases, so you can't afford to spend your valuable resources to dealing with this recurrent setting, because they are anyhow having poor prognosis compared to the per premium cases. So you have to deal with this thing also. Your infrastructures, your resources. What is non-surgical options we are having? It is just because we all are surgeon here. It is just for your knowledge. It's like re-radiation in the form of either curative or palliative. And in systemic chemotherapy always is a palliative sort of thing, but it could be in form of targeted immunometronomic or palliative, single agent or multiple agent therapy. In our centers in SMS Medical College, like almost 650 cases we are having in our database. Almost 100% recurs, almost it is around 15% patient. Among them, recurrent cases was 61 and residual was 33% case, 33%. It is almost 15% in general. Most of the cases was buccal mucosa and tongue and neck recurrences. If you see the follow-up, we had a follow-up 6 months to the 4 year with a median follow-up of 2.1 year. Disease-specific death was 37.1% and disease-specific survival was 15 months in such patients. We are having such patient because such patient defaulted very easily. So you have a high defaulting rate in such patients. So like this patient who's having previous RT, having fistula, underwent the surgery, extensive surgery, then this patient had a distant metastasis after 15 months and he is not anymore right now. There are some extensive cases where we underwent. This is the post-CTRT patient. Is a young patient, is 25-year-old male, presented with the recurrence casing post-CTRT and underwent with the surgery, and he's doing quite well. It's almost 3.5 years since last surgery. This is again same thing. In dictum, in general, it is said that in recurrence or residual settings, we should not take the flap from the same surgical bed, especially in cases of the post-RT cases. But in certain cases, we can take liberty. There are some, exceptions are there. For example, in this case, this is the post-CTRT old lady. She is around 65-year-old lady. Had a labial carcinoma recurrence, underwent with the surgery, and Karapanji flap did very good. And she is doing right now very good, almost 29-month follow-up. This is again median foreplate reconstruction of such patients. This is malignant melanoma, locally recurrent cases, but it recurs again and again and again and again. So, like take-home message from this presentation is just for this thing. It's a teamwork, and your patient and his family is also part of your team. You should sit with their entire people. You should counsel them. You should tell the entire spectrum of your surgical treatment, expected outcome, expected good outcome, expected bad outcome. You should select appropriate modality and extent of your surgery and proper counseling. That is the last but very important thing. You should sit your patient and counseling, and never hesitate to put both the hand together and say no sometime, because sometime doing nothing is the best what you can do for your patient. Okay, thank you so much.
You are working in a tertiary stage,
Yes,
that is in the medical college. You must be getting a lot of referral patients from outside.
Yes, sir.
How much care you take at your hospital for those patients, because they require long stay?
Yeah,
Financially and of course from treatment point of view also.
Yeah, like we are working in SMS. SMS is one of the good institute of state. We are referring for patients from the other neighboring states also. But the things which we are facing has been faced by so many institutes of all over India, even regional centers and good institute. Even Tata is also facing the same thing, because they are all having a long waiting list. So that's why I said we should at least address if our per premium cases is waiting and we are consuming our resources and time into these recurrence settings. They are anyhow, they will poorly, their prognosis is poor. So we should not let them wait. So you have to triage your patient, and you have to, you have to talk and you have to sit, because long waiting list is a problem, and its problem is of every institute, and we are facing is very much.
What we find that primary cases, they are being dealt with at every level. But recurrence cases which are coming, तो लोग avoid करते ही नहीं छोड़ो इसको कौन झमेला ले.
Yeah, exactly. Most of the people who did they don't want to do it, they refer it to the higher center. And as being on higher center, you can't deny, but you can accommodate also. So then you have to sit them and you have to tell them that we are waiting list and we are waiting list this thing. Till then you will wait, you will definitely will be inoperable at that time. If you are having money issues, you can go to certain NGOs and certain agencies, they can aid to you and you can go to get it operated outside and wherever it is possible. So like you have to counsel your patient. Thank you.
Thank you, Dr. Hada,
Thank
for the excellent talk. Now I invite Dr. B. Srinivas for his talk, Spectrum of Hemangiomas in Head and Neck.
My pleasure to be in this beautiful pink and vibrant city. And my talk is also slightly related to beautiful colors. But in my talk, I think my heart rate will be a little high when I'm operating certain cases. So I am talking on vascular anomalies. That there is a change in nomenclature, vascular anomalies and hemangiomas, which I'll be going through my slides. So I'm talking on vascular anomalies in head and neck and its challenges. So there is hemangiomas and vascular anomalies. It's quite commonly seen, okay? And it is, the prevalence is seen to be about 4.5%. It is more common in white people, whereas Caucasians it is slightly less. And if you see the male and female ratio, the females' hemangiomas are more common in females, but if the vascular anomalies, the preponderance of gender is almost not much. The anomalies are usually diagnosed during infancy. And, excuse me one second. And the most, usually the common problem they present to us usually with psychological distress related to the disfigurement or maybe for cosmetic reasons, and sometimes because of functional defects because of many lesions affect the airway as well as the vision. If you come to history, there have been a lot of, doctors who have run through this case, and we had a lot of changes which happened over the years. Wardrop in 1818 first recognized this, and he differentiated malformation from hemangiomas. And it is nice to say that the first case of, either which was discovered was used on a case of a vascular malformation, and which show, based on so many things, they tried to classify it. Which show classified based on histopathology, and later based on the changes in behavior of the lesion or by the way it clinically presents. All these have been taken into account, and the recent classification is the one by the ISWA classification. ISWA classification is mainly based on cellular features, vascular flow characteristics, and clinical behavior. Vascular flow characteristics, usually we will pick it up on radiology. So we have to use a radiological for the purpose of this classification. It is very important to differentiate between vascular tumors and malformations because it helps in the treatment decisions. Okay, this is the classification. It's a beautiful classification. I think we are seeing most of the lesions here. They are classified into vascular tumors, vascular malformations, complex lymphatic anomalies, lymphedema, developmental anomalies of the named vessels. Very commonly we see all these benign lesions, usually the infantile hemangiomas, congenital hemangiomas. See, over this period, I told you about the nomenclature. We used to call hemangiomas, and even our pathologists also will give the diagnosis as hemangiomas, capillary hemangiomas, and cavernous hemangiomas. Now the terminology has slightly changed. Marker. It is now the fast flow, the AV malformation, venous malformation, portvein, they are all very common. The earlier what we used to call as capillary hemangioma, now we call it as a capillary malformation, and the cavernous hemangiomas are now we call it as a venous malformation. Okay, so these terminologies have slightly changed, and maybe sometimes it may be introduced by many pathologists. Okay, and how do we differentiate between a hemangioma or a malformation? So in hemangiomas or in a vascular tumor, usually there is an abnormal endothelial growth. It grows rapidly. And not only it grows rapidly, sometimes it will also, there is a spontaneous involution. So most of the time in children, even just wait and watch is enough because it involutes. And there is a recurrence is uncommon. In case of vascular, usually it is from the normal endothelial cell turnover, and they do not involute, and the recurrence is quite common. How do you approach to the patient with a vascular anomaly? Usually the history is taken, and apart from history, on clinical examination, most of the time it can be picked up on, superficial lesions can be picked up. But we need to evaluate, even apart from the local lesions, we need to evaluate the airway, we need to look at the vision, and sometimes we know that these have the tendency to have lesions elsewhere in the body, maybe in the liver or in the brain, there could be some vascular lesions. So we need to keep in, because some syndromes might be associated, and we have to evaluate the person as a whole sometimes. And imaging is the mainstay of the diagnosis. Doppler ultrasound can pick up all the superficial lesions. CT angiography and MRI is very commonly used. Dynamic contrast enhanced MRI will be the mainstay of this, because it can pick up not only the soft tissue lesion, but it can also pick up the flow voids, the feeding vessel or where the draining vessel, we can pick it up on enhancing MRI. Yes, we do some blood tests like IHC for RBC, glucose transporter 1, because this glucose transporter 1 will be able to differentiate between hemangiomas and vascular malformations. 97% of the patients with infantile hemangioma or congenital hemangioma will be positive. So it will be a good investigation to make sometimes when you have a problem with the decision making. And there are some genetic workup like RASA1 and PIK3CA, which we can do for a familial lesions like in vascular malformations and lymphangiomas respectively. Treatment options usually can be medical, sometimes it could be minimal invasive or a surgical. And when you want to treat the patient, sometimes when it might be well localized and it might be proliferating, or there might be ulceration or bleeding, or maybe could be obstructing the vision, or decrease in the vision, or sometimes facial features distortion. Medical management may include, sometimes in hemangiomas, it could include intralesional steroids and systemic steroids. Systemic steroids in children we try and avoid because of various things. It can form Cushing's syndromes, and it can form various skeletal deformities. And usually it was on the contrary, like when the person actually during the treatment for arrhythmias, he saw that by the use of propranolol, he saw a complete reduction in case of the hemangiomas, and propranolol came to use from that time. And propranolol is a very good medication. It can be used for about 1 to 6 months, but only thing is we need to keep caution. It may have some side effects. You have to evaluate the patient completely, because especially some complications like hypotension or bradycardia, all this we may need to keep in mind. Okay, so local hemangiomas can be surgically excised or sometimes be staged because in case if it is involving the lip. So complications, yes, sometimes it might be involved with, there might be consumptive coagulopathy, which can lead to some thrombocytopenias and then bleeding, and there might be infections because of the reduced immunity levels, and thrombosis and ulcerations can also happen because of the exposure externally. General complications, I said, maybe sometimes because of this conjunctive coagulopathy, it can lead to disseminated DIC, and then can cause CCF and also embolism. Capillary malformation, okay, this is what we telling in the AV malformation. This is again very commonly seen. You can see a pink spot on the face, and it can also be associated along the trigeminal supply. Okay, it is very superficial, and usually most of the time they will resolve it by itself. And in case needed, they may have to use a pulsed dye laser or a excise and use a local. We can use a split skin graft. Venous malformation, again, usually they are compressible, and again they are bluish, and it can increase in size on crying or when there is rise in pressure. Okay, and if you palpate, you can also see that there will be the presence of lipoliths, and the lipoliths can also be picked up on a CT scan sometimes, and most of the times. And the treatment option for venous malformations will be sclerotherapy and excision. And lymphatic malformation has a tendency to get infected and have the tendency to suddenly increase in size. So we may need to evaluate a little more cautiously when you're treating it. And sometimes the lymphatic malformation, I think they also grade it depending on supraoid and infraoid extensions and involvement of unilateral and bilateral. So depending on that, we can manage the lymphatic malformations. Again, surgical excision will be the treatment of choice. Sclerotherapy by OK432 is also used. Yes, AV malformations, again, it is, here there is nidus, which we have to be keep in mind. So it can appear as a red tumor, sometimes with rise in temperature, and then you can also feel that there is a pulsation, the bruit, thrill, all this can be present on palpation. The showing a staging is there for us to, sometimes we can, based on our management as well as the stage, we can decide on the extent of the lesion. It may be just a bluish skin lesion, or sometimes it can also extend to become it can lead to heart failure. A treatment for AV malformations, usually we can embolize and do surgical excision. I have few cases from our institute. It's a tertiary institute. I collected over the last 5 years, and I thought I can present some interesting cases for you. This is a 14-year-old girl who had a soft tissue lesion over the dorsum of the nose. It is soft and globular. And if you see the CT scan showed a serpentinous pattern of marked arterial phase enhancement with the feeder vessels, that is the facial and ophthalmic arteries here. You can see these vessels. And there is a persistence of contrast on delayed phase. There are various treatment options. What we did is we did the lateral rhinotomy, Morse incision, and we raised the flap. Only problem is thing, you should be very careful when you're raising the flap, because we thought we'll preserve the skin as it is the best dressing as we know. And this is 2 days post-operatively, there was some edema. And the histopathology was confirming that is the EVG strain, which is showing that dilated walls of the capillaries, and which is not picked up by the veins. Yeah, this is the post-op 6 months later. 6 months later, you can see this. I think this person, I think when she is happy, we are happy. High flow AV malformation. Again, this is another extensive large AV malformation. High flow, 26-year-old female, swelling on the left side of the face since 10 years, and there was a facial asymmetry with convexity to left. There was a swelling on the temporal area as well on the left side of the face and around the submandibular region also. MRI picked a high flow vascular malformation involving the deep spaces, a lot of extensive lesions. We did the embolization for this patient, and you can see there is an absence of the blush. Okay, this is an intra picture where we took the subtemporal and preauricular incision, and this is quite an extensive lesion. Here, there was a need for us to involve the interventional radiologist. We have to involve the plastic surgeon, okay? Because it was a quite extensive lesion, we may have to reconstruct it. So we did remove the mandible and the zygoma, and we were able to do the parotoidectomy, able to preserve the facial nerve all along our procedure, and we could remove the lesion in toto. And again, the plastic surgeons fixed it up with the mini plates, and they fixed up the zygoma also. Okay, this is the post-operative picture. This was actually taken almost 2 years. Just before I came, I asked for this picture. Okay, so she has got some mild facial palsy, but I think it's okay. Lymphatic malformation, again, this is a child, a 4-year-old child presenting with the swelling on the left side of the neck, 1 year, slowly progressive. The parents are very worried about this because they were really scared on seeing all the, meeting so many doctors. Well, it is a well circumscribed lesion, about 3 to 3 into 3.5 centimeters. It is displacing the carotid laterally, and the tonsil is also pushed medially and anteriorly, and it's just narrowed down the oropharyngeal space. So again, this is the extent of the lesion here. Yes, intraoperatively, we are able to remove the lesion in toto. We are able to also save the marginal. Yeah, there's a histopathology showing lymphoplasmacytic infiltration, okay, and spaces containing eosinophilic material. This I think capillary hemangioma, lobular capillary hemangioma. This is very commonly seen in our practice, and this is one most of the time postgraduates will see in the OPD, and they will manage it themselves. They'll give a local and then can do the excision. I just thought I want to include this also. So it is showing some lobules and few eosinophils. Venous malformation, again, this was actually misdiagnosed as a schwannoma. There was a lesion along the parotid, and when we opened it up, actually we could actually palpate it very superficially. So we did not go and remove the parotid. So when we are able to identify, and it was very clear, I mean, it has got well-defined margins, and we are able to take it out in total. So again, you have to, histopathology can show thin-walled vascular channels of very well-in calibers. Sometimes here again, we had another case which had a hemangioma of the face, and there was again another case, we use a flap to cover it. This again, septal hemangioma, which we do see regularly in our OPD, and most of the time I think postgraduates, they will be able to manage it themselves, giving some local anesthesia and cauterizing it. Sometimes in the orbit, again, we'll have sometimes if it is in the present in the orbit and causing some vision changes, then we may have to take our opinion from our ophthalmology colleagues. So they gave some intralesional steroids and are able to reduce the size of the lesion. Okay, vascular anomalies. So what I would like to say is, usually, sometimes it may be looking very simple, but still we like to evaluate the patient, keep the whole picture in view. We have changed some nomenclatures. I think it will be over a period of time. Our pathologists also will do that. And usually the choice is imaging, and management should be tailor-made, because sometimes we just wait and watch, sometimes just propranolol may help, sometimes even we may have to use multi-speciality management. And you always approach with caution, because there are sometimes it can also recur. Always do the counseling and give a guarded prognosis, because it may be, I think that is the in thing today. Thank you very much from St. John's Medical College.
Thank you, Dr. Srinivas. Any questions from the audience for Doctor?
Yeah.
Lymphatic malformation sometimes a very benign tumor, and if it is in kids, sometimes doing surgery itself is like end up with a muscle section, muscle trauma, as well as cranial weakness, for example.
Yeah.
So like sometimes it is my question, what do you think in such cases doing surgery is, it's little bit overdue to giving such morbidity to kids, facial weakness, pharyngeal palate is not working, like tongue is not working properly.
Usually they are well encapsulated, and it is well defined. And sometimes the problem, why I think if you compare with venous, I will suggest lymphatic malformations are better to be addressed surgically, because they have a tendency to suddenly increase in size, then they have a tendency to get infected, so, and they grow very rapidly most of the time.
Yeah, that's why, that is my question. Because it's a benign one, we can re-aspirate, and infection we can treat. But giving the morbidity of, in terms of muscle weakness, in terms of cranial nerve weakness, because patients having...
Actually here it was compressing the oropharyngeal airway. The child was going into...
Yeah, I'm not talking particularly, in general. In general I'm talking. Yeah, so that's why, like what is your view? Whether we should, like sometimes it feels like doing nothing, re-aspirate and let the kid grow up, and then we'll take care of it.
They have classified into microcystic and macrocystic. And again, like they have made a classification, I think grade 1, 2, 3, 4, where it is involving suprahyoid, infrahyoid, grade 2 is infrahyoid, grade 3 is bilateral suprahyoid and infrahyoid, grade 4 is both involving both sides of the face. Sometimes it might be very extensive, but if you see that infrahyoid, sometimes we can wait and watch. But suprahyoid, I will feel that maybe surgery might be the better choice, because we cannot wait so long so that to cause more complications and more, it can affect the airway and all that. Sometimes we may have to approach suprahyoid a little more aggressively. Yes, sir.
What is your experience of bleomycin injections in lymphangioma?
Which one, sir?
Bleomycin.
No, sir, we don't have much experience. Have you used it, sir?
No, it's there in the literature.
Oh, okay, sir. Yeah.
But it is not sclerotherapy, but recently I had a case, the pictures or videos of one scene, like so extensive that I made the airway by combination, lasers, it took me 3 hours. But still I couldn't do part of bleomycin, this receptor.
Yes,
There I just injected bleomycin on the protocol.
Actually, from our side, sclerosing agents we didn't use much. We are doing more of surgery, sir.
Thank you, Dr. Srinivas. Thank you. I thank all the speakers.
Thank you so much.
Yeah, please. Please.
The evolution of lateral skull base surgery. It's basically from open to endoscopic, and why are we doing it as a whole from open to endoscopic, and why there is a shift in this approach. So endoscopic skull base approaches are something which is very, very common, but endoscopic lateral skull base is something which is coming up now, and it is sort of an evolving science, and we keep learning as we move forward. I'm sorry, slideshow ही press किया पर. ठीक है. रहने दीजिए, I think that's okay. ठीक है. It's okay, sir. ठीक है, रहने दो. I don't think we mind this. So swap display है ना ऊपर, उसको दबाना पड़ेगा. ऊपर आएगा. Everything and anything, and then you go on and take up massive lesions and go do an endoscopic approach. But obviously, the traditional approaches of subtotal petrosectomies and all those things do stand the test of time. And for extensive lesions, obviously, extensive reconstructions, there's no question of doing any endoscopic approaches. And then these are time-tested open approaches which have been there, and they have given us a good sort of outcome even over a long periods of time. But still, what happens is when you do these cases, you realize that they are not a bed of roses. So, for example, here I'm operating on a cere temporal bone, and you can see we're dissecting the tumor of the carotid artery, and then suddenly you have this. So this is not something which is not common, and then I cannot just show you videos which show you good outcomes. So there are outcomes where you struggle, and in this patient, even though we repaired the carotid, took care of him, he expired within 6 months because of the tumor per se. So these things are very, very essential, and you need a lot of planning when you go with your lateral skull base surgery. And what is most important now is to provide the least possible morbidity. So whenever you're doing a lateral skull base surgery, these are the major structures that you're worried about, and these are the structures that you want to take care of: the facial nerve, the carotid artery, and the intracranial, and then the internal aortic canal. So for simple lesions which are there in the external aortic canal like this, like you can just go for and do a lateral temporal bone resection, and you would get wonderfully good results. So these are certain things which you commonly do, and you get wonderfully good results. You're not too very concerned because of the nerve monitoring and everything that's available for you. You can save the facial nerve, and you can gather the best possible outcomes. So these are cases that are sort of the gold standard cases, or the good cases that you have good results with, and you can preserve all these structures, and you just have to close down and follow up them regularly. So this is the post-op scan, which again shows you how well you can take out everything, and then the morbidity is also quite less. There are other factors, but I'm not going into it, like the intraparotid lymph nodes that you need to take care. Our publication on it is presently coming out. So these are things that you need to consider as and when you go forward. So we have extensive lesions also, where you can go translabyrinthine, where you can go directly into the intracranial cavity. So here you can see the labyrinthectomy being performed, all the semicircular canals. Then you enter the vestibule, and once you do that, then you delineate the whole of the IAC. And then you can take out your tumor directly from the intracranial cavity. So you can have a good translab approach and take out the tumor, and then once you take out, then you reconstruct the defect, and then you don't even need to obliterate the external aortic canal. You just need to obliterate the aretus, and then you would have good results. So this basically takes away the chances of CSF leak, takes away the chances of brain retraction, and then the outcomes are decently good for the patient. And this is something which you can do. So not always that you want to go in and do massive. You can do as much as is required. So for example, here we are operating on a small child with Ewing sarcoma. So here based on the disease, you can go forward. So you can go forth and take away how much is required in this child. And if the facial nerve is preserved, you can go on and preserve the facial nerve. The most important factor here is to preserve the labyrinth. And if at all you have to take away the labyrinth, then you need to counsel them that they're going to be hearing loss and all those things. So these are certain approaches which will give you wonderfully good results. And you need to make sure at the end that you are giving them an R0 resection. So that's something which is very, very vital. And you know that it always has to be done in a piecemeal, and you will not be able to do it in a en bloc fashion. So here you can see that we are following the disease, and then we are taking it out from all the nooks and corners while preserving the facial nerve, because at the end of an year, when you see these patients, they have near normal facial nerve activity. It really helps you, and then it sort of gives a good quality of life. And that's what this whole progression in lateral skull base surgery is all about. So endoscopy has come in massively in our ear surgeries. We do it left and right. You do endoscopic maryngoplasties, you do endoscopic stapes surgery. So these have become a norm, and these are something that are being practiced by majority of our ENT colleagues all around, with wonderfully good results and with sort of minimal drilling. And obviously, in compared to microscopic techniques, you have less sort of dissection and an ease for the patient when you go forward with this. So these are things which are routinely done now. So you've gone further, you've started taking tumors also, like for example, endoscopic approaches for glomus tympanicum. So this is something again which has become a norm. You just have an A1 disease which is limited to the middle ear. Nobody is going to go down and do massive surgeries, and you would get wonderfully good results with your endoscopic techniques. And then obviously here you can see we are even Jacobson nerve have been sent for histopathology just to make sure, and all the structures are preserved. So these are certain things which are there now in the routine practice. But then we have gone a little step further, and then you had the endoscopic assisted procedures where you use a microscope, and then for the nooks and corners you take in your endoscope and look at those areas. And then there are specifically purely transcanal techniques, which is the true endoscopic techniques where you go in and take care of the tumors through the canal, and then you can avoid a post-oral incision and all those things. So this was the landmark paper which came in laryngoscope. There are the suprageniculate approach, there is a transpromontorial approach, and then the infracochlear approach. So this is just a representative case. Here we have done a transpromontorial for an infracochlear or an infralabyrinthine cholesteatoma. So what it helps you is that you have minimal dissection as compared. Here you can see it extending into the internal auditory canal, into the cochlea again, the same MR where you can see the congenital cholesteatoma extending in there. So here you can go transcanal. One of the major steps is to do a canaloplasty, widen the canal so that you have adequate space over there. And we obviously knew that it's going into the IAC, and then we would have CSF leak coming in. Just for the time, I'm just going to take it further. So as you debulk it, as you take out the cholesteatoma, you obviously can see the CSF pouring out. And then here, we are going to go transcochlear because there's obviously no hearing left in the patient. So we go transcochlear, take away all of the cochlear bone to have a direct head-on access to the internal auditory canal. So this is very important to make sure that you take out the tumor. And here we can see the internal auditory canal and the superior and inferior vestibular nerve. With the facial nerve monitoring, we can very clearly see the labyrinthine segment entering into the internal auditory canal, and then we have preserved it there. And then you drill away so that you do not have recurrence, because you would have to go on and obliterate this canal. You can see the nerve very beautifully entering into it. And then you can see the nerves also there, which have been obviously sacrificed. For us here, the most important nerve is the facial nerve, which we could preserve, and then we could close it down over here. And then you obviously do a canal closure because you don't want CSF pouring out from here. So the dissection is very less. You do not have more air cell tracts available for the CSF to pour out from. And then even the canal obliteration can be done through the transcanal approach. So this is something which you can do, and you can reach directly into the cochlea. So there are different approaches again. So just one more case. So you can see where we are going in. You can go infracochlear. So you can go infracochlear right into the petrous bone. All you need to make sure is that you drill and take away the cholesteatoma. You cannot leave anything over there. And as we remove this cholesteatoma, you can start seeing the carotid artery. That's the petrous carotid artery. Here the facial nerve is being mapped, which is all there. Then you have the carotid artery where you've gone infracochlear here. Over there you can see the impression there and the pulsation. So you can do minimal sort of traction and you can deliver the same sort of results. And obviously if you want, you can obliterate, you can place back the tympanic membrane that you have taken off, and then you can preserve everything. So these are certain things which will help you with better outcomes, and then also you're not sacrificing the disease removal, but then you can also give less morbidity to the patient. And this is something that comes on, and there are which will be better. And then obviously it's evolving because of the better optics that we have, better radiology that we have. So all these things help you in identifying these structures and delivering the results that you want to. So you could use the different approaches which have been described, but important is to make sure that you do not leave back the disease. And obviously the newer radiology with diffusion weighted images, fat suppression images, you could again go for relook surgeries, or you can again map whether there is any recurrence over there. So this definitely helps. And obviously this doesn't mean that you're going to go in and do it for all your cases. You have to be super selective and select the cases where you want to do these surgeries, and then you can deliver the results. So obviously lateral sulbase surgeries, they stay with you for 10 days, 15 days. You need to control the leaks. But with these, patients are even ready as early as on the second day or the the third post-operative day to go home. To conclude, endoscopic assisted procedure is not definitely something that you want to do. It's always an assisted thing. You are doing an open approach. You can use an endoscope to assist, and that is the norm. And that's not changed as of now. Pure endoscopic approaches is for select lesions which are localized, where you want to identify it near the fundus, or it's there in the apex, or it's there above the geniculate ganglion, and you can do minimal dissection, and then the endoscope helps you in those situations. They are complementary to each other, and you should not shy away from using either of one. And morbidity is definitely lesser, but not at the cost of recurrence. And that's where your radiology is something which is very, very pivotal. And the learning curve has to be respected. And the more the amount of temporal bone dissections that you do, you would obviously deliver better results. And we are still learning, the science is still evolving, and hopefully there'll be much more to gain from this endoscopic approaches. Thank you.
Thank you, Dr. Pritham. Any question from audience? Dr. Tiwari, please come in. Yes, please.
Yeah.
Sir, tell something about your experience in the patient who received adjuvant radiation. In your cases, for example, you said one Ewing sarcoma and some squamous.
Yeah, so Ewing sarcoma, basically, this patient was not primarily treated with us.
My question is, how you will end up, or if you end up with some patient with osteomyelitis or osteoidonecrosis because of adjuvant treatment after surgery, and what is your way to deal with all this thing?
Yeah, okay. So for our CA temporal bones, whatever series we have had, we have been lucky enough that we have not got ORN or osteoidonecrosis, and it was more, if somebody had anything, it was more of a recurrence where we lost them. So that's one thing. But this Ewing sarcoma, those lesions which are primarily taken care of by adjuvant therapy, so they came us when it didn't work, and then we sort of did a salvage therapy for them. Frankly, we didn't have an ORN, anything there, but if an ORN develops something, then I realized that we just have to go in and debride them. So we'll have to do a secondary surgery. There's no other way out that we have. If you're very, very lucky enough, then your antibiotics and conservative management works, but then long term it doesn't. So you will have to end up doing some revision surgeries. But for these endoscopic approaches that I've shown you, we do not, or I personally have not operated any malignant lesions with an endoscope, because that again is not something that I'm comfortable with. I would still prefer an open approach for a malignant lesion, because I'm aware that I need to deliver first on the disease front rather than just primarily looking at the morbidity for the patient. So for me, it's always a benign lesion for sure, for even to think about doing a endoscopic approach. Thank you.
Well, thank you, Dr. Pritham. And with this, thank you so much. Mementos to be given to.
Sir, to facilitate out for chairpersons. Curry. Please. So the first presenter will be Dr. Brajendra Basar, sir. His topic is challenges in thick skin rhinoplasty.
Reconstructive surgery, and he has written more than 3 books. Welcome, sir, for your talk.
Right. Good afternoon, everybody. Post-lunch wakey. How it works? Pointer. Gallant Mekala, then came back and attended a course of Tony Bull, and then I did a rhinoplasty at Nair. I was working at Nair Hospital. And then at that time it was era of black and white photography. So we had a hospital photography department, and it was very near to ENT department. So I went there, and for post-op photograph I sent the patients there. So now this photographer very like innocently asked me, "Sir, which is before operation photo?" It was very embarrassing. I said I learned in America and in England, and I did the same thing, and there are no result. It looks almost like the same what I was this thing. Then I realized that rhinoplasty is not that easy. Now this I got from Canadian Journal, and it says that I wish people always show good results, but they don't show what are the problems we face. Very thick skin is an relative means you should never perform rhinoplasty. No matter what you do to the cartilage, the tip will be bigger after surgery, not smaller. So you'll have a tough time post-operative to the patients explaining. Of course, some people are proud of their big noses, but not many. Now, why this, what we are discussing is all the surgical work which we do is below the skin. We modify the cartilage framework and the skin drapes it. But if the skin mass changes you made, so they say thick skin is, recently I got a patient from Australia, and thick skin, and the doctors refused there to operate her. But what we do in India, we get all these patients every day we get, so we have to operate them, we have to produce results. So first of all, as Sandeep said in the morning, pre-operative counseling to know them that it's going to take a long time to settle it out. But gradually, as the experience increases, we realize that it is possible to give good results in thick skin patients. Now, understanding the concept. There is what is the problem? One is a thick skin, then there are a lot of fatty tissue under the skin, and then you have a lot of acne and lots of sebaceous skin. And once the cartilages are weak, and then this dead space can be replaced by scar tissue. Now, this is a general concept that thick skin, weaker are the cartilages. But sometimes you get other side also. You get thick skin and thick cartilage. I will show you some of the both aspects of it. So what we do, we make a strong tadpole. I'll come to these things. Like this patient was operated somewhere and came for a revision. And everybody said there's nothing more can be done. You are breathing well, and he's not happy with it. So here you have to not reduce the cartilage, but make a strong cartilage framework. And this is the framework which we made. And this is how this, a year later, you can see out both functional and aesthetic improvement. So structural rhinoplasty is the key. You don't have to reduce, you have to strengthen the framework. And you may have to use large peg grafts or sheen graft of cartilage because thicker skin mass is, and a supratip graft. I will come to that. So this is a peg graft, and then sheen graft I will show you now. Then there are various articles in the journal that you score the skin and reduce the fat, but doesn't work, it leaves the scar tissues. So let out with, this is thick skin with thick cartilages. So when you open it up, these cartilages are not weak, they are well formed and very dominant. So we remove the fat over them, and this is the little radical approach. You free them from the vestibular skin, and creation of 2 new domes with lateral crural steel and alar turn-in flaps. So you cephalic part you are turning in, and using them you are strengthening the cartilage. Septal extension graft, osteotomies, and these are articulated alar rim graft. There are 2 types of rim grafts. One is a free rim graft, and this is articulated alar rim graft. So to strengthen the alar rims, and then you are trimming a part of the columnar skin to stretch. We want all our efforts is to avoid the dead space. So these are on-table results. And now, and after, in the post-operative period, he lives in Dubai, and every 2 months he used to come for Kenacort injections. And so this is after 18 months. He took this thing, and in between we had given him. I'll talk to you about the skin treatment in the end. I want to repeat it again and look it out. A significant improvement in the presentation. Okay. So it is thick skin and thick cartilage. Now this is another thing, thick skin and weak cartilage. So here you see a cartilage, so this is only fat only below. This fat is giving this, making the tip. So you remove all this fatty tissue, and of course you have to be careful about not to damaging the subdermal venous plexus, otherwise you get terrible scarring which will be difficult to correct. You're removing out, you are seeing out the cartilages. Dorsal augmentation. Now this girl refused to give a consent for rib. This septal extension graft, again, we have freed them from the vestibular skin, so making an absolutely new tip. So there is going to be the dome will be shifted medially and increasing the anterior posterior height of the tip. And these are alar extension grafts. Dorsal augmentation. This is on the table, and this is a year later. I mean, I usually like to show, though India follow-up is a problem, or like to show late follow-up results and see out. There is a significant change in the appearance. Another patient with a thick skin and thick cartilage. 1 year follow-up results. Now this is an interesting case worth seeing. This is only fat. You just press it, and there is a. Now how did she is from Jaipur? A lot of fat has been removed. Then the large septal extension graft. And then reducing the the alar cartilage. So we are doing a sliding technique for lateral crura, reducing the width of the lateral crura, and these are measurements to reduce the tip width. Overlapping techniques, so to make them small and strong at the same time, make it structurally strong. A peg graft, and here again excision of the columnar skin to stretch the skin, and wide excision of the alar base. This is on table. This is about 6 months later, and see out how the tip has gone in. Otherwise, very difficult to produce changes in these kind of patients. Then you get again another patient, thick skin, the strong cartilage. She is the one came from abroad, and see out. Here we did both modified lip set technique. In lip set technique, they excised the lateral crus and medial crus along with the vestibular skin. We excised a part of the, we not excised, we incised the lateral crus, overlapped them, and excised the medial crus and overlapped them. So whole thing is pushed back. The new tip has come at a lower level and maintaining its strength. And then this is a tongue in groove. So we're fixing it up because the septum was strong, it was protruding out, so tongue in groove, and these are the results. On the table you can see out the tip height has been reduced, and the boxy tip has been improved out. Again, this is another case with thick skin, strong cartilage. Please don't take pictures, huh? You can stop this video, because some of the patients I don't have consent. ये वीडियो बंद कर दोगे आप रिकॉर्डिंग बंद करना है. Principles are the same, whether you're doing a columnar incision or not, it's up to you, and the skills you have and techniques. This is. Now, there's some of the things which this is the structural thing, but it's not only the surgery on the table, but the post-operative picture. Some of the things which have started, one thing that we have started a trial of isotretinoin. We are giving it, the normal dose is 1 milligram per kilogram body weight. So like a 60 or 80 kilogram, it is 80 milligrams. But we give in a low dose 20 milligram. It is a very toxic drug and you have to be monitored it carefully, liver function test, and of course teratogenic effect and things. And a lot many people complain of dryness. In one patient we have to stop it because the patient complained of impotence. But it works well in thick skin and we give it for 6 months. Many times we start it a month ago, before stop it 1 week before and do it out. And second thing we have started, we are doing post-operative Botox injections, which we give it on day 7. Because what is happening, all the changes you are making in the structure, you're not making any changes in the muscles in the skin. So they have a memory. So that they don't cause pulling effect on the new structure you make. And I do a lot of in the crooked noses, 50 to 100 units. Usually I give it on day 7. You can give it on a table also, but that increases the operative cost by something like 100 units to 35,000 or something like. So I like to give it after a week. And so look, this is the 4 months post-operative. He was given structural rhinoplasty, Botox injection, and he is on Aoicon, 20 milligram per day. He does have side effects, exfoliation, the lip skin and things, but all those put together helped in making him a significant change in the appearance. So these are the pictures, 4 months. He still has to continue, is continuing the Aoicon for another 3 months. And then we also give perioperative skin cleansing program, retinoic acid, salicylic acid face wash, and clindamycin gel sometimes when there are active acne. And all this post-operative skin care regime helped in improving as a result. So initially our aim is to produce result. Now we want to go to fineness and give better quality of results. And that comes with the combined approach. And then Kenacort injections, they should be given subdermal, not in the skin, and not in all cases, but where you think there is a risk of scar formation, give it. I usually like to do 3 to 4 injections in a month interval, and isotretinoin already talked about you. So the key points in the thick skin rhinoplasty, yes, we face it every day, and here you do a structural rhinoplasty, pre and perioperative skin care regime, following up and then counseling with the patient. It may take 1 year or more than 1.5 years to get the results. And once they accept it, and a well-understood patient, well-counseled patient helps in achieving good results. This is our workshop in October last year. We do it every year. This is 23rd year. And next year, this is the Pain Asia Academy Conference. I invite you all. This has come to India after 11 years. This is in New Delhi. And be part of the organizing team and help us. Thank you very much.
Yeah, I am from the Northeast, and many people in the geographical distribution, our some ladies especially, they have a complaint about their short nose and flat nose. And they used to come to us, so ma'am, can you raise my nose a bit? But I examined and then found that their skin is very thick. It is very difficult to do even augmentation. So it is very difficult, and I don't know how much justified to do the rhinoplasty in this patient. So I started doing some fillers injectable, and they are quite happy, but it should be repeated. What is your opinion regarding this?
I mean, that's an entirely different debate. Ultimately, what you're doing with the filler, you are adding a volume to stretch the skin. So that is a temporary, and it has the fillers are not cheap, and you have to do it every 9 months. If they're happy, it's an easy lifetime job. So that's quite popular, and many times we are, when the patient is buying time, we give fillers and then come back for surgery. So it depends on your counseling with the patient, perfectly fine. Of course, fillers have side effects, but Northeast, I get a lot of patients from Northeast also. And their all complaint is that the nose is flat enough, and even after augmentation, they feel thoda or maybe more, doctor, can you do it again, and something like that. But there again is a problem, is a deficiency of the skin. You cannot put 10 kilogram sugar in a 5 kilogram bag. So there you have to make these things, balance out with this. Nowadays, previously we were doing diast cartilage in fascia. Now we stopped doing that because that gets absorbed and it isn't not working. But now we are doing diast cartilage without fascia as a filler layer. First structural these things, and on top of it using diast cartilage in the PRP and injecting with a syringe, and that seems to be working. That gives an additional layer, the augmentation they want. Basically this is also like a filler. When you're doing a filler, this is also acting like a filler, but surprisingly the free cartilages are working better than the one in the fascia. Anybody else? Great, thank you so much.
The next speaker, I would like to invite Dr. Sitesh Patil from Amravati. He'll be speaking on septal extension graft, a workhouse in rhinoplasty. Welcome, sir.
Such a wonderful afternoon in the pink city of Jaipur. We do come across a lot of patients nowadays with our stalwarts in India have already worked so much. Now the demands have increased, and we do get people with more and more demands like, doc, make me beautiful anyhow. But as Dr. Basair sir has already mentioned, the results can be unpredictable. So we have to think why these results are so unpredictable. It's probably because of the difficult septum, unpredictable dynamics of healing, loss of tip projection in the post-op, and especially loss of tip projection in the post-operative period. So there's a new guy, the septal extension graft, which I think is a workhorse in rhinoplasty. I'm Dr. Kshitij Patil from Amravati, Maharashtra, and I'm going to speak about septal extension graft, which I think is a workhorse in most of the rhinoplasty procedures. The septum is a central structure of the nasal framework on which the entire septal skeleton is built upon, and the nasal tip is attached to the anterior septal angle with various ligamental supports. And septum surgery does affect the midline alignment, profile line, tip support, ala columella relationship, and also the nostril contour. And a septum, although termed as a beginner's surgery, a difficult septum even pose today present a great surgical problem. If we look into the ideal nose tip aesthetics, on the front view, the bridge should be high enough to cast shadows on the sides. On the base view, it should be almost like an equilateral triangle with columella show of about 1 or 2 millimeters. This is by Dean Toriomi. The projection should be just about 50% of the nasal length, and that nasolabial angle should be about 90 to 95 degrees. When we look into the airflow and its sensation are different. The cold receptors sense the airflow. Air is directed initially upwards and backwards from the nasal valve over the anterior part of the inferior turbinate. Then it splits into the laminar flow above and below the middle turbinate. So if you look into the vestibule, initially this is a vestibular valve. Then is the attic of the vestibule, which is also open, and then comes the nasal valve area. The nasal valve area should should be at least open, and it should have a valve angle of about 10 to 15 degrees. And majority of the deviations are the breathing problem, the sense of breathing definitely comes from when the air passes through the internal nasal valve area. If the internal nasal valve area is closed, the air does not pass through the internal valve area, and the patient does not have the satisfaction of the breathing. How much ever the posterior septum is deviated, how much ever there is a spur, there are a lot of patients who still don't complain anything. So the major culprit is the anterior septum. And now that we are evolving in rhinoplasty, a very typical protocol that most of the people follow is open approach, spreader graft, fixing the caudal septum to the nasal spine, and columella strut. So whenever we are cutting the ligamental supports, we have to reconstruct with the help of columella strut. But many a times we have to know that the Caucasian kind of noses, that is the North Indian noses, and the non-Caucasian kind of noses, the South Indian noses, they are basically different. The quality of cartilage they have is different. The Caucasian kind of noses, that is the Central and the North Indian population, they have strong cartilages. So the columella strut may survive in those cases, but with thicker skin and thin cartilages, the columella strut generally would not survive as well. And then that's why all these seniors say that whatever you see on the table may not be there at the end of 1 year, and there when you start seeing the loss of tip projection, then that is after the year that you start seeing a polybeak deformity and sometimes even a persistent nasal obstruction. If you look into the nose, the nasal septum, the nasal tip is about 9.5 millimeters, that is about a centimeter ahead of the anterior septum, and about a minimum of 0.6 to 0.7 millimeters on the top of the anterior septal angle. So, and this is a study on Caucasian, non-Caucasian population. In non-Caucasian noses, this is even more. So whenever we are doing any surgery, you have to reconstruct when you are cutting this. So you have to reconstruct this with the help of a septal extension graft. So what is septal extension graft? Septal extension graft is you have to take a piece of cartilage and then you have to put it on the caudal septum, so that you have to fill this 1 centimeter area which was deficient. So this can be done either by a side-to-side fixation, and it can be supported with a spreader graft. So this is basically a piece of cartilage that is taken from the part of the septum that is behind. This is initially fixed with needles. I'm sorry for this. This is initially fixed with needles, and then at least with 2 or 3 sutures, you have to fix it, at least minimum of 3 sutures. So this is basically a septal extension graft. Septal extension graft can also be done by end-to-side fixation, but for that you have to fix it with a ethmoid bone plate with multiple holes on it. And then the tip assembly can be advanced on the top of this septal extension graft so that it stays in place. Septal extension graft can be of various sizes and shapes depending upon the needs of the patient. Now when you have to do a reconstruction of the anterior septum, in deviated noses, sometimes you have to remove the anterior part of the septum. So in such cases, you have to replace the anterior septum. So this is called as anterior septal reconstruction, or we also call this as a partial extracorporeal septal reconstruction. But in addition to this, when this is sitting on the nasal spine, in addition to this, you have to still add this graft. So in such cases, it's better to take the caudal septum of the length which encompasses both the things. So Sam Moss has written a wonderful paper on anterior septal reconstruction. So this is partial extracorporeal septal reconstruction, in which initial about a centimeter or so of the cartilage is straight and rest of the cartilage is deviated. So I removed this cartilage, and then so this is the septal extension graft which sits on the nasal spine, but which is about 1 centimeter more as compared to the original size of the septum. So we generally fix this with spreader grafts first. So I measure the graft, then I put the spreader grafts first, as you can see here on both the sides, and then the septal extension graft is fixed to this. So this is how you get an exactly straight septum. The internal nasal valve is completely open, and also you get a wonderful support for the tip. So this is the wonder of the septal extension graft. So it serves both the purpose. So as you can see here, this part of the anterior part of the septum, which is the major culprit in the nasal breathing, you have to remove it if it is deformed, and then you have to reconstruct the anterior septum along with the septal extension graft, so that it also supports the tip area. and then the tip cartilages are advanced on the top of this assembly. Now coming to a few cases, this is a 24 years old female with a breathing difficulty and a twisted nose, and she was also she had also a little bit low on radix. It's not working. I'll put my laptop. Okay. Versus a septal extension. Okay. Now it's come. So it was a simple oblique nose. So we did osteotomies, put a spreader grafts, and I did a septal extension graft and advanced the tip assembly. So this is a 1 year follow-up of the same patient. As you can see here, a very nice a projection which is well maintained. I just put some free dice cartilage on the radix because she did not want much of an augmentation. Coming to C-shaped deviations, as you can see here, a C-shaped deviation. It was the really deformed septum, so I did a partial extracorporeal septal reconstruction. In this, the caudal septum was also deviated, so I put a ethmoid bone splint on this, and this is a 6 months and 2 years follow-up of the same patient. As you can see here, the tip projection is very well maintained even after 2 years of the surgery, and even the tip width is very well controlled, and even on basal view you can see similar shape of the nostrils. So this is a wonderful 28 years old girl with a lot of breathing difficulty and S-shaped deviation of the dorsum. On opening up, she had a septal deviation which was impinging upon the cartilages. So we removed the cartilages and did a partial extracorporeal septal reconstruction with septal extension graft. And here she is about after 1 year of the surgery. Wonderful projection is still maintained with a little bit of supratip break. The hump we removed. And although the nostrils are not the same, but still it's an acceptable result. Now septal extension graft in pseudo humps. So this is a partial low radix with a hump and a droopy tip. So in this case we did again a partial extracorporeal reconstruction, and here she is 10 years post surgery, and as you can see here the tip width is so very well controlled, absolutely straight tip, and the tip projection is still maintained. So even with thick skin you can get good results if you put a good graft. Coming to hump noses and caudal septal deviations, so this gentleman about 30 years old male was concerned about his aesthetics more than the breathing difficulty, but he really had a bad septum. So did a partial extracorporeal with septal extension graft. So we removed the hump and gave him a good tip projection. So here he is about 1 year after the surgery. Now coming to unsupported tips. So this 22 years old girl with a breathing difficulty and history of childhood trauma, she had developed a tip drooping, and also the nasolabial angle was acute. So we removed the septum and did a partial extracorporeal septal reconstruction along with septal extension graft. So this is about 6 months and 1 year after the surgery. As you can see here, it stays like that. So you have to reconstruct with a good cartilage and a support. So the tip stays, and even the drooping of the tip which is there has also gone. So this is about 1 year after the surgery with a very, very open nostrils and open external nasal valve area also. Coming to septal extension graft in complete extracorporeal septal reconstruction. So whenever we are planning a septal extracorporeal, sometimes you can also add another graft to your extracorporeal septal reconstruction. And here he is about 1 year post-op. And the entire, because he felt that his nose was very big, so we also reduced the size and did a tongue-in groove. Coming to isolated middle vault deformities. This is a 25 years old female presented with breathing difficulty and external deviation at the keystone area. So in this case, we did an in situ technique, and we just put spreader grafts and then excise and just incised and keep it over there. So we did not remove anything and added a septal extension graft to this. So here she is about 6 years after the surgery. Very nice dorsal aesthetic lines, and you see this hanging columella is also gone. So this was a tongue-in groove. A little bit of hump she had was also removed, and this is 6 years post-operative period. Now, coming to septal extension graft to treat isolated tip deformities. Now, this 24 years old girl comes with breathing difficulties and external deformities of the nose. On opening up, it was a huge alar cartilages and on opening a septum, it was impinging upon one of them. So we removed the septum, reconstructed, and I gave her exactly straight septum, and then did a tip plasty. So this is about 1 year of the follow-up of the same patient. And as you can see here, it was a pseudo hump, so we filled a little bit of the radix with the free dice cartilage, and the tip projection, the droopy tip is also gone. So even after 1 year of the follow-up, the patient had a good tip and the good aesthetic results. Coming for septal extension graft for droopy tip. So this is a very typical poorly defined nose, and we really don't know what to do with this. So she has a droopy tip, and if you look in the lateral view, she has a droopy tip and a little bit of a low radix, but she has a breathing difficulty also. She also had huge alar cartilages, so we did a partial extracorporeal septal reconstruction, in this case with a septal extension graft. And here she is about 6 months, and this is after 2 years of the follow-up. As you can see here, the tip edema which was there after 6 months has almost gone, and you can see 2 tip light reflexes. And even after 2 years, the tip projection is still very, very well maintained of the surgery. And even on the basal view, you can see almost symmetrical nostrils at the end of 2 years. Coming to caudal dislocations and the poorly defined tip and broad tip and a droopy tip. So we did a partial extracorporeal with this was only a septal extension graft with spreader grafts. So this is about 3 years follow-up. Her tip width is well controlled. And even after 3 years, as you can see, you get a nice subtle supra-tip break over here. And the tip projection is still very, very well maintained. And the caudal dislocation which was here is also gone. The breathing difficulty is also gone because of the internal nasal walls are absolutely open. Now this 27 years old girl comes for aesthetic complaints only. She feels that her nose is too big. So as you can see on the lateral view, her nose is so big that her lip is almost not seen at all. So we decided to reduce it. So she had a crooked septum, so we did a partial extracorporeal. We also did a tongue-in groove technique for this patient. So as you can see here on the front view, this hanging columella is gone. So automatically the lip size is increased, and this is a 5 years follow-up of the same patient. You see the lip, we reduced the hump, we also reduced the caudal septum, and then we did a tongue-in groove technique. So you see the size of the lip is also very well controlled after 5 years. For hanging columella, these are the last few slides. For the hanging columella, now this woman comes for aesthetic complaints only. For a hanging columella, we did a tongue-in groove technique, and these are the early results, but I wanted to show you this. So by tongue-in groove technique over a septal extension graft, so this is called as a modified tongue-in groove technique. It also gives you wonderful results. This is one more patient, 5 years follow-up of the same technique, tongue-in groove technique. Sometimes you can use it for deep projection also. Now this wonderful looking girl, she thought her nose sticks out too much. She wanted a small cute tip nose. So we did a lateral crural sliding technique, and we reduced the length, that is deep projection, over a septal extension graft. And this is a 7-year follow-up of the same patient. As you can see the difference in the camera also. So this is a 7 years follow-up of the same patient, and she got a nice C-shaped septum, a C-shaped dorsum, which very few people sometimes ask. So this is a 7 years follow-up and a wonderful, and even on basal view, almost equal nostrils. Sometimes you can also use it for derotation, for upturned noses or pug nose deformity. sometimes you can use extended spreader grafts and septal extension graft. So extended spreader grafts are fixed to the caudal septum, and then septal extension graft is anchored in between these. So this is a septal extension graft along with extended spreader graft. So as his main problem was he thought his nose is too short and he can see the nostrils on the front view. So we have to derotate the nose, and this is 8 years follow-up of the same patient. We did not do any kind of augmentation and only derotation, and the patient was happy. Coming to the cases of augmentation, now this girl only wanted some tip work. So we asked her, we also counseled her that we should do a little bit of augmentation. So, and because there was an adequate septum, she was not willing for a graft. So I convinced her. In this case, I only used a very small graft. So this is called as something called as a TO graft, which you can use at the anterior septal angle. So even if you use and then advance the cartilages on top of this assembly, and then I use the rest of the cartilages to augment her dorsum. So this is about 1 year follow-up of the same patient. We could nicely control the tip width, and also on the lateral view, you see the projection is still very well maintained, and we also did some dorsal augmentation. Coming to major augmentations, unless and until you give them a good tip, a major augmentation will not work. So in this case, we did a total septal reconstruction with the help of costal cartilage, advanced the tip assembly on top of that, and then we did a costal cartilage graft. So this was a guy, this is a 2 years follow-up of the same patient. He had to change all his IDs, including a passport and Aadhaar card, because there's a very, very drastic difference. So this is about 2 years follow-up of the same patient, although this is not a perfect on basal view, but I think it's an acceptable result. Coming to revision rhinoplasties. So this was a case of a revision rhinoplasty. In this case, we did a total septal reconstruction with the help of costal cartilage, and on top of that, we added a solid contoured costal cartilage. So this is about a year after the surgery. She is very well breathing and also happy about her aesthetics. So coming to conclusion, the septal correction is the most essential part in each rhinoplasty operation. It is a structural operation and not just a resection. So all our colleagues must know this. A straight septum is a fundamental of the straight nose, and pre-operative planning is of a paramount importance. Septal extension graft with replacement of anterior septum is very effective technique for correction of severely deviated noses and has got excellent functional as well as aesthetic results. It is comparatively an easier technique and provides more reliable long-term results and support to the tip. It also opens up the anterior nares and the internal nasal valves as compared to the columella strut. And in cases of severe deviations, in any axis more than 30 degrees, it's better that you have to go for an aggressive approach and replace the anterior septum so that it serves both the purpose of breathing and also the tip support. So although the learning curve in rhinoplasty is very big because you get the results only after a year of the surgery, I say thank you, and you never have to give up. You should never give up. Thank you very much for your patience.
Thank you, Dr. Sitish Patil, for your informative lecture, and the patient audience too, for bearing with us with the technical difficulties. Any questions from the audience?
What I see is there's only one there are two drawbacks sometimes. The one drawback is because the movement of the tip in an individual is independent of movement of the septum. Here it becomes a little bit stiff because you are giving it a support. But I've been doing it since last 8 to 10 years now. And
after 2 years that goes?
No, it still remains. If you see the finer nuances, if you see the patient will not be able to move his tip alone. When he does this, the entire nose will move. So
only thing he cannot do is the tip upward rotation.
Yes. So this one he
Yes.
cannot do.
Yes.
So But I really don't have any patients. I may have only 1% patient complaining about the same.
They feel it is more stiff for 1 year.
Yeah.
But after 1
But
year,
after that, yeah.
yes, it becomes more natural.
And another thing is, when you are using a septal extension graft, if the septal extension graft is deviated, then the entire tip will be deviated. So you have to be absolutely sure that if you are putting a septal extension graft, you have to put it on an absolutely straight septum, or otherwise the entire tip assembly will be deviated. So I do not use septal extension graft only for asymmetric faces or for facial asymmetry. So I correct the nose, the dorsum with respect to the glabella, and I would like the tip to remain in relation to the philtrum.
Thank you. I would like to request the audience to please connect to Dr. Sitish Patil on personal basis after the lecture. We are falling behind. I would like to invite the next lecture person, Dr. Vishwas Vijayadeva from Bangalore. He will be speaking on designing nose tip.
A very good afternoon to all respected chairpersons, and thank you for showing the support to rhinoplasty and being here in the post-lunch session. And I'm very happy to be following it up after my colleagues and senior Dr. Bajendra Base sir and Kshitij Patil. And they have covered a lot of ground in rhinoplasty. So my role will be to dwell upon what the nasal tip does to the nose. Hopefully in the next few minutes, we'll try to cover the finer aspects of the rhinoplasty, which is possibly there is an overlap with the other speakers. Nevertheless, I'll try to do justice to the topic. Now, the old adage was, as goes the septum, so goes the nose, and this has been so for the structural rhinoplasty. And with time, what we realize, or as we get into serious rhinoplasty, as goes the tip, so goes the nasal beauty. So finally, when your patient comes to you, he goes on asking about this, that you give me a good nasal tip, and that is when my satisfaction levels are better and the expectations are met. So nowadays, we have patients coming to you and asking you those subtle variations on 1 millimeters, 2 millimeters, and symmetry, and many other things, apart from what you see in a regular rhinoplasty. Now, just to understand a few pertinent points on the tip is, one is this lower segment starts from the supratip break that you see here, and then you have a supratip lobule just above the tip lobule, the infratip lobule, and the columella. And these points have been defined aesthetically to give a better appearing nose for a better facial dimension as a nasal dimension. Now, the concept of the nose is it has to blend into the face in such a way that the person on looking onto you speaks to you with their eyes focused on you and not looking at your nose itself. So this is just the underlying anatomy on what is there underneath. Now the upper lateral crura and the lower lateral crura are overlapped at a certain angle, at the scroll angle, and there are ligaments which hold it down in place. Along with it, there are fibrofatty tissues and other ligaments that help move the valve and help move the lateral nasal tissues as well. Now, coming to the ultrastructure, what we see down there is a medial crura, an intermediate crura, and a lateral crura. Now, these angulations are most important when you're defining the nose, the medial crural angle and the lateral crural angle. And this has to be a certain dimension to give a good optimal result. Now, just going on to the technical matters, because my colleagues have already spoken on a lot of techniques and philosophies. Now, any tip for that matter has to have a strong foundation. Many times when you open up the nose, this is what you see, that the septum is either slipped off from the center anterior maxillary spine, or it is possibly deflected from the center. So then You either take a drill hole onto the anterior maxillary spine or onto the periosteum and then fix it right in the center. So this is where we start from the base. So the principles or the basics never go away. Now, once you come up, you might find cartilage deviations like this, especially so those which can cause caudal septal dislocation and come outside, and thereby the definition of the tip itself might go away. Or you might be faced with cartilages like this, which are totally deviated out of place, and even if you do any tip techniques, they will definitely show up in the middle third. So for this, obviously, as shown earlier, a partial or a complete extracorporeal septoplasty may be essential. Now, our workhorse, as mentioned, was the septal extension graft, and one thing that you need to remember is keep the dimensions in place. I'll be coming to the dimensions, and once you close it, get the triangle to be an equilateral triangle for you to be able to get a good definition. Now, most of the time, when in male patients we create a nasal tip, we try to keep it straight, possibly give a small hump, that is an aesthetic point, and the definitions of the lateral crura itself should be more into the alar line rather than high up, which would be called as a lateral crural malposition, which has to be replaced down. So what happens when you have a septum which is totally deviated? Make sure you take it out, design it accordingly, make an L strut and place it back. Now, while placing it back, from the profile view, you need to keep examining and seeing what is the ideal dimension that you can get, and at the same time, you need to put it onto 2 points here. One is the nasal spine and the maxillary spine to fixate it. Now, a collapsed septal skeleton is something that all of us need to handle first before the tip itself. So, it is not a standalone job of doing the tip. It all starts from the nasal skeleton itself. You can see that the nasal bone itself is deviated, so you might need to do a root osteotomy to handle it as well. So, just coming to a few examples. Now, the tip asymmetry that you see here is secondary to the septum. What would have happened is one side of the medial crura would have gone oblong and one other side would be shortened. So, you need to correct it. Meanwhile, a person with something like a polybeak deformity and a hump deformity can also be corrected by handling the crura. Now, I'll be coming to the finer tips later, but this is just a few examples in place. There can be tip malformation due to a septal orientation itself, where the septum is oriented way away from the axis. Get it into the center and get the symmetry right, and the tip symmetry comes back again. So many times you see that the tip septal cartilage itself is broken. That's when you can utilize behind the cartilage a perforated ethmoid plate, as mentioned earlier, along with cartilages to make it straight and stable. So once you put it in place, what you'll be doing is actually a septal extension graft, which will define the tip by doing a tongue in groove technique. So by the tongue in groove technique, you mean that you can either change the rotation of the nose or the projection of the nose, and that's a very stable technique that has stood the test of time. The only disadvantage, as mentioned in the discussion earlier, is the stiffness of the tip that many patients might not like. Now, the tip might also be undefined secondary to a deficient septal height or a premaxillary projection. Now, if that is so, obviously we need to build a cartilage frame and also build the augmentation that is necessary. Now, the rib cartilage would be the most ideal. So, this is how it would appear in the 1 month post-op, and this is the long-term post-op that you can see. And what you can see is the premaxilla is also lifted up from here, and you can get a good tip definition. Obviously, this is thick skin. You can't give a very sharp point here. But then by working on the premaxillary lines, you can also give a good nasolabial angle definition, which is usually 90 to 95 degrees in the female. So this is the helicopter view, and this is a 2-year follow-up to see how it is after a long-term follow-up of the septal framework build. So why I'm talking about the septum is we all try to go at the tip first, but the septum holds the key a lot to the tip. Now, tip may be undefined sometimes due to rare cases like this where there is no septum at all and it's just standing on the lateral cartilages. So again, we need to build the septum, and this is in the long term. The patient had a good augmentation and a good septal support. So septal extension grafts are like this. Now what you need to do is 2 points here, the supra-tip break, and you need to get the 2 points wherein the tip definition comes better. Now, if you have a triangle here pointing out, the tip will look too sharp and not look good. So you have a supra-tip break, another infra-tip break, and this angulation would be better to give a better tip definition. Obviously here there's a lot of edema, which is just post-op, but then a definition is essential. Now coming to the tip projection itself, an ideal tip projection in this ratio will be a 3-4-5 triangle to be able to give a good definition from the face itself. And there are many other ratios, but we use the 3-4-5 ratio or the goods ratio. Just come to it. Now, the ratio between the projection and the length, nasal length, should be 0.55 to 0.6. Obviously, we don't measure it on table, but it's a suitable way to get the tip projection. Now, one of the patients had a tip which was not very well defined, and she felt that her tip was not that projected well. And obviously, the principles that we have to use are the same. Used a septal cartilage, tongue in groove technique, augmented the tip, got shield grafts, got tip cap grafts in, and what I could also do is a cephalic trimming and interdermal and transdermal stitches. And this is just a definition through time, 3 weeks, 6 weeks, and this is how the edema settles down, and the patient is able to get a better tip definition and a tip defining point. So what is a tip defining point? The tips of the two sides of the crura are visualized in a dome-shaped pattern or a rhomboid fashion. Now, this patient was actually concerned about this concavity here and the tip that it looked to the side. It's just because of the cartilage framework. She basically wanted me to understand that her dorsal aesthetic lines need to be corrected as well. And she was not happy with the fact that her columella was hidden or the nostrils were hidden. So they wanted a definition of the nostril slide show or a rotation in the other words. Now, nowadays, it's not just about having a typical malish nose. Some of them do ask for a metrosexual nose as well, wherein they want a sharper tip, though it's a male patient. And he wanted to change the rotation. Obviously, that's a male character, but he also wanted a very sharp tip to match his features. So what's the ideal definition? The ideal definition is in a male nose, a 90 to 95 degrees and a 95 to 105, but these are changing with time, and many patients exactly tell you what they want, and this is how the patient wanted and I was able to deliver. Now, tip and shield grafts are very, very essential part of our armamentarium to be able to give a better definition in patients. And this is what I was talking about, the tip defining points and the rotation. Many times when we try to trim a lot of tissues, the entire cartilage shifts up. So this is, we have to avoid it and try and do a reconstructive technique than a resective technique. So this was the Rio technique or the TO technique that Dr. Kshitij was telling you about, of getting an extension in such a way to give the better tip definition. So the double break point was what I was mentioning to you about earlier. This is a rounded tip. By giving one break here and the second break here, the definition becomes better and the patient is better looking. There are specific tip defects that your patients might come with, something like this, where they have a very concave deformity and they just want it filled up. It might be as simple as a lateral crura which is concave. You fill it up with a conchal cartilage which is convex in the opposing direction. Sometimes you might get patients with absent tip cartilages. Sorry for the bad photo here. Yeah, absent tip cartilage, the lateral crura was totally absent, so you will need to build the lateral crura again. And this is how the patient would be after the lateral crural cartilages are built from the scratch. And this is from the side view. This is just a visualization of the introp photograph. Sometimes it might be absent on one side and then you will need to build it to get a better definition. So just coming to another salient point that we see is the lateral crural malposition. Normally the lateral crura is directed more towards the lateral canthus and not the medial canthus. So this definition creates a bulge just above your limnae, and then what you need to do is turn it downwards to get a better shape. So how do you turn it downwards? You put a lateral crural extension graft like the way you see here into the pockets, or a rim graft or a marginal graft to rotate the lateral crura downwards. So how do you do it? Something which is oriented high up, you rotate it downward and get a better definition of the nasal tip itself. Now, obviously, pediatric rhinoplasty is out of the purview because it is not aesthetic or of any concern for the aesthetic purpose. But nevertheless, what I just want to reiterate is, if you have a septal deflection or a deviation, better to batten it rather than resect it to get a better tip in the future. This is what we need to think about. The future is what we are looking at, and build it so that it can be a better tip. Now, just another point that many of your patients might tell you, that in the profile view, that their columella is either hanging down or their ala is too lifted up. So the ratio, as mentioned earlier, is a 2 to 4 millimeter columella show up from the alar line, or sometimes you can have an alar retraction. So you need to identify it, and this is just an immediate post-op photo on how, I'm sorry about this darkening here, the light hasn't shined enough. So she had a hanging columella which she want corrected, and this was in the immediate post-op. She's yet to come for a long follow-ups. Now, just coming to the last few points on the tip. Recently, the definitions have changed on a lot of preservation rhinoplasty going along, and structural rhinoplasty has its own significance, but the preservation guys are talking about ligaments and how to handle them. So they're talking about superficial smash layer, deep smash layer. Yes, they have a lot of significance because they tend to be a dynamic concept. They need to be made correctly or into position. So the important ligaments that you can remember is the scroll ligament and the superficial smash and the deep smash layers. The interdermal ligament is also of significance. The septocolumnar fibrous attachments is something that you can recreate once you open it. Now, this is another schematic diagram to show this. Now, what can be actually done once you split this layer is, you can get the tissues back again, put it down to the cartilages to get the definition back. These are popularized by the European concepts. Now, this is just an example to show you. Many of the patients in South India have this problem. Depressor septa is quite active, and when they smile, the tip droops down. And this is something that we need to handle to get it better. So this is apart from the ligaments. This is a muscle which is quite active, and that we will have to trim it down to allow them not to get this. So the complaint that the patient gives you is, my nasal tip drops down and my lip is hardly visible. So that is something that you can correct.
Sorry,
so this
Dr.
is
Vishwas, last 2 minutes, please.
I'm done. Last slide. Yeah. So this is just about the ligament, which is a deep smash ligament. You can take a suture on this and get it down way back to the place where it was, and that will create a better supra tip and reduce the polyp. Just a last point on the ratio. This was what I was telling about, the tip defining points, the tip diamond, which has to be got back, and the alar base and the tip defining points to be ratio of 60 to the alar base. This is an example of a patient who underwent because of a tip asymmetry, and he got a tongue in groove technique, a shield graft, a tip graft, to be able to give that alar base which is equal in length to the width of the eye itself. So this in brief is all about the nasal tip. I hope I've just touched upon the philosophies of the nasal tip that we usually encounter in our daily practice. Thank you for a patient listening.
Thank you, sir. Since we are running behind schedule, we won't be able to do the question answer session. Those who would like to speak to Dr. Vishwas can connect to him personally. Now we'll just felicitate the speakers.
Yes, ma'am. Thank you so much, ma'am, for chairing this wonderful session for us. I would please request you to felicitate our speakers. Can I please request Dr. Swagata ma'am to come and felicitate our chairpersons?
Association of Rhinoplasty Surgeons of India. He's trained under world-renowned Professor Gubish. He's also honored with the first Wolfgang Gubish Gold Medal by the Rhinoplasty Surgeons of India. So it's our honor to have you as a moderator for the session.
Thank you very much.
The first.
Hello. Yeah, so I would like to introduce the panelist. First, starting with Dr. Sunil Tawar. So he is a senior ENT surgeon practicing in Jaipur and is the director of Jaipur Durmeen Hospital.
Our international faculty, Dr. Sandeep Pouncer. He's a consultant nasal and facial plastic surgeon and the former head of department at St. Bartholomew's and the Royal London Hospitals. Sir is the medical director of the Symmetry Clinic, a private practice in London's well-known Harley Street. He's been trained in London, the United Kingdom. He was awarded a fellowship of the European Academy of Facial Plastic Surgery and has spent his time in Amsterdam, Toronto, and Boston working with leading international surgeons, learning various aspects of reconstructive and aesthetic facial plastic surgery. Sir, it's our honor in India to have you.
Next, I would like to introduce Dr. Gajanan Kashid. So he is the director and chief surgeon at the Gajanan Hospital Advanced Endoscopic ENT Surgery Center at Ahmednagar. And he was the AOI Indian Governing Body member during the duration of 19 and 20.
Our next panelist, Dr. Jyotsna Jagtap. She's working as director and consultant ENT surgeon at the Dr. Jyotsna Jagtap's ENT Hospital, Thane, Mumbai. Ma'am's also a visiting rhinoplasty surgeon at the Sion Hospital and the Jagjeevan Ram Railway Hospital, Mumbai. She's the past president of AOI Thane, and she has received her training in rhinoplasty at the Marine Hospital, Stuttgart, under the guidance of Professor Gubish.
Then I would like to introduce Dr. Vikas Kulkarni. He is a senior ENT surgeon, currently practicing in Islampur. And he is presently working as an associate professor in ENT at Krishna Institute of Medical Sciences, Karad. And he is also trained under Dr. Gubish. And we are happy to have you, sir.
Our next panelist, Dr. Aditya Yuelekar. Sir has received the International Young Doctor Award at the Asian IRA SPARS in Dubai in 2014. He was a fellow at Professor Gubish in 2016 in Germany. He's also received for his work in rhinoplasty, the Dr. G. Gananath Research Award at Aoicon 2017. He's also contributed a chapter in a book in contemporary rhinoplasty.
I would like to introduce Dr. Mitul Bhatt. He is practicing in Mumbai and is the director of Dr. Bhatt's Advanced ENT Center and is an honorary assistant professor at St. A.G. Bay Municipal ENT Hospital, Fort, Mumbai. And he's also trained with the world-renowned Professor Dr. Gubish.
Our last panelist today, Dr. Ashima Saxena. She's done a post-graduation and senior residency from the Maulana Azad Medical College, New Delhi. And currently, she's doing a private practice at the Sri Ashwini Saxena Hospital, Reveri, Haryana. Thank you so much, and over to you, Kshitij.
Okay, so after a good dose of rhinoplasty, we have a lot of masters who are actually doing rhinoplasty, and we'll find the finer nuances and try to extract maximum from our esteemed faculty. As we all know, in a sculptor, the shape is already inside the stone, and it's an artist who can disclose it. This was by Michelangelo. The goals of the surgery are the first, a good function. The nose should be in harmony with overall facial characteristics. It should be a beautiful nose, and it should yield a non-surgical appearance. But rhinoplasty is considered to be an operation with high risk, primarily because of limited predictability of the aesthetic long-term results. And this is owing to the dynamics of healing. A perfect result immediately after the surgery may be totally different a year later. As we all know that the septum surgery does affect the midline alignment, profile line, tip support, ala-columella relationship, and the nostril control. An exact straight septal framework is more important for breathing and also for aesthetic purposes. But errors and complications in rhinoplasty are unexpected, so we need to really investigate why these happen. According to literature, severely deviated noses need up to 30% revision. And why do failures happen? because of wrong surgery, wrong analysis, wrong patient, or what? And you also get to hear some news like an angry patient suits a Russian plastic surgeon, so you have to be aware about the kind of patients also. So let us learn from our masters. Let us have a good tug of war between all of them. So coming to preoperative counseling and discussion regarding the expectation and the psyche of the patient. So the first question I would like to ask Dr. Sandeep Ponsar, so how much importance you give for preoperative, how much importance and time do you generally give for preoperative counseling and discussion with the patients?
Thank you. I feel a little bit, you guys are all Wolfgang groupies, right? And I just meet. I spend an hour and a quarter with every patient.
Okay.
45 minutes on the first session, and a half an hour for a second session. And if they want me to see me third time, I'll see them third. If they want me to see me a fourth time, I don't operate on them. Because then that's just, these are really difficult patients.
Difficult patients.
I think spend enough time with them, and on the first visit, we examine, go through the operation with them in detail. I do digital imaging with them.
Okay.
And then the second one, I spend half an hour talking through the risks and complications, and then we give them a 14-page consent form. I think there's nothing like talking to the patients. I talked about it this morning. If you don't counsel them properly, you're going to have unhappy patients.
Okay, so so this was from London. So let's go to Mumbai. Dr. Josna, madam, what kind of patients do you face in your day-to-day practice? What are the difficulties in counseling the patients? What are the expectations that you generally would like to avoid those patients?
Actually, we do get patients. So expectations, if you ask, usually patient comes with the expectations. So we need to speak with the patients. As I said, we need to give a lot of time speaking with the patients. Sometimes patient do come with some photographs of some actors or the leaders whom they want a nose like that. So we need to discuss with them, and the same nose may not suit the patient itself. So that point we need to clear out. And the second thing, sometimes they come taking their selfie. So that is also important. Even in that time, we need to take proper pictures of the patient and discuss what are the angles or the deformities that needs to be corrected, because the selfie pictures would be
generally
different.
give you a fisheye appearance because the angles, because you never see your face like this. So for seeing your face like this, the angle has to be a fisheye. So you have to tell them that this is not how you actually look.
Yes.
So so this was about Mumbai, and if we come down to a tier 3 city, Dr. Vikas Kulkarni sir, what are the problems that you face in counseling? If you come down to a smaller city.
The best patients are the crooked nose patients or the saddle nose patients. Because here you are very sure that you are...
Patients with deformity, you want to say.
Yeah, deformity, it is definitely going to improve post-operatively. Number one. Another thing which I encounter, because we take a lot of clinical photographs and patient witnesses it, even the relatives witness it, and they demand for the photographs. The pre-operative as well as post-operative. But I straight away refuse to give it because I say this is my intellectual property and these are clinical photographs. If you want your photographs, you go to any photo studio and get it.
Okay.
I show them, but I never give them.
Okay, so basically, patients with deformities are better patients to deal with. Patient coming up to you, especially alone, male patients coming alone to your OPD, multiple consultations, they are the ones who are difficult patients. So you have to be aware of these kind of patients. Patients coming to you with photographs of actors and actresses, so you have to be careful regarding these patients.
I want to add on one more thing. During preoperative analysis, we always focus on the patient, always. But one thing, the important, then always towards the clinical side, that you always focus the comfort zone of the surgeon also. If the patient is in your comfort zone in pre-operative analysis, so then you do that case, because if your result is good, then definitely you boost up your confidence. But in comfort zone, if you find that the patient is not in your comfort zone, then you try to avoid it.
So
in
yeah.
pre-operative analysis.
Completely agreed, because this
And
is what.
yes,
Yeah,
another
Sandeep
important
said.
thing, I saw in lot of, especially my Indian colleagues, I saw a lot of photographs in the various groups, but I think no one have the uniform photographs. Your documentation, that should be proper. We focus always in pre-operative analysis on the patient.
I think we are deviating from the topic.
Yeah.
I'll be coming to that.
Can I add?
So,
Can I add one
yeah.
point? Yeah. So, dangerous patients, as Dr. Kshitij mentioned, is the young male patient coming alone. So it always has to be accompanied with one relative or the parent. That is preferable. Second thing is, sometimes patients have a single point complaint on their nose. So you make it a point to tell the patient to look into the mirror, note down exactly what all deformities he can see. On photographic analysis, you point them out 2 or 3 more deformities which you as a surgeon would like to correct. And then you have to tell the patient that these are the 4 things, in my opinion, which make your nose better than what you are thinking. So your wavelength and patient's wavelength should match at the first or the second sitting itself.
Correct.
Otherwise, what you deliver later might not be liked by the patient.
I always hand him a mirror and ask him to point the deformity. So that's how you get to know the patient.
Just one last point is body dysmorphic disorder.
Yes.
So
You have
sometimes,
to-
sometimes
you
patient
have to-
come with.
So these are the patients who are like coming alone, and you have to specifically ask them that do you
Why they
really,
are doing- why they are
how
doing
many
surgery.
times in a day do you look into the mirror, and do you really think that this is the point that is holding you back in life? So this is
the
very
best
important.
patients are the patients who have seen your results either in their friends or relatives. They are convinced, and though they know what you are going to deliver and at what cost.
Absolutely. Now we need to go to the next point. So any role of endoscopy, pre-operative endoscopy, Dr. Gajanan Kashid has a good say on this. So
in each and every patient's rhinoplasty patient or breathlessness patient, we routinely do nasal endoscopy, rhinomanometry, and CTPLS.
Okay.
For documentation purpose also, and to rule out any other just like nasal polyp or adenoid tissue.
Okay, so if there's any nasal polyposis or an infection, so would you like to operate in the same sitting, or you would like to deal with
I
the?
routinely do in same sitting sinus work also and rhinoplasty.
Okay, so if it's a frank infection, if it's a sinusitis, would you still do it, or you stage it later
Before
for the later?
surgery, I give antibiotics, and if there is need of sinus surgery, I routinely do in same sitting.
So you did not have any complications?
No, up till now.
Okay, Dr. Sandeep Pond, do you do endoscopic surgery along with rhinoplasty in the same sitting?
I don't do, to be honest, I don't do much complex endoscopic sinus surgery anymore. But if I did have to, I mean, I can still fezzes, but if it's a very limited, if they've got significant polyps and stuff, I'd stage it.
Okay.
I think the risk, and it depends what you're doing with your rhinoplasty, but if you're using grafts and stuff, the risk is if you end up with an infection, you just don't want to have that problem.
Okay, anybody on the panel who would do infected?
I'd like to differ very strongly, because the sinusitis and the polyposis or CRS, chronic rhinosinusitis, are medical conditions. And what you are doing is a surgical condition. So medical condition has to be treated medically. So unless the patient is, see what happens once the CRS or sinusitis goes away, that patient will not come. The patient is coming to you because of for the nasal obstruction, and the main contributor of the nasal obstruction is the contributor and not the septum. So you have to differentiate between these two conditions. You are going for a surgery, and simultaneously you are treating the medical condition.
Absolutely, but
so
there are
medical
conditions-
condition has to be treated pre-operatively.
But sometimes maxillary sinusitis which contains pus, and also would you still do it?
You can treat it medically. See, if it is allergic fungal sinusitis, then frank debris is there. As access, then yes. You are doing it as access rhinoplasty.
No, my question is, would you do it simultaneously, or would you stage the procedure?
I limit only to MMA, middle metal antrostomy.
Okay.
I usually.
And turbinate reduction, that's it.
So I will be staging the procedure, 2 different procedures at 2 different times, usually the gap of 3 to 6 months. So
Dr. Sunil, would you do it in the same sitting, or?
It's basically depend on the extent of the disease. If you have the frank, extensive sinonasal polyposis, and I never prefer the simultaneous.
Okay.
First, I did that one. If you have the minor, like the mild maxillary sinusitis, you open the epidural enterostomy. You can do, but I try to avoid if you have extensive.
Okay, so whenever, so basically it depends upon the type of disease. If it's a polyposis kind of a disease and a limited disease, it should be best treated medically. And if it is a small disease, then you can do it simultaneously, but many surgeons still would like to stage the procedure. I think we can skip these because we have less time. Now coming to a patient like this who's a colleague, and she doesn't know what is so much wrong with her nose, but she feels that she wants to have a better nose. So what would be your take for such a patient? Dr. Vikas sir?
Frankly, what I can see is the flaring of Ella. So, Ella base excision is a must because she is a female to give her cute nose. Because that pyramidal shape you can give to nose. And again, the septal extension graft for suppurative break. And free dice cartilage for the low radix.
Okay. Dr. Sandeep Pon sir, what would you tell such a patient?
I wouldn't operate on her.
You would not operate her?
Unless she has clear and defined what she wants,
Okay.
I don't touch patients. Because the problem is, you can impose your aesthetic on a patient, but that may not be what they do. So in the sense that, I won't say I just won't operate on her, I will do imaging and everything, but if she's still not sure at the end of it what it is she really wants, I wouldn't operate on her. I wouldn't start doing ALA bases, I wouldn't start doing supratip breaks and stuff, because at the end of it, if she turns around and say, well, this is really not what I wanted at all.
Okay.
So if you're going to take these sort of patients on, I always say them, we send them pre-op information. We ask them to come with their top 3 dislikes and then additional dislikes.
Okay.
And
Dr.
then we
Ashima,
discuss
you
them.
have, Dr. Ashima, you have any experience regarding such patients?
Sir, I'd like to agree with 2 points, the one that Dr. Sunil made and the other one that Dr. Sandeep made. The first point is that you should do what you're comfortable doing. So as an early surgeon, when you're starting out, if you take gross, crooked, deformed noses
We're talking about this
No,
patient.
yeah, so about this, so I'm coming to that. So particularly in this particular patient, because she doesn't have too many defined problems, as an early surgeon who's just starting out rhinoplasty, I probably would not operate on her because she's out of my comfort zone, one, and the other is because there is no defined problem. Unless she comes and says she wants a smaller, thinner nose, then we could do an Aller-based reduction for her.
Dr. Aditya?
First of all, the problem has to be defined by the patient, as all panelists have said. Still, if you would like to go ahead, there is axis deviation, as I can see. So I would like to put a unilateral spreader graft on the right side, also with osteotomies. Tip looks okay. Also on lateral view, you can see there is a little bit of retrusion of the chin. So probably can have a chin implant or something at a later stage.
Yeah. So she was a colleague, she was really close to me. I did operate her. I suggested that she should go also for augmentation and a chin implant. So we did her surgery, we did a dorsal augmentation, we could control the tip width. I just did a little bit of tip projection and a little bit of dorsal augmentation. So she's really happy with that, and she is now, we are posting her for a second stage chin implant surgery. So it depends upon your.
But how do you know what she wanted?
Eventually
you discussed it with her,
Yes,
right?
I discussed it with her. I showed her computer stimulation also because she was a colleague, and she was convinced, and that's how we took her. That's how we did it. And we did not do anything to the ala base. We just gave a good projection, and she's very fine. Okay, now this girl feels about a marriageable age, 27 years old girl. She comes for a little bit of a breathing difficulty, but she feels that her nose is a little too big for her face, and she feels her lip is very small. So what would you do in such a case, Dr. Gajanan Kashid sir?
Nasal dorsum is broad dorsum and she needs surgery and may require extracorporeal septoplasty.
Okay, Jyotsna madam.
She has excessive columnar show also, other than the deformities mentioned by Dr. Jalan. So, yeah, I agree. Osteotomies would be required. Then the maybe either extracorporeal septoplasty modified, mostly modified extracorporeal septoplasty, and tongue-in groove technique, so as to reduce the columnar show.
Okay,
And
Doctor.
the spreadografts.
Okay, Sunil.
Her lip appears to be short
Yeah.
in the lateral view, and it is clearly because of the excessive
Hanging
columnar show.
column, yeah, it's
So
because
the
of-
moment you do the tongue in groove, the lip will look
Yeah,
better.
absolutely, absolutely. Dr. Sunil?
Really, such type of the cases, crooked nose is most complicated case. So in such type of the case, we complete change the inner framework. So if we, the most important thing during the osteotomy, the sequence of the osteotomy and which site of the osteotomy for this bone correction, bony vault correction. Other we use for mid vault correction proper, after open we decide that either unilateral or bilateral, the spread graft. And you look that the patient has some overhanging columella. So
Yes.
jo correction of this
That's-
overhanging columella, we go for the tip and groove. And good foundation, we use the septal extension graft. So maybe we need the modified tongue in groove.
Okay, Dr. Aditya?
The caudal part of the septum is sticking out too much, so probably that is the main thing that needs to be corrected. Also, the little hump on the right side, it could be bony or cartilaginous. You can just trim it off. Other than that, standard extracorporeal.
Okay, so we took her up. She did not require any extracorporeal septal reconstruction. We did a little bit of a hump reduction. We did a tongue in groove technique. We also reduced a little bit of a caudal septum.
Whether she was having excessive nasal spine also?
Yes, yes. So now you see, the moment you take this hanging columella, the lip becomes all right. And you see, she had such a big nose, but I also did a little bit of hump reduction, caudal septal resection, and a tongue in groove, a tongue in groove technique for her. So this is how she's. In this case, yes, we did a lateral crural overlay also. So this is about 3 or 4 years after the surgery. Now coming to a marriageable girl, 24 years old female, poorly defined nose, very, very broad tip and a very thick skin. So what would your approach be in such a patient, Dr. Mithun?
Yeah, so this patient has a very broad, boxy kind of a tip, and there is a little columnar retraction as well, and thick skin. So she will require a lot of tip work. She will require maybe a cephalic trimming, domal creation sutures, and for the columella, maybe a septal extension graft, and maybe a tip suspension suture also, to give her a more defined tip.
Okay, Dr. Ashima, what do you think about such a case?
For this case, we probably like to remove a lot of fibrofatty tissue in the tip area, in addition to what Dr. Saab said.
Okay, and Dr. Aditya?
So plenty of columnar retrusion can be seen. So for a strong tip support, rib cartilage, costal cartilage is required for a strong base. On top of that, you can add up many things to get a good, nice tip. One thing you have to tell the patient that you have a really thick skin. So whatever we try inside the result what we expect, you might not get that. Also skin needs to be treated either by isotretinoid or a skin specialist. But first, number one, costal cartilage. If it doesn't agree to that, then I would go to bilateral conchal cartilage.
Dr. Sandeep?
I tell her I've got a really good friend in Pune she can go and see, because this is a really difficult case to get well. I mean, I'd agree. She needs a large septal extension graft to push that columella down, or you can use a plumping graft. A plumping graft won't work. I wouldn't even bother going to the ears. If she doesn't want rib, I wouldn't operate on her. She needs rib, the strength of the rib. I talked about it earlier on today. with this sort of thick skin, unless you push that whole envelope forward, you're not going to get any definition at all. And even if you push that, it's one of these cases where 3.5 hours later, you put the skin back and you think, what the hell did I do?
Yes,
Because that
exactly.
skin, it hides everything. So you have to talk about limitations. You need strength with a rib graft, a big septal extension graft. Wider inferiorly, this is the one time I would put a wide inferiorly graft, because you want to push that columella down to get some, and then project her. Make her nose bigger to make her look better. You can't make this nose look smaller and better.
Absolutely. And the biggest problem is a dead space in the supratip area, which is very difficult to fill.
That's why I send it to you.
So we operated her, we put a very, very large septal extension graft, and then after removing the fibrofatty tissue, she had a big dead space. As he said, we thought really what we did nothing. And in that case, we use a supratip suture. So we pass a needle through the columella, and then through the point of the maximum dead space, you have to, this was after dorsal augmentation, still nothing was much visible. Dorsal augmentation, septal extension graft, a lot of tip grafts, multi-layered tip grafts, multi-layered shield grafts. And this is a supratip suture we take, and then the other end is cut and it is passed through the needle again. And then this is tied. So this will take care of the supratip dead space that is there. So you see this? So now that dead space is reduced. So she had, because of that dead space, now she had a lot of lateral flaring in the supratip area. So in such thick cases, what I generally do is I take a percutaneous suture. I pass a needle percutaneously and then take it from the other end. And then I pass another needle. And then I take a transcutaneous suture. And I keep some steri-strip in between so that there is no scarring at that point. And then it is tied very snugly. And we also did a la base and seal resection for this patient. Yeah, here I kept some cotton, I guess.
I was going to say, don't leave steri-strips. You need cotton, because otherwise that's going to, as that swelling occurs post-operatively, you'll get irregularity.
Yeah. So nowadays I'm putting silicone. Yeah. So here she was. So we did a dorsal augmentation with costal cartilage, and we did a septal extension graft.
Such a patient, there's something more that can be done, which is a supratip excision suture.
Yeah.
But again, it's
you see, I am absolutely scared of that.
Yeah, because
I do not dare to do that. I've never done it in my life.
I've just seen
but you
now
you look at this.
In fact, I would also be very reluctant.
You look at this. I gave her a very good projection, and multi-layered tip grafts, multi-layered shield grafts, and then this dead space which was there is also reduced. I also reduced her a la base, so she is pretty much happy. And I also put her on isotretinoin after the surgery. So you see this. We gave her, to make her nose sharper, we gave a dorsal augmentation, a good tip projection, and she is pretty much all right. Although this basal view is not perfect, but I think this is acceptable.
Another important thing for my junior colleague message, in such type of the thick skin patient, you never do more and more the cephalic trimming, rather than you fold their cephalic parts, so getting the more strength. Otherwise, the patient have the more chance of the LR retraction, because it's so thick patients.
I completely agree with this. You should not modify the LR cartilages at all, because if you may just burn your hands, because they may land up into what this guy has. If you do too much of cephalic trimming in thin cartilages, now this gentleman comes to me with this kind of a device which he got from Amazon, and he has to put this and only then he can sleep. So he comes to me and he's like, "Doc, can you help me?" So what do you think, Dr. Gajanan Kashid sir?
Patient had external wall collapse, so intraoperatively we should strengthen the lower lateral cartilage by adding some cartilage, is battering.
Dr. Aditya?
I do get a lot of such kind of patients, and along with strengthening of the lower lateral cartilage, I always put a LR batten graft, which goes right from the junction of the upper and lower lateral cartilage right up to the pyriform aperture to give it a strong lateral support.
Okay, so
Coming to the previous case,
Okay,
I would
so-
like to congratulate on the previous case results. One
Okay.
more point I would like to add in that, as you give a good tip projection, later sometimes you find that there is a notching at the soft triangle. So a lateral crural strut graft would always be necessary whenever you
Yeah.
are doing a good tip projection.
Okay, so for such a case, you would go for a Batten graft. Dr. Kulkarni, sir? Ala Batten graft. Now, what is your take? For
Yes,
such
certainly the spreader grafts and the lateral crural strut grafts. Both. Just to prevent.
Lateral crural strut graft, Dr. Vikas Kulkarni would go
Yes.
for lateral crural strut graft. Dr.
Yes.
Sandeep, sir?
Along with spreader.
Dr. Sandeep,
Yeah,
sir?
I mean, you'd have to examine the nose properly and nasally, see what's going on there. Sometimes that sort of collapse, and particularly when it's unilateral, it's not actually a collapse, it's actually got to do with septal deviation. It's the valving effect, so you've got to look inside the nose. But if you assume that he has got weakness, then actually one of the things, and we saw this yesterday in the live case, is the thicker the skin type,
Yeah.
the thinner the underlying cartilages are.
Yeah,
We see
absolutely.
that a lot with Afro-Caribbean patients. I do a lot of Chinese patients that have very thin cartilages, and you get it here too. So you need to strengthen that lateral wall. You need to have alar battens. And the good thing about your thick skin is it won't show. That's where I struggle is when we've got thin skin Caucasian patients who've got the same thing, and then you're struggling because you're having to tell them, what do you prefer, form or function, because it always shows.
So this gentleman had, not only he had very, very thin cartilages, they were directed towards the medial canthus. So it was also a malrotation. He had papery thin cartilages. So we did a lateral crural strut graft. We also put spreader grafts and septal extension graft. And we also did a little bit of dorsal augmentation, and then he was fine. Now, with such a big deformity, this gentleman comes to me and he says that people really tease him for his looks. So he wants a little bit of help. So, Dr. Sunil?
So basically, the patient looked at the problem regarding the bony mold and the lower overhanging, basically this columella. This patient basically need the correction of the caudal part of the septum. So after the opening, we just check if the axis part of the septum is correct, and definitely you need the tongue-in groove technique. So for correction, and obviously the classical rest of the steps for the bone correction.
Absolutely. So tongue and groove is a very well taken point. Dr. Josna, madam?
So this patient will need reduction rhinoplasty. He has.
You mean a dorsal reduction also?
Yeah.
Okay.
Yeah, especially on the right side, bony, maybe rasping would be required. And I feel at the keystone area, he will need bony and cartilaginous reduction. And for the tip, I would like to do medial as well as lateral crural sliding technique for reduction.
He has a huge nose. And
Yeah.
Dr. Saxena, what you'd like to add something?
So, it seems he has alar retraction also on the left hand side. So he
Yeah.
may require rim grafts to support.
Dr.
support
Saxena?
the alar.
Reduction rhinoplasty, in which we will try to take away a little caudal part of the septum that's projecting.
Okay, so you mean a dorsal reduction and also caudal reduction. Dr. Sandeep?
So one nice little technique here. Again, he's got a very short upper lip. So one way of actually deprojecting, because he needs a little deprojection of the nose. And there's lots of ways of deprojecting the nose. You can do lateral crural overlays, medial crural overlays. But a medial crural setback, where you actually take out the soft tissue just in front of the anterior nasal spine, really, be quite aggressive with that, and then slide those medial cruri right onto the most inferior part of the caudal septum.
So
and that will lengthen your upper lip, it will deproject, and then you could reproject as necessary. So instead of actually taking out cartilage or sliding the lateral crus, which you may want to do in a lot of, you can actually do it the other way. You can do a medial crural setback, which will then have the added benefit in him of just opening up. You could have done it in that other patient you had with a very short lip as well. But in him particularly with such an over-projected nose, that will help him, and then you can reproject it and re-rotate and use a septal extension.
So you will go for majorly for a reduction and then resection of depressor septi, you mean, or?
You'd have to resect depressor septi, you'd have all the soft tissue around that, and then set that medial crura back onto the caudal septum, thereby deprojecting
And the medial crural and the medial overlay, medial crural.
Medial crural setback. So you're not actually overlaying the cartilage, you're literally taking that cartilage and pushing the whole complex back, thereby shortening the nose.
Okay.
And then you can rotate and support with either a tongue groove or a modified tongue groove septal extension.
I think, sir, this is so over-projected rather than the classical tongue groove. If we go the tongue groove setback or just reduction some this long medial crust, that is the good option for this one.
Yeah. Dr. Vikas, sir, I would like to seek your opinion regarding this.
His
case.
concerns are, I think, the deviated tip and the Pinocchio nose.
He feels that overall he has a very large nose and a Pinocchio nose, both.
Hump, I will not rasp the hump because he is a male. Even the radix and the keystone area is fine. The only problem is with the lower third of the nose. So I will do the lateral crural sliding, septal extension graft and spreaders. And if the bony dorsum is asymmetric, then and then only osteotomies, otherwise no osteotomies.
Okay, so he was a really...
I'm not creating the open roof, so no osteotomies.
Okay. So he was a very poor guy and I wanted his photos post-op, so I operated him for a very, very less cost. I did a dorsal reduction. I did a dorsal reduction. I did a tongue in groove. I did a caudal septal resection. I also did a resection of the depressor septi. I also did medial and lateral crural overlay both together so that I could get down to this. So even after I did about 3 millimeters of the dorsal reduction, 2 to 3 millimeters of the caudal septal resection, and then a tongue in groove, and only then, and this guy still doesn't come for follow-up because when I needed him. So this was about 5-6 years back, and he never would come for follow-up because I would take photos.
It's a really good result, though. It's a beautiful result. And I said the only other advantage if you do the medial crural setback is you could have just lengthened that upper lip maybe a couple of millimeters more, but that's a beautiful result.
Okay, so
I would like to ask his opinion on excision of the foot plate and too long the medial crest is too long. The technique which you mentioned right now versus the excision of the foot plate.
Yeah, I mean, in that sort of case, what you're using is the length of the medial crura, and you're actually setting that back onto the caudal septum. So you actually need the foot plate most of the time. Although sometimes the foot plate flares in that sense, so you do have to exercise it a little bit. I'd have to show you the technique. It's called a medial crural setback as opposed to a medial crural overlay, where you're shortening it. But here you're actually using the length of that medial crus to actually help set it back as a tongue in groove, but very low down. But to do that, you have to remove, like you did, the depressor septi and actually a lot more soft tissue there as well to really help lengthen that upper lip. You could have done in fact, the other case that you showed, the young girl, was even more so because she had a tiny upper lip and she would have done really well with that.
Okay, so now coming to aging rhinoplasty. So this guy develops a breathing difficulty at this age. Till this age, he was fine. And so what would you do in such a case, Dr. Mittul?
So he has deformities of both the lower lateral cartilages.
Yeah, this is how it looked out.
So
on opening up.
Along with a strong septal support, maybe a septal extension graft, he will probably need a flip rotate of the concave alar cartilage.
Okay, so you want to, because he developed a breathing difficulty, probably also because of the aging nose, loss of ligamental supports, and also because of this internal nasal wall blockage and external collapse. So you would go for a flip rotate technique. Dr. Saxena?
you would also go. Anybody having a different opinion?
So basically, this patient have the deformity regarding the SAP and the maybe the orientation of the lateral
No,
press also.
he's not really concerned about the shape.
Yeah.
He's only come for breathing.
So basically, for correction of this concavity, we just use the lateral flip technique. Lateral
yeah,
flip
the same
technique.
thing, that
We
is what-
entirely rotate it.
Yeah, yeah. So
basically,
this
sir.
is
And
what.
if need, then lateral stud graft also for getting the more strength of this lateral nasal wall.
Okay, but after doing
and
a
good
flip-
central foundation, good central support, or septal
Okay.
extension graft.
So, oh yeah, but after in a flip rotate technique, would you still how would you put a strut graft?
No, it's depend on the after the opening of the nose. It's depend on maybe sometimes basically this is the paradoxically lateral crura deformity.
Yes,
Sometimes
absolutely.
the patient have some malposition, the cephalic malposition also. If the patient have the malposition,
No, this
then
is this is how it look like.
then we correct by the rotation basically.
Dr. Vikas,
The quality, if you see the quality of right lower alar cartilage is extremely good. But if you see the left has become weak because of gradual airflow. So instead of flip rotation, I will just do the infolding along with the stud graft.
Dr. Gajanan Kashid?
Infolding of lower lateral crura and strengthening of lower
Okay,
lateral.
and Dr. Josna, madam?
We flip rotation, mostly we flip rotation only.
Flip rotation. So I did the exact, I also did a rotational. I did a flip rotation, but after doing a flip rotation, I was still not satisfied. So I put a overlay graft on top of this. So here he was. But flip rotation is the must. So you have to do flip rotation, and still I was not satisfied. So I had to put one more graft on top of it. Okay, now coming to complications, we have 10-15 minutes left. The complications in rhinoplasty can be good, bad, and sometimes can be ugly. So just coming to some not so bad complications. This young girl comes to me for better aesthetics, and I took her up. I did a dorsal augmentation with the costal cartilage, a septal extension graft, and she's happy with overall. This is only about 3 months, and she's about to get married. Now there is some warping at the radix area, and this is one thing that she's bothered about. So when would be the best time to deal with such a deformity, Dr. Sandeep sir?
When is she getting married?
She's getting married very soon.
Soon,
yeah, in 2 months, and it's only 3 months after the surgery.
It's tricky because she's going to want to look her best for the surgery. I'd say Photoshop her photographs at the wedding and wait, because this may settle, number one.
No.
So you wanted to wait as long as possible, but there are times when, like now, where you've got this difficult problem, whether she's getting married, whether you want to just go back and just literally lift the skin and trim it again. The problem is if she's getting married in 2 months, that skin is not going to shrink down well in that point of time. You're doing
She's absolutely happy. She's only worried about
just that little bit.
just that little
Yeah,
bit.
so you could lift the skin again. You can, it's cartilage underneath there, so you could try.
So you just have to trim. You don't have to do anything else. You have to only trim that much of her.
Yeah, you just trim that down, or you could even, if you were really wanting to be fancy, you could try using a white needle, and you can scrape some of that down. You really need to feel it, how much is going on.
It's not an earthquake.
Okay. But you can, sometimes for little irregularities, I don't think it would work with this, it's quite firm. But yeah, I just probably just lift the skin and just trim that a little bit of cartilage down. Or you could use a filler and try and sort of make it look a bit better. But I think you're probably going to have to make it a bit smaller for her.
So I'm going to plan that. I'm just going to put some needle and scrape it. Dr. Sunil, what do you think is the best time to deal with such a deformity?
I think you should wait for some time.
But
It's a shallow radix, so the long, it's a shallow radix, so the nose appears the longer. But I think first wait for the sometimes, I think. That is the good.
Dr. Jyotsna, madam?
Yeah,
When would you take her?
Better to wait for some time.
Okay, so we have still not operated her again. She's absolutely fine. She's only worried about this, which we have to shave it off. Coming to post-SMR saddling, a very, very common deformity that we face after surgery.
So, what would be your take, Dr. Saxena, for such a case? Post SMR saddling. So, how would your approach be?
Take a conchal or a costal graft and do an augmentation.
So, you would do a dorsal augmentation with
A conchal or a costal graft.
conchal or costal. Dr. Mittul?
Yeah, total septal reconstruction.
You would go for a total septal reconstruction.
But with a rib graft.
Okay.
Conchal
You
may
prefer,
prove insufficient in
but
this
you
case.
would want to do a total septal reconstruction, and then you would add some dorsal augmentation to this.
Yes, maybe a small piece of DCF on top of it.
Okay, Dr. Sunil.
Yeah, it's basically classical post-septoplasty settling. When we open the nose, such type of the nose, we have some residual septum.
Absolutely.
So we use good mid-walled foundation by bilateral good spreader graft, and then after that, if the patient need, we feel that still the patient, then we augment the dorsal.
Absolutely. So this is a very common scenario. He had some amount of cartilage left inside. So we did the septal reconstruction with leftover cartilage, and then a DCF. And so this was about 10 years back. So those are old photos. Okay, now a young surgeon has she had a hump, and the young surgeon just rasped the hump. And now she has an open root deformity. He did not do anything to the septum. So it was a young surgeon who just happened to rasp the hump by close approach. So what would you do, Dr. Aditya?
So probably there is a damage to the keystone area and everything is sunken in, so you have to get it out. So by extracorporeal approach, you will have to fix bilateral spreader grafts. You will have to do 3-point fixation. You might have to take transcutaneous transosseous suture, fixing both nasal bones, upper laterals and septum together. Also make a strong L strut underneath, and might be a little bit of dorsal augmentation by free diced.
Okay. So yes, we'll open up and see what there is. But she had the entire cartilage for herself. It was just an open root deformity. So just a little bit of work and osteotomies and some free diced cartilage. She was fine. We can skip this. So yeah. So for young surgeons, such a crooked nose deformity with a huge hump, enthusiastic surgeon did a septoplasty for him, and his breathing difficulty even worsened. So on opening up, he had no cartilage at all, and this was the only amount of cartilage which was left, and that was the only amount of cartilage on the hump which actually he could not remove. So obviously he went into a saddling. So in such case, what would be your approach, Dr. Saxena?
This we would want to do a total reconstruction.
You
with the costal
would want to go for a total reconstruction with
costal graft.
with costal cartilage. Dr. Sunil?
Yeah, really, in such type of the case, basically the first important thing for correction, the sequential osteotomy for bony vault correction. And now we totally almost deficient the septum. So if we have only some residual septum, we need long piece of just like a fan shape cartilage. We create the new septum. And then we use the on both sides the baton spreader type
For
of
a long piece of cartilage, which costal cartilage you prefer?
I usually harvest the 6 costal cartilage.
You have 6 costal cartilage. You, Dr. Vikas, sir?
Actually, now it is a revision case, post SMR case, no cartilage is left. So there is
nothing.
no option than the costal cartilage. I usually harvest 7th, if needed 8th costal cartilage. 7th costal cartilage, you get width as well as tapered nose for dorsal augmentation. And in this case, dorsal augmentation is not required. But what I find, if you go for costal cartilage, the width of the cartilage, you can make it 2 mm thick, but the width of the cartilage is restricted to 5 mm. So with the 5 mm width, you cannot reconstruct the entire septum. So now what I do, I take the 2 pieces of 5 mm, I stitch them together, edge to edge. I see that they are very strong. I stitch them with the 5-0 ethylon and make it the entire septum long as well as wide. So it will be like this. So this will give him the very good anterseptum. You can do tongue in groove. You can give tip stability as well as along with the spreaders. So whatever reconstruction you want to do, you can do with the long spreaders as well as wide anterseptum.
Okay, so the take-home point was 6th is good, 7th is good, 8th is all right, and then the cartilages have more tendency to warp and they are not long enough. So we did the same thing, and this is how he is after the surgery, and he still don't seem to be very happy. So Dr. Sandeep sir, what do you think? He has no reason to be happy?
Yeah, it's a lovely result. I mean, you've straightened his dorsum, you've got rid of that saddling. He's given tip. I can't see the side view, but I'm sure he's given him a lot of. Yeah, he's got tip support. It's a great result. And you cannot do this without rib. I mean, don't even try to do it without rib.
Yeah, but he is he's a person from a village, and still he's not happy because the columella show.
Because the columella
show is not good. So it does not depend upon the city. The aesthetics would still remain the same. He's from a village and he's still not happy.
He's got an Instagram account. That's the reason why.
No. He's a field worker, but even he cannot be completely happy with the deformity. So that's how rhinoplasty is not a very simple surgery. Now, aging rhinoplasty, he has history of previous septoplasty, breathing difficulty. He has ischemic heart disease, and patient is not fit for general anesthesia. So, Dr. Gajanan Kashit?
Under local septal reconstruction.
Yeah. So even he has IHD, so you cannot even use adrenaline. You cannot use adrenaline. So, sir, Dr. Aditya?
As a young surgeon, I would not like to touch this patient. I'll refer it to a senior surgeon.
You are a senior surgeon.
I'd send him to Amazon to buy that little device which the other patient was using. That's probably the easiest.
Yes.
I don't think I could do this thing justice under local. But
Okay, so we did an excision of the skin in the radix area under local anesthesia to pull. Yeah, this is not the same patient. Actually, I don't have the intra-op photos, and he was all right after. He was not completely happy, but yeah, something is better than nothing. Osteotomy has gone wrong. Okay, we can skip that. We have less time. Now, this is my own early post-op patients, and he had a crooked nose, and he has perfect view on the front view, but on laterally, he is not happy. So what do you think is wrong, Dr. Saxena? The columella strut has sunken,
Yeah,
Dr.
the
Saxena?
tip is drooping.
Yeah.
And then there is a big deformity.
Yeah. So I think I over-resected the cartilaginous septum, and under resection of the, I over-resected the bony septum, the bony dorsum, and under resection of the cartilaginous septum and the columella strut. So this went into a polypic deformity. So, yeah, just can I ask the moderators, can I get about 5 minutes more? Okay, 15, they gave me 15. No, but this was running, this was, because, yeah, because I was given a timer of 50 minutes. So now coming to a soft tissue polypic. So this is all right, we did an augmentation, and after some time the patient develops a polypic kind of a deformity in the supratip area. So Dr. Sandeep sir, what do you do for such soft tissue polypic?
so for these patients, I counsel them ahead of time. They're going to need steroids, they're going to need taping. So the first thing you want to do is inject steroids into these patients liberally, often, and tape them, see what happens, and counsel them. I mean, I think the key to this is this sort of thick skin nose. You have to counsel them well ahead of time that they may get polypeaks, they may get soft tissue fullness, and that they're going to need multiple steroid injections. But you can treat them with isotretinoin as well, which is the other option.
Dr. Aditya, what do you do for such patients?
Till now, I have not encountered my own such a big soft tissue polyp because
This is, yeah, but they do often, they often come.
They do come, but what I usually do is from second week onwards, I'm doing this steroid injection.
Okay, so you're already giving all the patients steroid
steroid.
injection.
I
So
try to
which
prevent that.
steroid you give, when do you give, and how much do you give?
Yeah, so this triamcinolone acetate, so about 0.3 to 0.4 cc per week for three weeks. So I start in the third week, or
So you
for
start-
say around 14 day, and every week for 3 weeks.
Okay, so yeah, that's correct. So I also give all my patients the supratip injection of steroids in almost all my patients except for thin skin. But I tell them that I give them so that they at least come for follow-up for my. Sometimes I give them placebo so that at least they should come for my photographs. Okay. Yeah. So yeah, we've all witnessed absorption of rice cartilage wrapped in fascia.
Works every bit as well. We've just published, we've looked at 70 cases, and we've seen no difference between using donor and patients. So we give patients a choice, particularly females who don't want a scar.
Okay, so this was now coming to the last few cases. Okay, yeah. So extrusion of implants. So which is the worst? Nowadays, I also remove more implants than to put in. So which is the worst implant complication have you seen, Dr. Sandeep? Yeah.
I see a lot of silicone because from going from Southeast Asia, the worst, without a doubt, Medpor.
Medpor.
Medpor. The problem with Medpor, well, the advantage of Medpor is it's porous, so you get tissue ingrowth, so it's meant to feel more natural. You try taking a Medpor implant out again, it's a nightmare. It's all scarred down, very, very difficult. Silicone is easy, they just slide out of the pocket. I mean, you can do it on a local
but
anesthetic.
silicone, they also have some biofilm around it. So
They do.
when do you stage the surgery? Do you stage the surgery or you put the?
No, if I'm taking an infected silicone implant out, the problem is if you take it out, that skin, soft tissue skin, contracts. It's difficult because it all scars and it's difficult to lift it back up again. So I thoroughly wash it out. We give them post-op and pre-op antibiotics, and then we just do a rib reconstruction there and then.
So you do it in the same sitting. Dr. Vikas, sir?
Silicone extrusion is worst and it comes out somewhere near the
Vestibule, yeah.
Yeah, soft tissue or vestibule or columella. And I also usually stage. I just remove minimum 6 months, if better after 1 year.
Okay, so you would wait, Dr. Gajanan Kashir?
Wait.
I stage this surgery.
You'll stage this. Dr. Jyotsna, madam?
Yeah, if it is infected, I do stage it.
Okay, if it's not infected and if there's a biofilm?
I do it the same stage. I do at the same stage.
Okay, you'll do it at the same stage. Okay, so silicone, they generally come out a little bit more. General time is about 5 years or so. After 5 years, they start showing what they are. So now I think we are at the end of Now just this last one case. This gentleman, a young boy, came for an aesthetic surgery. A costal cartilage, dice cartilage wrapped in fascia was put, and it got infected. The surgery lasted for 7 hours. Early surgeon. It got infected, and after the infection got controlled, he came to me like this. The columella got infected, the columella scar got infected. The primary surgeon sutured, approximated the columella again. So this is what he landed with. So what would your take be on such a case, Dr. Sandeep?
Got any cartilage behind that columella?
There's nothing.
Nothing.
Nothing left. What he told was there was pus along with some sugar kind of thing which was coming out through nose. when...
So I think you have to rebuild that whole framework again with costal cartilage. The problem is, of course, that skin loss which he's got. So you'll have to think about either a full thickness skin graft or even a composite graft, depending. But if you've got no cartilage behind that, there's no advantage of using a composite graft. So I would use a rib reconstruction. You're not going to be able to close that columella, so you're going to use a full thickness skin graft. Actually, earlobe works pretty well for that. If you just take off the bottom of the earlobe, it's curved. And actually it works very nicely to close that that extra columella space that you got. It's not a great color match. He's never going to get a fantastic result, but at least you'll give him something better than what he has.
So would you like to
I have had a similar kind of a case. I had done a costal cartilage and then it got infected. Everything melted away. I had to revise the patient. So we have to prevent infection. So this being
coastal
an
cartilage has
extra
it.
mucosal operation, all small mucosal tears you have to suture meticulously. First, when you start, I always make it a point to give dilute betadine wash in the nose. Second is usually the staph is the culprit. So you religiously tell the patient to apply mupirocin ointment post-operatively. And amoxiclav is my discharge medicine for 2 weeks. Because I have burned my fingers, I don't want any more infection again.
Okay. So in this case, I did stage the surgery. I put a composite graft, but I planned it in such a way that I planned a shield graft and a skin. So to expand the columella first and then the revision surgery. So on taking, I harvested it from the posterior aspect of the concha. So I did a shield graft like this and then a skin. I sutured it and I took it off from here. And then in second stage, he had nothing left. So I had to reconstruct the septum, I had to reconstruct the lateral crust and also tip grafts. And here he is about a year after the surgery. Although this is not a perfect result, but results of rhinoplasty can be ugly. So you have to be completely thoroughly studied. You have to know all the techniques. You have to know all the possible complications, and only then you have to be completely well-read, well-prepared. You have to be assisting a senior surgeon for at least 25, 30 surgeries, and only then you should be doing your own rhinoplasty surgeries. So, as you can see here, although the dorsal and it is okay, but the columella is still missing. So this is not, so I think we can skip this. So with this, I had a lot more to discuss, but with the constraints of time, I think we'll just skip this. So there's a step ladder principle in surgery. The complications can be good, bad, and ugly. You can only step 1 or 2 steps up. So a good nose can be converted into a beautiful nose. An average nose can be converted into a good nose, but an ugly nose cannot be converted into a beautiful nose. So this is what we have learned. And only surgeons who don't operate have no complications. And the journey still continues with every one of us. And it was Michelangelo who said that I saw an angel in the marble and I carved it until I set him free. So thank you very much. The learning curve in rhinoplasty is very steep, but still you have to go on. Thank you very much all the esteemed panelists for sharing your views on different aspects, especially in Indian scenarios where you get all kind of patients, thick skin, thin skin, Caucasian kind of noses, non-Caucasian kind of noses. Thank you very much for such a wonderful interactive session. Thank you very much. And you should never give up, how much ever it is steep. Thank you, Dr. Kshitij. So it was a pleasure hearing you and the panelists over here. So we'd like to have a small, very quick question-answer session. If any of the audience has any questions from the panelists or the moderators, is free to ask fast, because we are already short. As the panelist mentioned, we'll be doing a reconstruction with a spreader graft or a batten graft to improve the nasal valve patency. So anything would you like to do to the turbinates in the sitting, or any management would include the
depends.
turbinates, inferior turbinate particularly I'm talking about?
We do a rhinomanometry for all our patients. Generally, these patients have an external nasal wall problem. So it depends if after a decongestion, if the curves are better, then we can still do it.
So was the patient satisfied after the,
Yes,
the
very
procedure
much.
what you
Very
did?
grateful patient.
So at the single sitting, you won't be addressing the turbinates unless it's really enlarged, or
Yeah, unless and until.
turbinoplasty will you go for? No.
Yeah, if it is required, we do in rhinomanometry, we do a decongestion test.
Okay.
And then you see how much difference does it make in the curves after decongestion. So if it makes a good amount of difference, then in all the patients we do turbinoplasty.
Okay, thank you.
Yeah, most welcome.
Thank you so much, sir.
Thank you very much.
Felicitate the panelists and the moderator.
Good cases.
Thank you. I request all the panelists to stay on stage so that we can have a group photo.
Dr. Shitish Patil. Dr. Ashima Saxena.
Challenging cases.
I really wanted you to stay for my lecture.
I'm so sorry. You know, we came back.
Dr. Mitul Bhatt.
We had to go to this place, and then we came back in time, and then we went to. These guys grabbed me and said, "We're just going to go for a 10-minute drink to."
Dr. Sunil Tanwar.
Rumbug Palace. Right? And then I said, "Look, I've got to be back for 2:30." And then at about 2:45, I said to I called the driver. I said, "Where are you?" He said, "I'm at the thing." It took me
Dr.
25 minutes
Aditya
to get to
Yoilekar.
It's only a 5-minute drive. The traffic is really
Dr. Vikas Kulkarni.
It's funny listening to it. It's like, what are you going to do for the family? I'm just report because you're all Wolfgang groupies, right?
You have to come to it. He's really comes.
I know.
He comes every year. Now you're
Dr. Jyotsna Jagtap.
What I'm saying. Extra report, extra report,
Yeah, Bhavika. Dr. Agrawal.
Putting up with us.
So now I would like to have a group photo of a panelist.
मैं कर दूंगा But before starting, I would like to pay tribute to my guide, Dr. Debajit Das sir, ex-HOD and professor, Department of ENT and Head and Neck Surgery, Assam Medical College, without whom I wouldn't have been here. So, introduction, access to the airways were first given by Hippocrates, and Manuel Garcia gave the major contribution during the period 1805 to 1906. Direct laryngoscope was first invented by Kirsten in 1895, standardized by Killian. Professor Siepert first used the suspension microlaryngoscopy, and Kleinschisser incorporated the Zeiss microscope to direct laryngoscope. In the recent time, Jaco, Strong, and Vaughan has used carbon dioxide lasers to the surgical microscopes. More than 50% of individuals with voice disorders have benign alterations in the vocal cord mucosa. The study is important in distinguishing them from the malignant lesions. So the aim and objective of my study was to study the clinical presentation of benign lesions and disorders, to study the outcome of the surgical approaches. Inclusion criteria of my study was all patients presenting with benign lesions originating in the larynx and all patients on whom conservative therapy had failed. Exclusion criteria where the conservative therapy was successful, patients with speech disorder due to neurological lesions and tuberculosis, patients needing external and other pressures, and patients presenting with malignant mass originating in the larynx. Duration of the study was 1 year and 3 months from the May 2015 to July 2016. It was a prospective study by pre-tested designs and performance. Patient selection was on the definite benign laryngeal disease attending the outpatient department of the ENT and admitted and were considered for the study. All patients were subjected to detailed history, general examination, and ENT examination. All patients in the study underwent the laryngeal assessment by 70-degree telescope and camera attachments. Endolaryngoscopic surgery with suspension laryngoscope was done under general anesthesia. The largest possible laryngoscope was used. 12-degree angle telescope was used with a camera attachment. Follow-up was done at 24 hours after surgical procedure, at 1 week, at 1 month, and at 3 months. So here are the results. Most of the patients in many of the studies which I went through were females, but in my study, both were equal. Chief complaint of most of the patients was disorder of voice, that means hoarseness was there. Some people also complained of cough and expectoration and foreign body sensation. Duration of symptoms started not long back. Most of them had 1 month to 6 months and 6 months to 1 year in some cases. Occupation was very interesting. It was found in most of them were housewives. Second were businessmen and teachers. And third were farmers. Vocal abuse was seen in 22 number of cases, and there was no vocal abuse in 2 cases. Here are the findings. Vocal nodule was found in 4 patients, vocal polyp in 12 patients, and rest almost single number patients. In the first picture, we can see a vocal polyp, which is in the form of fibroangioma. I'll try to show the video, which I did. It once more. This was the fibroangioma, which we tried to first give a small incision around the vocal fold and tried to get it in the piecemeal. Why piecemeal? Because, why in a single piece? Because it was a cystic field. Going back again to my slides. So here we can see that both male and females were equal in both vocal cord, vocal polyp, whatever the pathology was. So in almost all the cases, it was excision. And in one case, I had to go for injection of the fat below the sulcus. That was for the sulcus vocalis. What intraoperative complications I found was the short and muscular neck was there and the thyromental distance was 5.75 centimeter. Short neck again and macroglacia was seen in almost all the cases. Mucosal hemorrhage in oropharynx was seen in 4 cases. Mucosal hemorrhage in hypopharynx in 1 case. Mucosal hemorrhage in larynx 2 cases. Edema in epiglottis 2 cases. Edema in vocal cords 1 case. Lesions which persisted was only in the benign supraglottic lesion in 1 case, which came out to be neurolemoma. It was found that the angiomatous polyps were common in men, medium size, positioned in the middle third of the vocal fold, and more frequently associated with minimal structural alteration, while the gelatinous polyps were common in women, small sized, positioned in the posterior third of the vocal cord, and not associated with minimal structural alteration. Thus, the role of hormones in formation of vocal polyp can be evaluated. The statistical analysis which I found in the mean was voice handicap index before the surgery was 48.69 and voice handicap index after was 39.18. Standard deviation was 11.33 and 10.17 after this. P-value was 0.0003. The study was found to be extremely statistically significant. So what other study says, the percentage of cases in 41 to 50 years of age group is 45.83%, and this finding is more or less similar to the findings of the Chintapeta BK et al. Murthy et al. Again were found male predominance, and ratio was 1.5:1. Presenting complaint was almost in all the cases was hoarseness of voice followed by cough, foreign body sensation, throat pain, which was similar to my study. Ghosh et al. Found in his study that maximum incidence was among the housewives, similar to my study. Site of the lesions, Murthy et al. Again found 74% of the lesions were of the true vocal cord. Hegde et al. Found that most of the cases in their study had vocal cord polyps, similar to my study. Then surgical procedure performed by different operative procedures were in the 40 cases. Simple excision of the lesion was done in 36 cases. Stripping was done in 3 cases. And endoscopic decapitation and marsupialization was done in 1 case. Complication, Van et al. Found in his study related to the complication due to suspension laryngoscopy that 8 cases had dental injury, mucosal injuries, 12 cases, and sinus bradycardia in 10 cases. I want to make a point here that sinus bradycardia, even in my cases, I have seen in 6 cases. Out of those 24 cases, and one patient was he went to some 30 to 40 heartbeats on table. We have to give him atropine. In conclusion, I would like to say endoscopic surgery for benign laryngeal diseases is an excellent procedure with a high success rate and good outcome. Current technology with the introduction of endoscopic and imaging investigations dedicated to the larynx allow the site of disease process to be detected and to perform micro-invasive surgery respecting the anatomical structures. Thank you. Other speakers, if you want.
Okay. Sir, can I would like to request Dr. Tanmay Dev to please be the chairperson for this talk.
For her presentation.
Sorry for the delay. Thank you, chairpersons. I'm Dr. Rupali Patil Jain, and I'm an ENT surgeon as well as a medical legal consultant. Now, why is this interesting topic? Because if you are doing a lot of work in ENT, definitely you're bound to get 1 or 2 at least legal notices in your lifetime. So that's why I have chosen this topic. Now, what are the common issues which an ENT surgeon faces being a surgeon? First is the informed consent. Second is the documentation, then the OT issues, the post-op complications, delay in diagnosis, and adverse outcomes of treatment. Now, what is an informed consent? It is a landmark judgment which was given by the Supreme Court in Samira Kohli versus Dr. Prabha Manchanda, and the Supreme Court has given certain guidelines regarding how a consent form should be taken. So, the first principle is any invasive procedure the doctor is doing, he has to take the consent of the patient. Then the nature, how should be the nature of this consent? It should be a real and valid consent. That means it should be a free consent without any fraud or misrepresentation. The patient should be an adult patient. That means he must be competent to consent, and there should be lawful object and consideration. The fourth most important point is adequate information. What adequate information should be there in the consent form? Now, these 6 points the Supreme Court has given in that judgment. First is the purpose of the treatment. That is, what is the diagnosis of the patient? Why you are undergoing that particular procedure, whether it be investigative or a therapeutic. So, what is the purpose of the treatment? Then, in short, we have to write the nature of the procedure. For example, if you are doing any kind of surgery, whether you have to write even the approaches, the patient has to be told whether it's an endoscopic approach or an open approach, and you also have to mention the procedure. Any organs you are going to remove, that also you have to mention. How is the patient going to get benefited after the treatment? Whether he will be able to breathe properly after a particular nasal surgery or able to hear properly. Then fifth most important point is then outline of the substantial risks. What risks will that patient face after that particular surgery? So there, every surgery will have a different risk, so there should be a procedure-specific consent form. Sixth, again, the adverse consequences of refusing treatment. If suppose, for example, if you're doing a case of cholesteatoma, then you have to tell the patient that if he does not undergo that procedure, what all complications he might face. One, I forgot, alternatives. Like example, in a case of stapedectomy, you have to tell the patient alternative treatment of a hearing aid. So these 6 points are very, very important in each and every consent form. The third guideline which the Supreme Court has given is that if you are doing a diagnostic procedure, you cannot do a therapeutic procedure if the consent has been taken only for the diagnostic procedure. But yes, there can be a common consent form for diagnostic as well as a therapeutic procedure. If you feel that there is a need for an extra surgery, additional surgery, if you are going to remove tonsils, you might also need to remove the adenoids, then it has to be mentioned in the consent form. Or even for a tracheostomy, it should be mentioned beforehand. Sixth point is consent can be taken by your assistant doctor, provided they are able to explain all the 6 points which I have already told you before. Now timing, when should a consent form be taken? Whenever the patient he gets admitted in your hospital, try to take the consent form so that the patient gets ample time to decide whether he really wants to undergo that procedure or not. Regarding signature, according to Indian Contract Act Section 13, consent is it's a contract between the doctor and the patient. So the doctor also has to sign the consent form along with the patient and their attendants. Video consent is not mandatory. It is only mandatory for organ transplants. But yes, if you feel there is a high risk case, definitely you can take a video consent. Language of the consent form, try to take it in the patient's own language, or at least take even the attendants, if he understands, you can take it in the English language. As I already told you that the consent should be a procedure-specific consent form. There should be a different consent for every procedure. Again, there should be a different consent form for admission, for anesthesia, for surgery, and for blood transfusion. Many times we take the anesthesia consent in the same consent as surgery, but anesthesia risks and everything is different, so there has to be a separate consent form. Tracheostomy or a need for ICU, it has also to be mentioned in the consent form. If your video recording or images are to be taken, please mention it in the consent form, and do not guarantee anything in the consent form. Now the most important thing, medical records, where we all land in trouble. Poor documentation is poor defense, and good documentation is good defense. If you have not documented anything, the court thinks that you have not done that particular thing. So good documentation is very, very important. Now these documents, they can start from the prescription letter. When the patient, he enters your hospital, when you first see the patient, the prescription, whatever investigations you are advising, whatever provisional diagnosis you are writing, everything has to be mentioned in the prescription letter, because you never know. The second time the patient might go to some another ENT surgeon, there he might face some complications. The second ENT surgeon might put the blame on you. Then coming to the IPD notes, OT notes, see that all the notes, they are matching. Sometimes the anesthesia notes, the surgeon notes, and the nursing notes, they do not match with each other. This can land you in trouble. The judges think that you are playing a foul play, so all the notes should be matching with each other. The implant notes and the discharge card again is very important, and the referral and the transfer letter. All the records, they have to be kept for 5 years, IPD for 10 years, medico-legal cases till the final judgment has been made by the court, and for pediatric patients for 21 years. These are some of the guidelines for documentation. Write all the documents legibly. They should be understandable by any other doctor as well as the judge. All the notes, they should be with date and time of writing. Many times we don't write the date, and neither we write the time when we are seeing the patient. Ink should be difficult to erase. Signature should be with full name and designation. And please do not overwrite or overcorrect. You can be liable under some Indian penal codes. Do not use abbreviations. For example, if you are writing units, please write UNITS. Don't write just U. Always keep records in a safe and secure place. There are many incidences where the records have been stolen by the patient's attendants or the relatives. Medical records are confidential, they should not be shared with anyone. And if a request is made for medical records either by the patients or any other legal authorities, you have to issue the Xerox copies within 72 hours. Now coming to the operation theatre issues, the pre-op issues, peri-op as well as the post-op issues. In pre-op issues, please see that the pre-op medications, the xylocaine sensitivity, allergy to any drug, bleeding disorders or any major diseases has been noted. All the machines should be in working condition. Try to take an annual contract with the vendor so that if anything happens during surgery, they are also partially liable. Anesthesia issues, again, pre-op anesthetist checkup is a must. Always do it. Because many times in OT, instead of surgical issues, many times the patient, they land in anesthetist issues, and the pre-anesthetist checkup is not done. All the emergency medicine should be available in the OT. Identification of the patient as well as the site is important. It can land you in gross negligence if you're operating on a different site. Theatre checklist, identify all the risks which are there, and please count the sponges as well as the instruments. Before incision, again the surgeon, anesthetist and the nurse, they should confirm the identity of the patient, the site as well as the procedure. Before a patient leaves the OT, always complete the notes before the patient leaves the OT. Sometimes we tend to forget, sometimes we write some, we don't recall what has been done. There can be a mismatch again in the records. So before leaving the OT, the patient, the consent should be, the note should be completed. Count the instruments, sponges and needles. Identify the specimens and they should be properly labeled. Now, post-operative complications. Now, many surgeons, they ask me that if the patient lands in complication, are we liable? Are we negligent? So first, we will understand what is exactly medical negligence. It is an act of commission, which that means you have committed something which any other ENT surgeon would not do. For example, you are doing a laryngectomy without taking any biopsy. You are giving drugs to a patient who has known allergies to that drug. Or the patient or the ENT surgeon has omitted to do something which any other ENT surgeon would do. For example, he has given local anesthesia without doing a xylocaine sensitivity or performing surgery without doing the basic investigations. This is the difference between the civil and criminal negligence. The criminal negligence is very important because the punishment is imprisonment or fine. But very high degree of carelessness is required for criminal negligence, and no vicarious liability is applied in criminal negligence. To understand the components of a negligence, a Boehm's test has been passed. According to the Boehm's test, the doctor is it is decided whether the doctor has been negligent or not. First is whether any legal duty was existent. Second is there was a breach of legal duty. That means that a surgeon has not performed his legal duty. And third, again important, is there have been damages caused by the breach. If all these 3 points are present, then only you are considered as negligent. The following principles are followed while deciding whether the medical professional is guilty or not. The negligence it must be culpable or gross, like leaving an instrument or a sponge inside the abdomen, operating on a wrong patient or a wrong site. Then the court expects that neither a very high nor a very low degree of care is required by the law. There can be genuine differences of opinion between two ENT surgeons. And negligence cannot be attributed to a doctor as long as he has performed his duties with reasonable skill and competence. So that means if any post-op complication arises, if you have properly taken care of the patient, if you have handled it properly, or even if the death has occurred, but you have taken all the necessary measures, you are not considered negligent. So if you have committed any mistake, please try to apologize for your mistake and don't shun your responsibility. Never hide any error which might have occurred during surgery, even if you have rectified it. And study, it shows that there are more chances of litigation if you have withhold information from the patient. So if any complication arises, please explain it to the patient and what all you have done to rectify it. Fifth, what are the adverse outcomes of the treatment? The patient, they usually have unrealistic expectations of the outcome which we cannot fulfill, and there is a subsequent failure to acknowledge it. So please keep a good communication with the patient. The more time you share with the patient in your chamber, the less time you will spend with him in the court. The proper informed consent, I've already told you the 6 points. Documentation, a good documentation is very, very important. That only can save you. and do not guarantee anything to the patient. The delay in diagnosis or the misdiagnosis. Now, if you are considered liable, only the patient will, in such cases when the patient, he proves that your delay has directly harmed him or their clinical outcome. So documentation is again very necessary, and the necessary investigations pertaining to the patient's complaints, they should be documented. How to handle sudden death? First thing is, please inform the police. Once you have informed the police, it's the police duty to arrange for the post-mortem and not your duty. Disclose the sad news in a very highly polite and dignified way. If the death has occurred due to any type of drug reaction, please keep any anesthesia medicine, keep all the used vials separately, and the batch number of the medicine should be noted, because you will have to hand them over to the police for the evidence. And if death has occurred in OT, please keep all the case papers ready with you. Take care that the case papers are not manhandled. They will be needed by the police, and keep at least 3 copies of all case papers. And give only the Xerox copies to the police. The original copies have to be kept with us, because we'll have to present them later in the court. Now, what is vicarious liability? That doctor is responsible for any of his acts, like his housemen, his nursing staff, his assistants, and even subcontractors like the electrician or the caterers, which he is employing. These are the defenses available to a doctor. You should be properly registered in your medical council. Now, we have to renew every 5 years our registration, so that should be properly done. Informed consent and documentation, I've already told you. Foreseeability. Now, some of the complications, they are not foreseeable. So, if the complication is not foreseeable, you are not held liable. Contributory negligence, if you have documented, if you have given certain advices to the patient that he should not do swimming after the surgery or should not fly, so, and still he has not listened to your advice, then the patient is also negligent. Error of judgment, there are several judgments in which the Supreme Court has given judgments in favor of the doctors, because like in minor errors, you are not considered negligent. So a good communication is very, very important. Always have an empathetic attitude, and the doctor-patient relationship, it must be very healthy. So even if you amputate the wrong leg, there might be chances that the patient will not sue you. Thank you.
It was indeed a very nice presentation, but I have a question.
Yes.
In such scenarios.
Yes, I didn't put that point. In emergency cases, there is no need to take a consent.
Okay, thank you.
In emergencies. And there is another thing, it's called as therapeutic privilege, but it is very, dicey thing. Like if you're telling to a patient some diagnosis, for example, to a cancer patient, if you feel that after you tell him the patient might collapse or he might go in some shock, so you can hide some things from the patient. But again, it's very dicey. So that is, in these 2 incidences, the Supreme Court has said there is no need to take a consent. Okay.
I request Dr. Tanmay Dev to just present a memento to Dr. Rupali Patil, ma'am. Our next speaker is Dr. Ritesh Bhagavan, sir. He will be speaking on pituitary surgery beginner's perspective.
Good evening, chairpersons and delegates. Today is my talk on pituitary surgery, beginner's perspective. The outline of my talk is I'm going to introduce about the pituitary tumors, then the various approaches, the diagnostic and preoperative requisites, and the procedure, and our role as an ENT surgeon, where nowadays the four-handed transnasal, transmenudal endoscopic technique is popularized. And to see the related articles and references, and to come to a conclusion that how we can take up this field as an ENT surgeon. So you all know pituitary adenomas are slow growing. They are 10 to 15% of all intracranial neoplasms, and they produce some hormonal disturbances and compression effects. That's why they present. And radiologically, they are best diagnosed. And the most important, we are there to help these neurosurgeons to operate, providing them a wide exposure and a field. Historical perspective of this pituitary surgery is that initially in 1910, 1925, Harvey Cushing developed a sublabial transpyramidal approach with the help of an open approach, but the mortality rate was very high. So transcranial approach is now then came into the picture, where the mortality rate is little less, and a few advantage those neurosurgeons have because of immediate exposure of the tumor transcranially. Then in 1960, Jules Hardy repopularized this approach with the help of operating microscope and use of a fluoroscopy technique. In 1990, then technological improvement came where endonasal approach came. This diagram showing the speculum-based approach of a microscopic technique where the trajectory is a straight one and there is a narrow corridor. These images show that there are microscopic pictures and endoscopic sphenoidal view of the pituitary field, where there is a narrow angle and the straight trajectory is difficult to manage the bleeding and difficult to reach to the lateral recess areas. So what popularized or what purely endoscopic nowadays is a dual surgeon 400 endonasal approach, where both the nostril binostril approach is used with a 400 technique. What we can do with this endonasal approach is the access to the midline skull base, where we can tackle pituitary tumors and craniopharyngiomas. Broadly, the pituitary tumors are micro and macroadenomas. Functional tumors where they secrete the hormones like prolactinoma, growth hormone secreting causing acromegaly, then ACTH hormone secreting causing Cushing's disease. And non-functional tumors, they are non-secretory, but they mostly present with compression effects. And apoplexy is a terminology where there is a hemorrhage in the tumor. So what can be the goals of a pituitary surgery or a successful pituitary surgery? There should be a selective and complete tumor removal. We have to achieve the remission of the hormonal symptoms in cases of acromegaly, Cushing disease and prolactinoma, and we have to preserve and restore the normal pituitary and a vision. So what is the road to this success? So we are there as a captain of this surgical team, and we have to select the patient, we have to do the complete preoperative evaluation, we have to do the nasal phase of the surgery where we have to harvest the Haddad flap, that is a robust type of a nasoseptal flap. Sphenoidotomy is done by us. Then wide cellular exposure is done by us, and tumor removal and the dural part is done by a neurosurgeon. So we are there into a complete 60 to 70% part of the surgery. Only the dural part and intracranial part is done by the neurosurgeon. These are the preoperative imaging showing the tumor. This is a MRI and this is a CT scan. Visual field or perimetry is done preoperatively in all cases. Endocrine workup is done in all cases. So the diagnostic and preoperative criteria are fulfilled. So the most important thing we want is a skull-based anatomical evaluation before any case of a pituitary. The skull-based anatomical evaluation is what we have to see whether the pattern of pneumatization of a sphenoid sinus, whether it is a cellular pneumatization or a precellular or a conchal type of pneumatization. So cellular is a most preferred or most advantageous for us because it requires less drilling and more exposure. So this is an surgical dissection image which shows the imaging shows intercarotid distance, then the dehiscence of the carotid we can know in an MRI, and erosion of the cavernous sinus, or the consistency of the tumor can be evaluated preoperatively on the MRI. This is an 400 technique which we commonly go for in a pituitary case, where two surgeons are doing a case where the nasal part and the sphenoidal part is done by the ENT surgeon, and he is holding a scope in his left hand, ENT surgeon, and the neurosurgeon is operating with the both hands through the both nostrils. Mostly these require a micro set of pituitary instruments and our routine phase instruments. Surgical technique is done under general anesthesia, where hypotension is our prerequisite criteria. So these are the images we'll see to the steps of the surgery step by step. We have to first decongest the nasal cavity, we have to lateralize the inferior turbinate. Then the most important thing is to harvest a nasoseptal or Hadad flap, which is marked initially, and then the nasoseptal flap with an spinopalatal artery-based flap is harvested and it is kept into the nasopharynx. Next step is to get a wide exposure. Binostrally, we resect the middle terminates. Then we do an cavity and half technique. The posterior septectomy is done. We have to visualize the sphenoid with an owl's eye view. Then we have to wide the exposure by doing a wide sphenoidotomy with the help of a micro drill and a quadrangle handpiece with the help of a coarse diameter. Then the sella is exposed. Sella is exposed by drilling the skull base. Then the part of a neurosurgeon comes where he does take an incision over the dura in the form of either a cruciate incision or a U-shaped flap. Then he removes the tumor assisted by the ENT surgeon, and the lower part, then lateral part and the superior part till the descent of the arachnoid. The surgery is said to be near total or complete removal of the tumor when there is a absolute descent of the arachnoid part of the dura. Then we have to reconstruct this defect with the help of a fat, Surgicel and the robust Hadad flap. These patients post-operatively kept in the ICU where there is a monitoring of the neurological status. Then the most important, the diabetes insipidus can happen in such patients where there is a handling of the pituitary. So we have to keep ready with those desmopressin duct. Then there may be some chances of hematoma formation which can deteriorate your vision. So we have to monitor those, and scan is done after 24 hours. The patient is kept with higher antibiotics. These are the images showing pre and post-operative CT scan findings where the tumor is nearly completely removed. The pre-operative and post-operative perimetry findings showing the significant improvement into the vision. And our work, what we are doing is comparable with the adenoma resection rates in Pacific Neurosciences Institute, where there is they also have a near total removal of the tumor up to 90 to 95%. And those factors which limits the complete tumor removal are like sometimes the tumor may be invaded into the cavernous sinus. Sometimes there is an carotid artery is involved into the tumor, and sometimes there may be a huge tumor which is inaccessible or which is not approachable, or sometimes in a revision cases of pituitary where we get difficulty to completely remove the tumor. The probable complications are there in this pituitary surgery because of the close proximity to the important structures like the pituitary gland, which is supplied by the hypophyseal arteries, can be handled, and hypofunction can occur for a transient period or a permanent period. CSF leak can occur because of arachnoid injury. Nose bleeding, hematoma, and meningitis are complications mentioned. So this is a neuro textbook which shows that the guidelines in all the steps of the pituitary surgery where the causes of the complications and what avoidance factors can we go for those steps, each and every step of a nasal, sphenoidal or cranial or endocrinal part of it. So the outcome of transsphenoidal surgery is basically the neuro textbook reference which shows that the non-functional tumors can be completely removed. There are chances of recurrence. So it is ranging from 60 to 80%. So it is never a complete removal in cases of pituitary tumor. It is a near total removal, and there are chances of recurrence, and they are slow growing. So chances of recurrence after 10 years can be seen in this study also. Complications, they have listed like major complications and minor complications. The mortality incidence is very low in the cases of endoscopic transsphenoidal surgery. Major complications, these are like CSF leak, then intracranial hemorrhage or sinus bleeding, cavernous sinus bleeding that can be managed. And minor complications like mucocele, septal perforation or a nose bleeding. So my suggestion to those who want to enter into this field of skull-based surgery or pituitary surgery, First of all, you are the captain of the ship, so you should not panic. Be prepared to tackle and repair. The skull-base defect, obviously you are harvested and Hadar flap, you are going to repair the skull-base defect. CSF lip, you should get well versed to harvest the fat, fascia, and everything, so that you will be able to close the whatever CSF leak happened inside with the help of a tissue glue also. Management of bleeding from the sinus, it is best done by a flow seal material that we have to use timely and judiciously. This should not happen with anybody, but there can be a chances of worse scenario of a carotid artery injury. At least you should know how to manage that carotid artery bleed if accidentally it has happened. So you have to use a crushed muscle at that time of on the injured site of the carotid. Then we have to pack the nose and we have to shift the patient to an interventional radiology unit, and you have option of stenting and all. This at least you should know. So the complications mentioned in other reference studies also, they are quite high initially, but to review this literature and to have references of our work to compare with the studies shown in this Neurology India, then this study published by our own Dr. Nishit Shah, where these all techniques, they show favorable outcomes when done with an endoscopic technique and four-handed technique. So to conclude or to come to a conclusion, this four-handed endoscopic transsphenoidal endoscopic pituitary is nowadays is a popular technique with minimal invasive, we can say, and it's with less complications and a shorter hospital stay for these patients. My take-home message to those who want to take up this field as an ENT surgeon, going to become a skull-based surgeon. Ideally, they should build a very good relation with neurosurgery or neurophysician colleagues, because they have these patients, and we have to convince them for a transition from conventional microscopic to endoscopic technique. What we can promise to them, that we will provide a wide exposure, we will give an excellent visualization of the operative field. That's why the complications will be very less. And we are there to manage the complications. If at all a CSF leak happens, he is not going to do anything. We are there to repair that leak. And sometimes cavernous sinus bleed, that also we have to manage. So my suggestion is to invest in instruments and gadgets. And it's not a direct term to make them independent, because we are dependent upon them for the patients, these neurosurgery patients. But we can make them dependent because of if we have these all type of gadgets like a camera system, endoscopes, a debrider, a instrument set of face and pituitary set, a drill with a quadrangle handpiece, and a good quality bipolar gun. We should keep all these disposal items along with us: tissue glue, Surgicel, Merosil, everything. So this will become a ease for them to call us for this help of transsphenoidal surgery. So my suggestion is to don't see into this field as a financial gaining field. Just see to it as it will providing us a good hands-on skull base dissection skill to develop in and get an experience. So we have to master the nasal and sphenoidal phase. We have to go for this technique by observing lot of surgeries done by the masters, and we have to do the cadaveric dissections, we have to follow the protocols, and we have to get ourselves trained to managing such type of cases. So we have to form a team where together everyone achieves more, and we have to keep in my cases of more than 100 cases, I now keep a dream of in future using a neuronavigation or a carotid Doppler or an intraoperative MRI to give a better outcome results. These are neurosurgery colleagues to whom I work in my city, almost 10 of them, and I did more than 100 cases. And obviously, what everybody is observing or what I am today is because of these all bosses. They have shown a lot of skull-based work. I have attended a lot of surgical workshops and cadaver dissections. So my take-home idea is to follow the bosses, where we can observe these international surgeons like Professor Karao and Dr. Professor Prevedello also, and to get into this endoscopic pituitary surgery field. Thank you.
I just have a question. Like, instead of doing a posterior septectomy, can we raise the flap, mucosal flap, and then do it? There was a proposition like this. Instead of taking out the entire septum out, they raise the flap and go up to the sphenoid body, and then they say there is enough space. It's a novel technique, it seems. What is your take on it?
There is no literature which shows that patient is having some symptomatic problems because of the posterior septal defect. Actually, the posterior septal defect is going to give you more access to all the areas, and your 4 instruments are not going to interchange in between. They are going to work in all the fields. So better to go for it. And the rest of the things we are keeping it mucosalized things, so there are no chances of developing an atrophic rhinitis or a cavity getting lot of crusting after that.
So you don't believe in that?
Yeah. And in some cases, I encountered 5 revision cases in our work. So in those cases, you have to just go inside, you have to just take out the Hadad flap back, and you have to remove the tumor, and you can put the Hadad flap back. But those cases where the limited exposure initially done, it is difficult to get an access where the things are not in normal anatomical location. They are fibrosed, they are early.
Another question is, your bosses are doing by themselves. They are having another ENT colleague. I mean,
Sir, this is
you said you are holding the endoscope, and a neurosurgeon friend does the rest of the job, is it?
Yeah, sir, yeah. Because ideally or a protocol wise, this is the way that the intradural part should be done by neurosurgeons. Nowadays, if the neurosurgeon feels that you are competent enough or good enough to handle the intracranial structures.
Is there any sort of restriction on the ENT surgeon that he cannot?
Yeah, sir. Yeah. Yes, sir. Yes.
If he can repair the dural defect of CSF, rhinorrhea, and all, why can't he incise the dura and take out the tumor, like Dr. Jankiram is doing?
These all masters, they are doing by keeping a neurosurgeon beside them. They are not doing by their own.
They are not supposed to do.
No, they are not supposed to do.
Is it? Then, okay. And another point, if you don't mind, I'll just say, for the younger colleagues or maybe the students, in a PowerPoint presentation, it's better to avoid the red color. And font should be of the same size, and matter should be concise in each of the slides. For the younger colleagues, I hope you don't mind. Maybe somebody else might have made the slides. Very nice presentation. Thank you.
I would request Dr. Alpesh sir to present a memento to Dr. Ritesh sir. I would like to request
Yes. Towards your side. एक और निकाल लो.